Good morning and welcome to Bug Day. My name is Dr. Chris Christodoulou, Interim President and Chief Executive Officer of Shared Health. Today we'll begin by acknowledging that health services across Manitoba are provided in facilities located on the original lands of the First Nations, Inuit, and on the national homeland of the Red River Métis Nation. Shared Health, the Health Science Centre, and Manitoba's health authorities respect that First Nations treaties were made on these lands. We acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with our First Nations, Inuit, and Métis peoples in the spirit of reconciliation. It's my privilege and pleasure to welcome you to Manitoba's largest healthcare education event. Just before we started, we heard there's over 2,700 individuals that are joining us today, and to recognize your commitment to learning together. As an organization, Shared Health is committed to fostering a culture of learning, innovation, action, continuous improvement, and to serving our patients, families, staff, and communities with care. Shared Health is responsible for leading coordinated planning and delivery of vital health services throughout Manitoba. Our approach is grounded on the following 6 pillars: patients, families, staff, communities, performance, and accountability. Engaging with and being accountable to patients, families, communities, and staff guides everything we do. Listening and learning helps us to provide safe, compassionate, and effective care. On behalf of Shared Health, I want to thank each of you and your respective teams for joining us today. Thank you for all the important work and ongoing commitment to providing that compassionate and exemplary healthcare for the patients we are privileged to serve. The organizing committee has once again brought together a great lineup of speakers and topics for this 29th annual Bug Day. It's now my privilege and pleasure to introduce our moderator for today's proceedings. For many years, he has provided expert guidance and leadership in the area of infection prevention and control. He's a nationally recognized specialist in infectious disease. He's the Medical Director of Infection Prevention and Control for the Winnipeg Regional Health Authority, a Professor of Medicine at the University of Manitoba in the Max Rady College of Medicine, the Rady Faculty of Health Sciences, and a specialist in internal medicine and infectious diseases. He's been a driving force behind bringing in experts each year to share their knowledge at Bug Day. Please join me in welcoming Dr. John Emble. Over to you, John.
Thank you. I'm John Emble, and you heard the introduction. I'll be the moderator for today. Welcome to Bug Day 2025. As you heard, we have over 2,700 registrants, and the program will be broadcast by YouTube. So hopefully it will be a phenomenal day. We have a great lineup, but there are a number of housekeeping details. For those who registered online with the Continuing Professional Development Department, please ensure you've checked in and recorded your attendance in Slido at, so you need to go to the Slido website, you need to enter hashtag, and I think the hashtag is already there, so it's bug in capital 2025. This will allow you to download your certificate and claim credits for attending today's event. Please allow approximately 14 days for attendance to be recorded. If you require the certificate for credits and you have not registered with the Department of Continuing Professional Development, please visit the CPD website or Continuing Professional Development website now and register at www.cpd-umanitoba.com. If there's any question about doing this, just type in Bug Day 2025. You'll find a link. The link says register here. Click on the link and you're off to the races. If you don't need a certificate, then don't bother registering. Questions and feedback are critical for us as it helps us plan future events. In the past, when this program was held in person, people would complain about the room being too hot or too cold. Now, if the room is too hot or too cold, unfortunately, that's your problem, not ours. And that was a joke. For Slido, you can enter your questions, your comments, etc. For each of the speakers, please enter your questions. The questions will be sorted, and then in the 15-minute question and answer period after each session, we'll go through the questions for each of the designated speakers. We appreciate your feedback, and it's only with the feedback that we can plan next year's event. And just if you weren't paying attention, next year will be the 30th anniversary. We're hoping to have an even more phenomenal program than usual. So I'd like to take this opportunity to thank all of the individuals who've helped to make this program a success, or a reality and hopefully a success. First of all, we need to thank our speakers, without whom this program wouldn't exist. The Department of Continuing Professional Development, specifically Senia Molina, Andrea Martin, and Dr. Nurman Gerges, all of whom have been instrumental in getting this program off the ground, and of course the staff behind the scenes. We need to thank the audiovisual group at the University of Manitoba, and of course Peter Nickerson, our dean, whose support has been overwhelming, the leadership team at the Health Sciences Center and Shared Health, and of course my assistant Carolyn Garlinsky, who is always behind the scenes, making sure that everything is perfect. So this year marks the 29th year of the program, and without any further delay, we'll turn things over a little bit prematurely to Kevin Brown. Kevin will be speaking, or Kevin's presentation is entitled Alexander Fleming, A Chance Discovery That Changed Society. So Kevin is the trust activist at the Imperial College Healthcare at the National Health System Trust and curator of the Alexander Fleming Museum at St. Mary's Hospital, London. He set up the museum and is the author of Penicillin Man, Alexander Fleming and the Antibiotic Revolution. And little did Alexander Fleming know what he stumbled upon. Kevin, the floor is yours.
Thank you. Right. Let's just get the presentation up. So, can you see it? Well, I'm the archivist at St. Mary's Hospital, Paddington, and curator of the Alexander Fleming Museum. And that is my declaration that I have nothing to disclose. Now, I'm going to be talking to you about the discovery of penicillin and how it's affected the development of modern medicine. It involves, as John said, an element of chance. And we have to understand that chance events favour only the prepared mind. Louis Pasteur said it better. And then look at the role of other people. The development of penicillin was more than just Alexander Fleming. Now, it all began here at St. Mary's Hospital, Paddington. And at the right hand of the screen, you will see Fleming's lab. There's a toilet, and on the second floor, with the window with the pediment, that was Fleming's lab. Wasn't it a good idea of the architects to mark Fleming's lab out in such a way? But most people think the penicillin contaminant came through an open window. No. As those of you who are bacteriologists will know, the window would never have been open. Fleming, like all bacteriologists, wanted to work in a still atmosphere. And this was where it all happened. It could have only happened somewhere like this, Fleming's old-fashioned, low-tech, musty, bit dusty lab. After all, if there's no possibility of contamination, there would be no penicillin. Now, you can actually visit Fleming's lab here at St. Mary's and see for yourself where it all happened. And I think it's somewhere pretty special when you consider the impact penicillin has had on the lives of all of us. Some of us wouldn't be here without it. And also, penicillin was the first of the antibiotics and gave the world the concept of an antibiotic. So this was where a revolution in medicine began. And to look at it, you wouldn't think that. So, hope you'll come along. Well, what happened in there? In 1928, Alexander Fleming, Professor of Bacteriology at St Mary's Hospital Medical School and bacteriologist to the hospital, was asked to write a chapter for Medical Research Council textbook. His allocated subject will be familiar to all of you, either as a microbe or through its effects. Staphylococcus aureus. Very much the observational scientist, Fleming prepared some culture plates just in order to make some observations. He finished the work. He was about to go off on holiday. So what does he do with his petri dishes? You've got it. He left them on the lab bench. Was he lazy? Was he careless? Or was something else going on? Well, it was Fleming's usual custom to leave his petri dishes for a couple of weeks after he'd finished with them, just in case anything interesting or anything unusual might happen. More often than not, there was nothing, but there was always that chance. He came back to work on Monday, the 3rd of September, 1928, after 6 weeks' holiday. Of the day, he checked his petri dishes. Something on one of them caught his attention. That's funny. That is funny, he said. With those immortal words, he announced to the world the discovery of penicillin, or at least to the colleague who was with him at the time. Now, this is perhaps one of the best known images in the history of medicine in the 20th century. Fleming's own photograph of his petri dish. It was published in the British Journal of Experimental Pathology in 1929. And possibly the most noticeable thing to us now is at the top, that blob of mould. The petri dish had become contaminated by fungus. Well, it's noticeable now, but it didn't really interest Fleming all that much. Contamination like that was an occupational hazard in labs of those days. Fleming was interested not in what was there, but in what was not there. At the edges of the plate, you can see the colonies of staphylococci clustered together as you'd expect. However, close to the fungus, you have that classic zone of inhibition. The fungus had produced something that inhibited the growth of the bacteria. Fleming at first called that substance mould juice. Well, it's perfectly descriptive as a name, but it's hardly the most scientific. So when he came to publish his findings, he thought he needed a better name. How about, no, not mould juice, how about penicillin? Penicillin, the product of the fungus that was then classified as Penicillium notatum. It's now seen as a subspecies of Penicillium chrysogenum. And in fact, it has also been identified tentatively with Penicillium rubum. So, as knowledge of the mould increases, the whole structure changes. But its significance in this was that it produced something that stopped the growth of the bacteria. Now, people have accused Fleming of just being lucky. And yes, it was a chance contaminant of it was a chance observation. But, as I mentioned earlier, to paraphrase Pasteur, chance events favour only the prepared mind. You can have all the good luck in the world. If you're not intellectually prepared to take advantage of that, forget it. Fleming was. He was a qualified medical doctor. He's an experienced bacteriologist. Ever since childhood, on a Scottish farm, he'd been noted for being observant, a useful quality for any scientist, indeed for all of us. But also, this fitted in with other work Fleming had done. In 1921, also in the same lab, he discovered the enzyme lysozyme. And the discovery of lysozyme, when Fleming had a cold and wondered what would happen if he added some of his nasal mucus to the bacterium he was studying, Micrococcus luteus, well, he noticed that something in his mucus was dissolving or lysing the bacteria. And he was looking out for clinical potential. So he saw that this could perhaps be of some value. Well, as it happened, it wasn't, because it did not act against the most pathogenic of bacteria. But that's what got Fleming interested. He was looking for clinical potential in all his work. Well, this cartoon appeared in Punch, a popular satirical magazine, in 1922. And it shows school children queuing up to be caned and beaten to produce tear antiseptic. Well, it never happened like that. You'll be pleased to know there was no child abuse involved in the making of that cartoon. In those days, the lab technicians were known as lab boys. They could have been any age. And Fleming was paying them to have lemon juice squeezed in their eyes to make tea antiseptic and produce lysozyme he could study and isolate. The importance, though, of lysozyme is it's what got Fleming interested in penicillin. Because he was looking for clinical application in all his research, and penicillin seemed to resemble, in the petri dish, the action of the enzyme lysozyme. Could it be another enzyme with a clinical application? Well, a simple protein test soon showed him it wasn't an enzyme, but by then he was interested in it for itself. But if he wanted to use it clinically, there were difficulties. He couldn't isolate it. But the important thing is, he published his findings in 1929 and pointed out if these problems could be overcome, there was a clinical use. He was thinking largely in terms of topical use, but more significantly, he mentions the possibility of systemic use. If you like, he's got the idea of penicillin as an antibiotic. He's got the idea. He publishes the idea, but that's as far as he can take it. And the clinical development of penicillin was to be the achievement, separate from Fleming, of a research team at the University of Oxford in the early 1940s. They were attracted to penicillin for the same reason as Fleming. They just finished a research project on lysozyme. They were looking for a new research topic. Penicillin seemed the obvious next step. The difference, though, was that whereas Fleming was looking for clinical application in all his work, the Oxford team, led by Howard Florey here, when they started out, saw it purely as an academic research project. However, as they worked on penicillin, Florey, his colleague Ernst Chain here, the biochemist, and a team of other scientists, they too came to see the immense clinical potential of penicillin. And they succeeded where Fleming couldn't, because they were working as a multidisciplinary team of men and women scientists. And multidisciplinary teamwork was the key to their success and a pointer to the future, compared to Alexander Fleming, the lone researcher. But if you wanted to scale penicillin up for industrial production, a lab like the William Dunn School of Pathology, which during wartime, with the help of the penicillin girls seen here, became Britain's largest penicillin production facility, but you still needed to get industry involved. And that all took place in the context of the Second World War. You could say wartime conditions accelerated the development of penicillin, just compared to the development of the COVID vaccines. Both cases, you have a medical emergency. Everything happens much more quickly than it would otherwise. The difference, though, between 2020 and 1941, is that whereas the vaccines were based on existing knowledge and technology, with penicillin, they were working in the dark. They were using it, but they didn't know what it was. The chemical structure wasn't understood until 1945. Yet, at the United States Department of Agriculture, one of the Oxford team, Norman Heatley from Oxford, together with this gentleman, Andrew Moyer, a biochemist at the United States Northern Regional Research Laboratory for Agricultural Utilization Research, there they developed a method of production that became the basis of modern industrial production. And you could definitely say that penicillin was a byproduct of the Second World War. Now, Fleming was warning of the dangers of antibiotic resistance during the war, as early as 1943. For him, it was a strong weapon against infectious disease and should be held back in reserve for the most severe infections. It's a very modern attitude. Fleming was putting it forward 82 years ago. So, in subsequent years, as new antibiotics were developed or existing ones modified, the problem could be kicked into the future. As I need hardly say to you, the future is now. So, for those of you working in that field, your challenge is to deal with that serious problem of antibiotic resistance, AMR, which Fleming warned of 82 years ago. So I hope you'll take it up, and thank you for your attention.
Thank you very much. Don't go away. We need you for the questions
I won't.
answered. I'll turn the floor over to Melissa Wirt. Melissa will present Florence Nightingale, a pioneer in infection prevention and control. As a matter of background, Melissa is the Commercial and Operations Officer at the Florence Nightingale Museum in London, in England. She is part of an amazing team of museum professionals dedicated to bringing the story of Nightingale and her contributions across many areas to life. And Florence Nightingale touched many areas of medicine that I don't think she actually realized what her impact was going to be. And those impacts are still long lasting and continue to today, just like Alexander Fleming. So Melissa, we look forward to your presentation.
Hello, everybody, and thank you so much for having me. I hope you're seeing my screen because I can't actually see you. I can only see my slides. But I'm so happy to be here today, and thank you again for having me. As you said, I'm a representative of the Florence Nightingale Museum, and so because of that, I don't have anything to declare. But I'm really excited to be sharing a very small snippet about the mother of modern nursing, Florence Nightingale. Not only did she save countless lives by nursing soldiers at Scutari Hospital, but she was also a pioneer of evidence-based healthcare, leading to widespread changes and reforms, many of which are still of influence today. I am very aware that I only have 15 minutes, but honestly, I could spend so much time speaking about this topic. So feel free to reach out to me by email with any questions, or if you would like any additional information, please let me know. Also, many of these photos in this presentation are actually on display at the museum. So if you're ever in London, please feel free to stop by and see them in person. In order to fully understand the momentous effect that Nightingale had on these fields, I just want to give you some quick context into the world that Florence Nightingale was born into. So Florence Nightingale was born on the 12th of May, 1820. In fact, she was born only 1 year after Queen Victoria. So the two of them were actually very close in age. Her family was extremely wealthy, which afforded Nightingale a very upper-class lifestyle. She spent her time between two England estates and was heavily connected with other affluent families of the time. This wealth actually afforded Florence a very unique opportunity. Her father, William, went against common practices at the time and insisted that his two daughters receive a proper education. This included studies in languages, history, English, and Florence's favorite two subjects, maths and statistics, which would then continue on to be an important part throughout her life. Despite all of this education, and drive, Florence was still expected to conform to the very rigid lifestyle of a Victorian woman at the time. This meant attending parties, living in opulent houses, and most importantly, getting married. And actually at the bottom of the screen, you can see some of the many men who actually proposed to Florence during that time. But despite all of this, Florence, from a very young age, believed she had a true calling from God to become a nurse. This desire was heavily discouraged and honestly caused a lot of confusion within the family as a whole as to why Florence would ever want to do this. And now with the modern context, you may be asking, why was Florence's family so opposed to this? And that's because at this time in history, nursing was not seen as an honorable profession. To be a nurse usually meant you were either a religious person, like a nun, being more intent on the spiritual aspects as opposed to the healing of the body, or you were a very low class or poor individual, which led to some of the stereotyping that nurses were actually all drunks and lazy, and many of the times usually mean. So you can see why Florence Nightingale's family did their best to sway her from this path. Even going so far as to fund her traveling around the world to try to distract her from this calling. But thankfully, all these endeavors failed, and Florence ended up training a mere 4 months at Kaiserwerth Institute in Germany as a nurse. Her first job was on Harley Street in London at the Institute of the Care of Sick Gentlewomen, where she quickly developed managerial skills that she would utilize in the next step of her life and her career. And this next step really was the Crimean War, which is arguably the most well-known time period of the Florence Nightingale story, even though it only lasted about 2 years. When Nightingale and the team of nurses she hand-selected landed at Scutari Hospital, they were first met with fierce opposition from both patients as well as doctors. Before this point, the British government had never sent nurses into an area of war. The nurses faced large amounts of skepticism and sexism, and it was believed that most of them would just get in the way. The fact is, upon arrival, many of the doctors refused to let these women nurse at all. And there is one account of an individual doctor even trying to trick the women back onto the boat to get them to go back to England. But Florence and her nurses persisted. I just want to paint you a quick picture of the hospital at their time of arrival. The building itself had been built on an overflowing sewer, so there was waste actually seeping through the floor. There were no fresh bandages, so doctors were reusing bloody and infected bandages. The soldiers themselves were sleeping on the floor because there were no beds. And on top of all this, there was no fresh water because currently there was a horse carcass located in the water well. So these are the conditions that the women are faced with. And Nightingale decides that if she can't nurse, she's going to at least clean this place up. And she gets to work scrubbing, creating airflow, making new bandages, and building beds. And yes, she also got the horse out of the well. At this point in time, germ theory was not yet popularized. So the common theory was something called miasma theory, which is sort of the idea that bad smells are what make you sick. While we now know that this is not what the cause is, it did allow the nurses to do the right thing, although for the wrong reasons. Within 2 weeks of Florence and her nurses being on site, the fatality rate had already dropped by so much that the doctors had no choice but to accept Nightingale's and her nurses and allow them to do the job that they originally came for.
Melissa, sorry to interrupt. It's Chris Christodoulou here.
Yes.
We get reports that individuals can see your slides. So can you advance them as you're going through it? Is there a way?
Oh, they can. Oh, sorry. Can they see them now? I'm so sorry.
You've just advanced to the Crimean War, the lady with the lamp. That's the slide we're seeing right now. But I think upon completion, if you could please advance it just manually for now.
Okay, that's fine. Yes.
Thank you so much.
Sorry. I'm so sorry about that. Sorry about that. So she was basically able to then start her nursing. Nightingale used this time as an opportunity to make nursing into a true profession. It was at this point that she was ready to, she really pushed for personalized and individual. It was during this time that she really started to push for personalized and individual care. She was she made sure that her nurses sat with the soldiers and talked to them. She helped them to write letters home to their loved ones. And she actually instituted the system that if a patient was scared or if they were dying, that a nurse always had to be beside them throughout it all. She truly believed in the importance of what we would now consider mental health, thinking that the people who really wanted to get better and had a desire to go on often had better chances at recovery. She even saw that animals could aid in this recovery practice as well. For instance, Jimmy the tortoise was gifted to the patients by Florence Nightingale to serve as a ward pet to boost morale and aid in the recovery of soldiers. Nightingale became a much-loved person at the hospital, earning her iconic nickname, the Lady with the Lamp, due to her care and compassion of the soldiers there. And by the end of the war, she was not just running Scutari Hospital, but also helping run all hospitals in that area as well. And I can't do a presentation on Florence Nightingale without showcasing her famous lamp, which can be seen at the bottom of the screen here. This is what we call a fanus, or a Turkish-style lamp, and it would have been used by Florence in Scutari Hospital. While not widely discussed, Florence Nightingale's story does not end at the Crimean War. Upon her return to England, Nightingale utilized the data she collected and the knowledge she acquired to make real and lasting changes within the medical field. I want to start firstly with how she created outlets for this information to be easily shared and understood. In her lifetime, Nightingale wrote over 15,000 campaign letters and 200 books. However, she was very aware that not that many people who could enact real change, especially those who were in government official capacities, would not actually take the time to read these works. Using her longstanding love for statistics and numbers, she got to creating diagrams for an easy to understand way of showcasing her findings. The most famous of these is the coxcomb diagram, which I've actually put on the top of the slide here. This diagram showcases the causes of mortality during the Crimean War and poignantly shows the direct deaths related to battle were only a small section of the overall number of deaths during the Crimean War. The highest cause was actually that of preventable diseases. She used these charts as evidence to fight for better practices, like higher number of nurse to patient ratios, better cleaning practices, and an emphasis on the mental health and patient well-being within recovery. The charts were so influential and respected that they actually allowed for Florence Nightingale to be the first woman to join the Royal Statistical Society. To this day, she has the highest number of nomination signatures to get into the society. While 4 are all you need to join, Florence Nightingale herself received 11. However, if you actually look closely at her nomination entry, you will see that the pre-written form referring to Florence has her written as he and him, because the society at the time believed that there could never be another woman who would make as many influential statistical contributions as Florence herself. Florence realized that the use of evidence-based healthcare practices could only be utilized if the nurses were there to do this work. After returning to England, a fund was created to collect money to gift to Nightingale for all of her hard work during the war. Nightingale refused this money and instead asked for it to be used in creating a nurse training school. The school allowed nurses a formal education and a training process that offered a chance for employment in a time when marriage and religious life were the only options for women. The Nightingale Training School itself was a large part of Nightingale's lasting legacy, with the school being located in Gassiot House within the St. Thomas Hospital, which is actually where our museum is located today, and it remained there until the mid-90s. The program continues to live on as part of the King's College nursing program, and to this day inspires and educates current and future medical professionals. Nightingale lived until 90 years old, which during this time was considered quite a feat, but she used those years to inspire and carve a profession that to this day and age is one of the most respected. She inspired medical professionals to really analyze observations and numbers and use those to enact real change. Her methods saved countless lives and decreased fatality rates greatly. To this day, we're still learning from her works, and I'm really hoping that her story continues to serve as an inspiration to so many within this field. Thank you for your time and allowing me to speak here today. Here's some information about the museum, including my contact information. And just a real quick shout out, our newest temporary exhibition, which is actually opening in November, is entitled Healing Spaces, and it will be showcasing how modern day nurses are actually influencing architecture and hospital design, just like Nightingale herself. So if you're interested in those areas as well, please visit our website. Thank you.
Thank you very much. That was phenomenal. I'd now like to welcome Todd Hatchett to the virtual podium. Todd will present to us about Neisseria gonorrhoeae, basically a cross-Canada checkup. Todd is a medical microbiologist and infectious disease physician. He's the head and Service Chief of the Division of Microbiology in the Department of Pathology and Laboratory Medicine at Dalhousie University with Nova Scotia Health. So, Todd, the podium is yours. But
Sorry, just having trouble unmuting there for a second. Just confirming everyone can see my slides.
Perfectly.
Excellent, thanks. Thank you to the organizers, and thank you, John, for the introduction, and thanks for being so kind to reorganize the schedule a little bit to allow me to present earlier in the day. Let's see if we can advance there. So I have a few disclosures. Again, we'll flip this up just so that you can see that I do receive research funding from various government and industry, as well as been involved with all kinds of other ad boards and governmental organizations. So at the end of the session, hopefully you'll be able to describe the epidemiology of GC in Canada. We'll describe the resistance patterns of GC and then provide some recommendations of the new PHAC guidelines for treatment, newish being in the last year or so. So gonorrhea is caused by bacteria, Neisseria gonorrhea. It is a gram-negative diplococci. You can see it here on the slide. Within pus cells, the pus cells like to eat the bacteria. So this is one of the classic presentations. If you took a sample of pus from someone's urethra or cervix, as you can see there, generally we would look at this as a pretty much confirmatory for urethritis. But because of other Neisseria species that can live in the vagina, a gram stain is not necessarily confirmatory. But this is how people would present. They basically have pus dripping out of their genitals. But in addition to the penis or those with a vagina, you can also have gonorrhea and other STIs in other sites, throat, rectum. It can also be in the eye, and in the case of gonorrhea, you can get disseminated infection where it can slip into the bloodstream and infect joints and present with cutaneous lesions. So gonorrhea has multiple manifestations that our physicians need to be aware of. In Canada, it is the second most common bacterial STI. Chlamydia is by far the most common STI that we can see. And you can see that the rates have indeed increased. So this is some data from PHAC. And for those who see PHAC data, you know that they're always a little bit behind publishing their surveillance data, but you can see that gonorrhea continues to increase. There was a dip during the pandemic, probably reflecting more access to primary care rather than rates decreasing. But you can see that the rates have increased significantly over the last decade or so. And where gonorrhea is more prevalent depends on where you are in the country. So you can see in the side of the slide there with the Canadian geographic, the most prevalent areas that have highest rates of gonorrhea would be in the Northern Territories and in the Western states. There are lots of other places in Canada that have gonorrhea, but you can see the rates are particularly high in our northern remote communities, which is important when you're thinking about who requires screening for this infection. Similarly, if you want to think about the gender distribution, gonorrhea is highest in males, but it is also prominent in females, and the age distribution is slightly different, where it's more common in women or females aged 15 to 29 and males aged 20 to 30. The biggest issue with gonorrhea, of course, is that resistance is becoming a problem. It is one of the CDC's urgent level threats of drug-resistant bacteria. There have been cases of multi-drug resistant gonorrhea strains in North America, and it is the one thing that we worry about the most because we can go back to the pre-war era when penicillin didn't exist and there really was no treatment for gonorrhea, which would not be a good thing. Antibiotic resistance to, or gonorrhea's resistance to the various antibiotics is dictated by a number of different mechanisms, and this slide just illustrates some of them. So the macrolides and spectinomycin can be resistant based on mutations within the ribosomal RNA, as is tetracycline. Of course, fluoroquinolones become resistant through resistant changes, mutations in GyrA and PARC. And then beta-lactamase resistance has been around for a long time and is often plasmid mediated, but you can also have changes in the penicillin binding proteins or the porins that allow cephalosporins to come in, which leads to increasing resistance to these beta-lactams. And in fact, it's the sort of acquisition of mutations within the penicillin binding proteins that we often see decreased susceptibility to cephalosporins. So there are multiple mechanisms that the organism has to generate resistance. In Canada, and again, this is some data from PHAC that was published in 2022, you can see that the proportion of isolates that are resistant to tetracycline and cipro are very high, 50 to 60%. So we're not going to talk about it today, but there is post-exposure prophylaxis, which is a new method that people will provide doxycycline within 72 hours of unprotected sex to reduce the risk of acquiring infections like syphilis, chlamydia, and gonorrhea. But you can see with the given resistance rates to tetracyclines, the effectiveness of this initiative is going to be less for gonorrhea compared to the others. The ones that traditionally in our PHAC guidelines, prior to the new ones that have been published, we recommended ceftriaxone 250 milligrams IM times 1 plus azithromycin. You can see now that azithromycin exceeds the 5% threshold, which is sort of the WHO threshold that they talk about for empiric therapy. And in many different regions of the country, azithromycin resistance can be actually quite higher. Out east here, it's about 20% over the last little while. The more concerning resistance, of course, is to our cephalosporins. You can see the bottom line there, the orange and the blue. There is still very little resistance to ceftriaxone and cefixime, but it is one that we will look for quite readily. So we look for decreased susceptibility in those, but at the moment, they remain low. The challenge, of course, is that the vast majority of people who get tested for gonorrhea and chlamydia use molecular methods. So we have NAT tests of various companies that offer our ability to look for the molecular fingerprint of gonorrhea in these specimens. But because we don't culture anymore, getting direct susceptibility data is a challenge. So PHAC has worked hard to develop molecular testing for looking for resistance. Some of it is easier than others. So for azithromycin and quinolones, as mentioned, you can look for specific mutations within the ribosomal proteins or JARE and PARC in the case of quinolones. But with the beta-lactams, it becomes a bit more challenging, and you have to look for presence of changes within the penicillin binding protein, which really gives you an idea of whether or not they have resistance or decreased susceptibility to those. So you can see on this graph here, the number of isolates that are submitted by culture has continued to decrease as we've transitioned to NATs, and basically most of the gonorrhea and chlamydia cases that we see are identified through nucleic acid amplification tests. This table here gives you an interpretation of the different mutations that people will look for decreased susceptibility to the cephalosporins or resistance to cipro and azithromycin, and I've provided the breakpoints as well, or the MIC ranges that you would correlate to this. And it correlates fairly well with the culture data. So this is where people are moving because we just don't get as much culture as possible. Although we do still recommend that we encourage culture when possible for surveillance. So what is multi-drug resistant gonorrhea? Well, it's here, but extended drug resistance is still very uncommon. The two cases that I threw up earlier from Massachusetts were extended drug resistance, or basically had decreased susceptibility to all of the current recommended antibiotics, and we do see some multi-drug resistance. So multi-drug resistance, the definition is you've got decreased susceptibility to one of the currently recommended therapies, which is the cephalosporin or azithromycin, plus resistance to two other antimicrobials. If you look at all of the cultures or all the isolates that we see come through the lab, there will be some that actually are quite susceptible, but you can't predict that at real time, so you're left with empiric therapy based on the chance that something is going to become more resistant. You can see that multi-drug resistance hovers around 8 to 10%, but we haven't seen any extensive drug resistance to gonorrhea. There was a recent case report from Quebec where there was a failure to the currently recommended 500 milligrams of ceftriaxone treatment, but it was still susceptible to azithromycin. So it would still fit within that multi-drug resistant GC rather than an extensive drug resistant GC. So how do we diagnose and treat this infection? Well, the National Advisory Committee on STBBIs, of which I am a member, came out with new guidelines for screening. We now suggest that screening should be done universally for anyone under the age of 30 every year, that anyone who is sexually active, and that there should be increased opportunities to screen in individuals with multiple partners or new partners. And the committee has suggested every 3 to 6 months, depending on how frequently new partners are acquired for that individual. Now, of course, I showed you the prevalence of GC is different in different areas of the country, but there are also certain groups that are at higher risk for GC. And these higher risk groups or high prevalence communities, the National Advisory Committee suggests an opt-out screening program where you could screen as frequently as 3 months given the prevalence of the infection in these communities. And these would be in people who identify as gay or bisexual men who have sex with men, those living with HIV, those who are experiencing incarceration, having issues with substance use, and some indigenous communities. As I showed you epidemiologically, in the West and in our northern remote isolated communities, gonorrhea is and in our highest sort of prevalent areas. So we talked about genital testing. What about extragenital testing? The guidelines in the CDC, for example, recommend extragenital testing for men who have sex with men, but you know, as a clinician who works in the STI clinic, we offer testing of any site that somebody uses for sex. And that's because extragenital testing does pick up more infections. This is a nice study that looked at chlamydia and gonorrhea infections, not only in people who identified as gay and bisexual men who have sex with men, but men who have sex with women and women themselves. And you can see that, for sure, people who identify as gay or bisexual men who have sex with men, there are more non-genital infections. In fact, if you did not measure or test the throat or rectal regions, you would miss a significant number of infections. In fact, only 16% of this population had genital infection. There was a combination of multiple sites, but if you did not test anorectal or pharyngeal, you would miss a significant proportion. There is less in men who have sex with women, but you can see oropharyngeal infections do occur independent of genital infections. And the same happens for women as well, where you can see both rectal and oropharyngeal infections can be independent of genital infections and the only positive site. So in general, we recommend in our clinic that we would test for any part of your body that you use for sex. But the testing of pharyngeal and rectal specimens for gonorrhea and chlamydia is actually a bit controversial, which is interesting. We've shown that you can increase the rate of detection, but this was a cool editorial in Clinical Infectious Diseases that argued whether or not there was benefit in doing so. There's lots of data in those who identify as gay and bisexual men who have sex with men. And we know that asymptomatic infections in those individuals may put them at increased risk for other STIs, particularly HIV. The comorbidities with rectal infection is clear. You can have subsequent sequelae that can lead to issues, which is one of the reasons why we screen women or people with uteruses who for chlamydia and gonorrhea, because you can lead to PID and subsequent problems with fertility. But the comorbidities with throat GC is less clear. And as I mentioned, there's no routine CDC guidelines for those who identify as heterosexual men and women. There is, interestingly, some data to suggest there's spontaneous clearance of the infection. So even if you didn't treat it, it would go away in its own. And the thought that the overtreatment of particularly throat gonorrhea is one of the reasons that you're driving resistance. So from a population perspective, there is some consideration of whether or not there's benefit to screening for these infections here. Really, if you're going to screen for them and identify them, you're going to want to treat them, but do they need to be treated is one question. Is there downsides to treating it that's driving resistance? And then there are suggested costs, which I guess if there's no really big deal of having GC in your throat, there can be stigma and labeling with the patient. They can have adverse reactions to the medications you give. And of course, the extra cost of sampling these other sites. So I think it's an interesting discussion and warrants more discussion. Personally, if I had gonorrhea in my throat, I'd want to have it be treated. And this is what we do in our clinic. But from a population perspective, I think it raises some interesting questions that we could certainly discuss further. So what about treatment? The empiric treatment choices do differ between international guidelines. You can see the WHO basically has what we used to have, which is ceftriaxone 250 plus azithromycin 1 gram. But you can see that many places have gone to ceftriaxone alone, and the dose varies between 500 to a gram or even up to 2 grams in some places. Some places continue to add azithromycin. In our country, the National Advisory Committee on STBBIs published their updated guidelines in 2023, and they recommended that ceftriaxone be used as a single dose for all uncomplicated infections. They do still say that cefixime plus azi or doxy can be used if a person doesn't have access to intramuscular medications. So if they don't, we know that there are lots of people in Canada struggle with access to a physician. They may be able to get screened other ways through virtual care. Virtual care has trouble delivering intramuscular injections. So they can call a prescription in, and cefixime at a higher dose, 800 milligrams daily with azi or doxy is an option for people who can't get IM injections. The other recommendation is that test of cure should be done in individuals with gonorrhea, again, to monitor for suspected resistance. Again, we use NAT testing now as our primary method for identifying these infections. And because NAT tests measure DNA, which can be persistent after the organism has died, the recommendation is that the NAT test should be performed 3 to 4 weeks after completion of treatment to ensure that you're not picking up residual DNA. And the literature would suggest that by 3 weeks, pretty much everybody should have cleared the DNA. So that's why we sort of give a little leeway, 3 to 4 weeks, to give some buffer zone around that to make sure that you're truly picking up persistent infection rather than somebody who may have residual nucleic acid. If someone has had a culture and is positive, you can do the test of treatment earlier. And we really do encourage culture, particularly when treatment failure is suspected. So if you have someone you've treated, they come back in for a repeat NAT test, it's still positive. Making sure that you try to culture that area is really helpful to try and identify resistant organisms that can then be fully typed. Of course, if someone has persistence of symptoms after treatment, then I think that's a reasonable thing to do for culture. If you can participate in surveillance programs, even people who've been in contact with GC, if they're asymptomatic, you can try to do the culture in addition to the NAT to try and identify organisms that we can be used in enhanced surveillance circumstances. In Nova Scotia, we are part of an enhanced surveillance program that PHAC puts off, and we're encouraging culture in these circumstances. So that is a whirlwind tour of gonorrhea. I don't know, John, do you want to go through the questions, or are those just left there for people to do on their own?
Questions are there for people to do on their own.
Okay.
Why don't we now switch gears to the questions and answers, if you've finished your session?
I have. Yep, thanks.
Thank you. So the first question is there a difference in efficacy between urine and site-specific testing, i.e. cervix for GC?
So the urine and vag, so to do test the cervix, it's much more cumbersome in that you'd have to do a speculum exam. But with swabs and particularly self-collection, you can increase the compliance and participation in trying to get tested. In fact, there's lots of data to suggest that people who do self-screening are more likely to do testing and actually therefore come up with more cases. The urine and vaginal sources, for those that have a vagina, the actual vaginal swab is slightly more sensitive than urine. In those that have penises, of course, urine is the preferred test because no one likes a swab stuck down their urethra. If you want to culture, of course, you'd want to do a urethral swab. But
so locally in Manitoba, we've seen an explosion of disseminated Neisseria gonorrhoeae. Is that just a local phenomena, or is that a national phenomena?
I think that's a great question. I don't know if there's any data on the surveillance of disseminated GC. It would be interesting to see what the typing the bacteria to see if there is a specific MSLT type that might be associated with disseminated infection, or it may reflect the lack of identifying it early on and just the natural history in some areas. I don't know what the reason behind that is.
Excellent, thank you. Next question. For individuals unable to access direct physician care, could a community pharmacist not also administer the IM ceftriaxone like they would a flu shot? That, unfortunately, is a question that I don't think any of us can answer. That is a question for the pharmacists in the audience, and what the pharmacy group are certified, permitted, and feel comfortable doing. So unfortunately, I don't think we have an answer for that one.
Well, I can say from Nova Scotia's perspective, we do. So we actually have worked with a number of our community pharmacists to have the availability of IM ceftriaxone so that people who access testing either through our mail home kits or through virtual care can actually get IM ceftriaxone at some pharmacies. It's not available in every pharmacy, and there are challenges because if you buy a box of ceftriaxone and you don't use it very often, then it's the cost benefit thing depends. But you're right, it depends on the scope of practice of pharmacists across the country, which can vary greatly.
Thank you. Now, I have a question for Kevin Brown. What happened to Fleming after this monumental discovery?
Well, he just continued as he always had been. But he was a professor of bacteriology at St. Mary's. He was planning new buildings and new departments. But what's most interesting about him after penicillin became a big news story is that he took on a new role as a world ambassador for medicine. He was actually described as the best ambassador for his own country. But in terms of medicine, this was a modest, unassuming man who began to represent the human face of medicine and science at a time when these were seen as, if you like, a bit frightening, a bit scary. After all, this is the age of the atom bomb. And also, a lot of things are seen as quite remote. And the doctor's seen as a remote, magisterial figure, godlike. And then you have Fleming, who was down-to-earth, practical Scot. And he somehow fitted in with the vibe of the time. People wanted somebody who's a bit more modest, unlike the bigger heroes of the 40s, Churchill, so on, or almost the megalomaniacs of Hitler, Stalin, Mussolini. So He was the human face of medicine and travelled around the world, giving talks, receiving honours. And I think he did enjoy all of that. So it's a very different role to that of a doctor, and a public one. And he seems to have been perfect for it, even though he's noted for being taciturn. He was a very bad lecturer, and also he was quite reticent. But somehow he did become a hero of his age. When he died, his ashes were interred at St. Paul's Cathedral, and flags all over the world were lowered. Now, it was partly for him as a person, but I think above all, it was for the impact penicillin had had. Now, I think today most people, if you mentioned an antibiotic, penicillin would be the first one to come to mind. And also, if a historical doctor, Fleming's name would be high up there. So, different life afterwards, but in a way, just as interesting a one.
Thank you. So let's go back. Someone who is a primary care provider asks, what swab am I using for anogenital swabbing? E-swab, dry swab? That's a pure Todd question. So Todd, your recommendations?
It depends on what your lab is using. So in Nova Scotia, we use the hemorrhagic Aptima system. So we have specific swabs used for those collections. So I can answer the next question as well. NAT testing is by far more sensitive than culture. So if you're screening for individuals, NAT testing is preferred, but I would suggest that anyone who wants more information on their local process, contact their regional lab that they would be sending the samples to make sure that they're using the correct swabs.
So a question for Todd, how frequently or should we be sending urine specimens, I'm just focusing on males or females, how frequently should urine specimens be sent for GC culture and antimicrobial susceptibility testing, or should that only be done in failure or in situations where there's failure of conventional treatment?
So you wouldn't culture the urine. You would actually want to culture the urethra or the site that you're swabbing, because I'm not sure that urine is going to be all that effective for picking it up. If you have part of a surveillance program, if your lab is able to process GC, again, checking with your local lab is important. You can use the swabs that they recommend. So it depends on what swabs they have. There are some swabs that are a little more protective for gonorrhea, because it's actually a pretty fragile bacteria. The best way to recover it is by direct plating at the bedside on Theramartin media and quick transport to the lab so that it doesn't die. But that is not always possible, so you use swabs that your lab would recommend.
Thank you. So, very important question. Is there a difference in efficacy between intramuscular and intravenous ceftriaxone?
I do not know the answer to that. I'm not sure anyone's looked at IV ceftriaxone compared to IM for this particular treatment. I suspect it would be similar in terms of its effectiveness. I don't know what the half-life is with IM injection versus IV. That would be the only difference in determination.
Okay, so now let's ask Melissa a question. So Florence Nightingale had an immense impact on society, nursing, medicine, etc. But what's perceived to be her greatest impact, or is there one that's perceived as the greatest impact? That's
a very good question. I guess what she is most known for is creating nursing as a profession for women originally, and then it expanded as years went on. But obviously, if you ask our museum, a lot of times we will point people towards the statistics, towards the evidence-driven healthcare as one of her major achievements. I think the reason that she has remained such an iconic figure is actually because there isn't just one thing. She is so relatable to the masses because she really had her hand in a lot of different pots, and she was able to make so much profound influence in different areas. And I think that she herself would be very surprised that we do remember her at all, because at the time of her life, she really didn't like what she called fuzz buzz. She did know that she was a very popular person. Queen Victoria wrote to her, and she wrote back. So they were pen pals, if you will. She knew that everyone knew who she was, but she didn't really like that. And I really do think that she thought that upon her death, she wouldn't be viewed in such a high light as she is still to this day. So I really think, as far as her contributions go, because she has made so many contributions, and because she was very modest about those contributions, I think that you can't just pick one. I hope that answered the question. John?
So you're right. I don't think there is any one topic that stands out. They all stand out, and they're all interconnected. So we're running out of time. Last question for Todd: How will new treatment recommendations change the definition of multi-drug resistant and extended drug resistant gonorrhea, as azithromycin is no longer a first-line option?
That's a good question. I'm not sure how that's going to affect the definition. I think that it's still considered a second line option, so I doubt it's really going to affect the definition at the moment. It is something that we continue to monitor. I'm not sure. I got a note from Philippe that in Manitoba they did have a case of XDR was resistant to everything except spectinomycin. So that's a bit on the scary side, and I suspect that we're going to see that more when we have greater amounts of travel. We tend to see these organisms pop up from contact of individuals in Asia most commonly. So I think it's just a surveillance definition that, of course, if it changes, then the rates will change.
Thank you very much. Thank you to our three speakers, Kevin, Melissa, and Todd. We'll now switch gears and focus on a collection of prominent Manitoban scientists. So the next session will include three of our colleagues. The first session will be delivered by Keith Folk, and it's entitled "The Manitoban Impact on Global Infectious Diseases Research, the Nairobi, Kenya Case." Now, Keith is a professor and head of the Department of Medical Microbiology and Infectious Diseases at the University of Manitoba. He is a viral immunologist, and his lab is focused on the human immunodeficiency virus and other viral diseases in Manitoba and Kenya for over the past 25 years. And Manitoba has a long legacy of collaboration with the Kenyans on infection with human immunodeficiency virus. So, Keith, the floor is yours.
Great. Thanks very much, John. Thanks for, as always, for organizing such a great bug day. I think my talk is going to bring together the first three talks, where we'll talk a little bit about the history of infectious diseases, but also focus on, in particular, STIs. So I have nothing to disclose. And I hope from this talk that you'll learn a little bit about the work that we've done over the last 45 years in Kenya, a little bit about HIV infection, and also a little bit about how inflammation is a risk factor for HIV. And then maybe at the end, a little bit about the sort of current politics. As John mentioned, we've been working in Nairobi for a long time, but how did a medium-sized university in Canada come to work in Nairobi? Well, it all started with an outbreak of chancroid that was identified in Winnipeg in 1977. And that was identified by Alan Ronald here, and a clinical fellow working with him, Greg Hammond, who went on to lead our provincial lab, was also working very closely with them. And they identified 135 cases. And importantly, they were the first in the world to be able to develop the media in the lab to be able to grow Haemophilus ducreyi. And so that was really the key moment, that they could grow Haemophilus ducreyi in the lab, which you see here. And then once they were able to do that, they were able to determine antibiotic sensitivities, initiate treatments based on what antibiotics worked and which ones didn't. And they were able to clear the outbreak, which was very good news. And they became global experts on Haemophilus ducreyi, but they had nothing left to study in Winnipeg. Then Alan Ronald went to a conference, a WHO conference in 1979, and he met Herbert Nzanze, who is the chair of the Department of Medical Microbiology at the University of Nairobi. And then a year later, and Herbert said, we have lots of chancroid in Nairobi. Why don't you come and study that? So Alan gets a team together, and they come from Winnipeg to Nairobi, Kenya. And the leader of that sort of on-ground team was Dr. Margaret Fast, and she was with a technician, Leslie Slaney, and another researcher, Ian McLean. And they were working at identifying bacterial STIs, primarily chancroid at the beginning, in men, in a clinic that served the needs of men. And so again, they did the same thing as they did in Winnipeg. They identified the cases, they determined antibiotic sensitivities, and then they did clinical studies to determine which drugs were the most effective. That project then expanded when Frank Plummer, he was in Nairobi in 1981, but then he came back again to live there, and he started looking at STIs in women because a lot of the men had been having contacts with female sex workers. And so he set up a study of female sex workers and identified not only Haemophilus ducreyi, but as we heard about from Todd's talk, Neisseria gonorrhea and chlamydia trachomatis were also found in that population. And they did epidemiology to identify that these female sex workers were a reservoir for STIs, and you could prevent many community cases if you treated the women. Frank also went on a few years later to work on mother-to-child health. And again, they were looking at when women were infected with gonorrhea or chlamydia, and children were being born with ophthalmia neonatorum, which can cause blindness at birth. And then they were instituting some silver nitrate drops, which in the babies as they were born, which made a dramatic impact. But perhaps the largest, and all these studies on STIs, there's hundreds of, not hundreds, but there's tens of papers all about the STI work. But perhaps their greatest known work is from studying HIV. So in 1986, at that time, HIV it had just been identified. The virus was identified that caused AIDS earlier by a couple of years, and it was mainly thought to be a gay man's disease in the United States. And someone said, well, we should test women in Africa. And initially the thought was, well, why would you do that? Because it's a North American gay man's disease. But they tested and found that 2/3 of the female sex workers were already infected with HIV. They did a lot of epidemiology studies to found that heterosexual transmission was the main route in that community, as opposed to homosexual transmission, which was at the time thought to be the main route. They also identified that these other bacterial STIs were a risk factor for HIV, and that in this cohort, they progressed to the final stages of AIDS much faster than was previously observed. Something that I was also involved in is that they did the epidemiology to show that the longer someone was involved in sex work, they were less likely to become infected with HIV, which seems counterintuitive, but I'll get back into that a little bit later. They also developed public health programs for preventing HIV, and identified that between $8 and $12 US is what it would cost to prevent a case of HIV. And just to give you a sense for what was happening in the 80s and 90s, this is the life expectancy of people living in Africa. So this is age from 35 years to 65 years, and then timeline from 1950 to 2000s. So from 1950 to 1990, all of these gains in life expectancies were from vaccines, were from clean water, other public health measures. But then HIV hit, and people started dying. And it's this dramatic decrease in life expectancy that was solely due to HIV. So in order to try and prevent that, there's a number of approaches that can be taken. One is a more public health approach, and Elizabeth Ngugi was a physician and nurse who worked with Frank Plummer, and she identified working with the community as a very important part of the equation, and developing peer educators, women from the community that could go out and talk to their peers about using condoms and other things. Another important development was Stephen Moses from the University of Manitoba conducted a trial of male circumcision. So the male foreskin has lots of dendritic cells that HIV uses to get into the body. And they did a study showing that in an area of high HIV, where they were not practicing traditional circumcision, if circumcision was introduced, it had a 60% protective effect. And this was seen as a major breakthrough at the time. There's also Joanne Embry with Frank did a number of studies looking at mother-to-child transmission of HIV and how to prevent that. And they identified that breast milk was one way that HIV was transmitted, but only initially after a few months after birth. After some time, it was then safe to breastfeed again. And they identified that the children were being born with immunodeficiencies, which made them at risk for getting infections such as measles. So my own work was involved in looking at people who were exposed to HIV but not infected. So this is a study we did where we studied people who were initially HIV negative in the sex worker cohort. And by 2 years, about 50% of them seroconverted and became HIV infected. However, you can see out here, after a decade later, and now after 20 and 30 years, you see that some individuals, although highly exposed to HIV on a daily basis, they never get infected. And so that spawned a lot of research. And my colleagues, Blake Ball, Joshua Kimani, and Rupert Call, and I all studied and identified that these HIV-exposed, uninfected women had cytotoxic T cells that killed HIV. There was a genetic basis for resistance, and they're also linked to immune quiescence. So just a review for you that in order for HIV to infect, it requires two main things, which is a replication competent virus that expresses GP120 and a susceptible cell that expresses CCR5 and CD4, CCR5, CD4, and CXCR4. Two of those, one of those two co-receptors is required. And interestingly, cells come in different activation states. So a resting state is, a resting cell is actually 1,000 times less likely to be infected than a cell that is activated. And this is sort of a cartoon of the female genital tract. So this would be the vaginal vault here, and then this is the submucosa. And whether it's because of a yeast infection, a bacterial vaginosis, or whatever, there can be inflammation in the genital tract. And if there's inflammation, a lot of these activated HIV target cells come to the area. And then when HIV is introduced, there's many, many targets for HIV to infect, and that can fuel an HIV infection. However, in these HIV-resistant women from Nairobi that we studied, we had this phenomenon of immune quiescence, where there wasn't a state of inflammation. There was very few HIV target cells. The mucosal membrane was very well intact, so HIV had a hard time getting through. And even if it did, there was less likely to cause an HIV infection. So we were wanting to study how we could move someone from a case of inflammation down to this protective case of immune quiescence. And so we studied an anti-inflammatory drug, which is aspirin, acetylsalicylic acid. And we did a study in Nairobi, and we looked at the number of genital tract HIV target cells, and then after at baseline, and then after 6 weeks of aspirin, we saw a 35% reduction of HIV target cells. And that was getting down towards the low levels of HIV target cells that we see in HIV-exposed seronegative individuals. So overall, there's been 5 generations of researchers. So we had Herbert Nzanze here, and Alan Ronald were generation 2. Frank Plummer was generation 2. They were generation 1, and then Frank was 2. I was the 3rd generation. And then people like Song Gok, Lyle, and Paul McLaren were generation 3. And then we have generation 4. And then these guys, Toby and Monica, were PhD students in my lab, and they represent generation 5. So overall, this collaboration has generated a number of top quality publications, and has trained a number of hundreds of individuals, but more importantly, it saved hundreds of thousands of lives. So the project is moving on and doing many other things, including TB, HPV, emerging pathogens. So you'll hear from Lyle next, and then Julie, but other NML scientists from the National Microbiology Lab are continuing to collaborate in this project. From my own department, we have a number of scientists that are continuing to work on there. Jason Kinderchuk, Zulma Roweda, Corby Fink. And then also importantly, we've been training Kenyans as well who have gone on to senior management positions, such as Julie Soyogi, who's a director there. So I'll just finally tell you some current news about our program. So our largest program that we conduct in Nairobi, that is the foundation for all of our research, is the Sex Worker Outreach Program. We've been running this program since 2007. There's 10 different clinics that operate all over Nairobi, and we provide services to 35,000 female sex workers, 15,000 men who have sex with men, and 1,500 transgender individuals. And we provide HIV care and for both 5,000 people, and HIV prevention services. And these clinics are very important because they're tailored for these populations, and these populations are highly vulnerable because the government considers their activities illegal. And so we need to provide a safe and secure environment for them to work in. Over the years, we've seen a decline in HIV prevalence. In the general population, it was about 10% in the late 90s, and it's gone down. More recently, it's gone down to from 10%. So there's 2,000 people on this call. 200 of us listening today, if we were Kenyans in 1990, would be HIV infected. Now that's down to about 3%. So great progress has been made, and a lot of that can be attributed to the US President's Emergency Plan for AIDS Relief, PEPFAR, which has funded a lot of HIV care and a lot of providing the money to give people living with HIV a lot of the drugs that are needed. However, when the new US administration came, they cut a lot of the funding, almost all of the funding, to fund the PEPFAR program. And this has led to female sex workers not being able to get the drugs that they need, and including men who have sex with men. So people in Kenya are really suffering now because they can't get the HIV drugs that they need. In September, we had 4 women from the sex worker community come to Winnipeg, where they met with students, learned what we do in the lab. We listened to them, and they told us about their work. And we had a lot of different meetings. And this is an article from News that came out yesterday, and focusing on how U of M is trying to counter some of these US cuts. But overall, it's been a tragic decision to cut funding for people living with HIV and their medications. So what does the future hold? We're hoping we kind of have some funding that will take us through short term, but we need to do more. And it's only by working together with our colleagues, whether it's administrators, researchers, trainees, but together is the only way that we're going to be able to have a significant impact. So overall, the Nairobi project has been going on since 1980. We're still making important impacts, and the SWAP program is important, and it's at risk right now. I'd like to thank all of those who contributed to the study. Thank you.
Thank you, Keith. So let's shift gears. Hold the questions for now. We'll do them at the end of this session. So our next speaker is Lyle McKinnon. Lyle is an associate professor in medical microbiology and infectious diseases at the University of Manitoba. His research program focuses on mucosal immunity as it relates to prevention of sexually transmitted infections. And I think Keith nicely set things up for Lyle in terms of what we hope to hear and the role of the mucosa. So thank you, Lyle.
Thanks, John. It's great to be part of Bug Day. I just wanted to do a quick shout out to my Auntie Maureen, who gave me this this cartoon on the title slide here. It's always nice to have someone who sees something about an STD and thinks of you. I have no disclosures, and the objectives for the talk are really to talk about HPV at the beginning. That'll be most of the talk, and then I'll shift gears right at the end towards gonorrhea. But we'll talk about the natural history of HPV and some of the prophylactic and therapeutic HPV vaccine concepts that are out there, and then kind of the renewed interest in vaccines against Neisseria gonorrhea. And I think the first session set up this talk really well. So one of the questions, I guess, at the beginning of the talk, which I'll come back to at the end, is natural immunity a prerequisite for the design of effective vaccines? So most vaccines that we know about that are given out in childhood or to younger people are against childhood viral illnesses that in many cases resolve naturally. So there's a sort of natural blueprint for how to make what the vaccine immunity contains of. For other infections such as HIV, TB, malaria, and others, vaccine development has been slower. And that's largely because a lot of the empirical approaches have failed, and we've had to go into rational vaccine design, which hasn't had the same success as empirical vaccine. And STIs kind of fall into this category. So many STIs subvert immunity, and HPV and gonorrhea are good examples of this. And it's long thought to impede successful vaccines. So if you don't have a really good natural model of immunity, it's more difficult to make a vaccine for these types of pathogens. So HPV and HIV were both awarded the Nobel Prize in 2008. And this was from discoveries sort of in the 1980s, not of the viruses themselves, but the fact that the viruses cause chronic illnesses. In the case of HPV, it was cervical cancer. In the case of HIV, it was AIDS. So I'll just quickly run through some comparisons of the two viruses, because there are some important differences, I think, that are worth highlighting that I think relate to the vaccine and pathogenesis questions. So in terms of HIV, it's surprisingly uncommon to get HIV if exposed, and I think Keith talked about this a little bit in his talk. So the per contact rate of HIV acquisition is really low, but if you do become infected, it's pretty much impossible. There's very few cases of natural clearance. So there are people who can live with the disease for a long, or with the virus for a long time, but usually, if untreated, it almost always leads to the development of AIDS over the course of a number of years. For HPV, in contrast, it's surprisingly easy to get HPV. So the per contact rate of HPV acquisition is in the 40 to 100% range, depending on which estimate. However, in many cases, HPV is cleared. This is controversial. So some people think that this is actually HPV control, but either way, there's the observation that people become HPV positive at a very high rate at a very young age in many contexts, and then are able to clear the virus afterwards. And not everyone who becomes HPV infected actually goes on to develop cervical cancer. It's actually a very small proportion of the overall denominator who comes in contact with HPV develops cervical cancer. In terms of the immunology, HIV elicits really vigorous immune responses. So they're limited by escape and functional impairment. In contrast, HPV is really good at sort of limiting the immune response. So the T cell responses, for example, to HPV tend to be low in magnitude, and the same thing goes for the antibody responses. And HPV also functionally impairs these responses. In terms of treatment and testing, it's relatively easy to test for these viruses, presuming, of course, that this presumes that the person is coming for testing. The testing can be quite difficult if you're talking about finding the people or people coming forward for testing. But once they're in the clinic, it's very easy to test for both of these. Treating for HIV has been a major success of the pandemic, and the regimens keep on getting better and better for treatment. For HPV, it's not really that you treat the virus, you only treat the precancerous lesions. So it's only later in the disease course that you treat HPV. And that's kind of the window that we talk about therapeutic vaccines, which I'll talk about in a second. In terms of prophylactic vaccines, for HIV, these have been nearly impossible. There's been multiple failures despite really robust attempts to test different vaccine concepts. And we all know, I think, for HPV that there is a prophylactic vaccine. So the HPV vaccine has really been a success story, has a very high efficacy, and when given to younger people prior to HPV exposure, has a high efficacy and a lot of real world success stories. So in multiple different contexts, there's been dramatic reductions in HPV disease. I just pulled this one paper from Canada showing a 45% reduction in anal genital warts and an 86% reduction in CIN from 2006 after the introduction of the vaccine in a 10-year period. However, access to this prophylactic vaccine remains low in many lower middle income countries where the burden of cervical cancer is high. And because of this, the WHO and the Gates Foundation and others have really built the rationale for where a therapeutic vaccine could fit in for both HPV and cervical cancer. And so if you think about the natural history of HPV, people become exposed and then possibly infected, and this happens quite common, as I mentioned. And this is where the prophylactic vaccine really fits in, so it prevents infection at that initial exposure. However, if a person's infected by HPV and there's persistent infection, this is where things like therapeutic vaccines or other therapeutic approaches could come in, either to facilitate the clearance that happens naturally, or to clear out the precancerous cells. And again, this slide sort of shows a progression towards CIN surgical removal, but as I mentioned, this doesn't happen in most cases. So if you look at the meta-analysis, this looked at dozens of studies from various parts of the world. The observation is that if people start with HPV, a really high proportion of them clear over a 6-month to 12-month period, and the persistence, going out to 2 or 3 years, is actually quite low. And again, this could be you're controlling the virus with an immune response, or it could be that the virus is being eliminated. And there's some controversy around that. So the really hope for therapeutic vaccine comes from this observation that the different roles of antibody and T cell responses. So if you remember your basic immunology, T cells are really important in viral immunity. They recognize infected cells and can eliminate them. And antibodies are these Y-shaped molecules secreted by B cells. And antibodies are really good at stopping viruses when they're in between cells. So a virus infects a cell, comes back out, looks for a new cell to infect, and in the interim, antibody responses can mop up this extra virus before it goes on to infect a cell. And so there's very good evidence that the prophylactic vaccine generates these neutralizing antibodies, and this is really critical for vaccine protection. There is evidence from animal models and elsewhere that it's believed that clearance of established HPV in precancer cells may require T cells. So when people talk about a therapeutic vaccine, the immunology behind it is more looking at how we can use the T cell response to try to control HPV infection. And so Keith mentioned SWAP, and in addition to being a really successful program, SWAP has been useful for us to nest research studies. And so we got some funding from the Gates Foundation to run a prospective cohort of basically looking at HPV clearance or control in female sex workers. So what we did is we screened almost 2,000, primarily women, although we included some men and trans individuals. We enrolled 701 with high-risk HPV at baseline. And the burden of disease is kind of clear from the fact that 40% of the individuals we screened at baseline had one or more high-risk HPV types. We followed the 700 individuals every 2 months for 1 year, and we amassed more than 4,000 study visits. So this was really a huge effort, and many thanks to Joshua and the entire team in Kenya, I think, that worked on this study, because it was really a big effort. We are still analyzing the data from the study, but we have about 200 participants with evidence of HPV control or clearance during the study. And so, as John mentioned, one of the things in my lab I'm really interested in is mucosal immunology. So we've been looking at some of the mucosal predictors of HPV control, and I'm going to talk about a couple of these on the next slide. And the first one is an optimal vaginal microbiota, and the second one is increased tissue-resident T cells in the cervix. So many people are probably familiar with bacterial vaginosis, or BV, and that's a condition where you have inflammatory bacteria that cause inflammation and barrier degradation. And so what we found is that women with BV were more likely to have HPV persistence, and the opposite for women with optimal vaginal microbiome. And the reason for this is likely that it gives the virus access to these basal epithelial cells that the virus likes to infect, and also it might interfere with natural clearance mechanisms. And sort of the second thing we found is that women with increased T cells, particularly these tissue-resident memory T cells in the cervix, was associated with HPV clearance. And so these are the T cells that we think of a therapeutic vaccine might need to induce. And so there's a lot of literature now on the fact that these T cells migrate to tissue and are able to make tissue-specific responses in a very long-term fashion. So they reside in tissue, they sit there waiting for pathogen to be exposed, and then they can rapidly respond to that pathogen rather than having to recruit them from distal sites in the body. And so to really understand where these T cells are in tissue, we also got funded from the Gates Foundation to do an NCIHR, to do an HPV biopsy sub-study. So this is Nani, who's a postdoc based in Nairobi. And we have a really good clinic set up now for doing cervical vaginal biopsies, which look like this. And what we really want to do in the biopsies is detect where virus is. So this pink dot here is an example of a virus-infected cell. And this was done by Fred, who's a PhD student in the lab. So we're able to look at regions of the tissue that have HPV replication going on. And then Fred's also been looking at where the T cells are in tissue. So how many T cells are they? Where are the T cells? And are the T cells in areas where the virus is replicating? So what we really want to know is, do the T cells have the right phenotype to recognize virus? And are they in the right location where they need to be to eliminate the virus? And we think that people with better clinical outcomes will have T cells that are better at getting to virus-infected cells. And so we also want to do something about this. So in parallel to doing these human cohort studies, we're also working with Thomas Maruka and people in his lab to model HPV in mice. So HPV is not a great pathogen to work with in the lab, but there's this concept of doing immunotherapy that we're testing right now with an IL-15 superagonist. And this IL-15 superagonist has been shown to induce really robust T cell and NK responses, and also to induce them in the right location, so tissue resident memory cells. So mice infected with this mouse version of HPV have really good expansion of T cells, and it's early days yet, but we're looking now to see if these T cells are able to clear virus more quickly, and it looks like that's starting to emerge at week 9 here, and also maybe from and also to prevent the development of precancer, which this mouse also develops. We're just going to quickly, for a minute or two, switch gears to gonorrhea. And I think that the reason for this is that there's some parallels with vaccine development for gonorrhea. So gonorrhea, as we heard, has a very large burden of infection. In women, it's the cause of a lot of reproductive health complications. It's very treatable, but again, in lower middle income countries, diagnostics are lacking. Infections are often asymptomatic, so syndromic management doesn't work that well. And we heard a lot about the antimicrobial problems associated with gonorrhea. From a vaccine point of view, it's another example of where reinfection is common, and most people who are infected by gonorrhea don't develop robust immunity, so they're susceptible to reinfection. So even if they do come for treatment, they can become reinfected again. So I think better control strategies are needed for gonorrhea, particularly globally. And so the hope for a gonorrhea vaccine, there's been lots of failures in the gonorrhea vaccine field, but there was this landmark study from New Zealand showing that vaccination of young people against Neisseria meningitidis provided cross protection against Neisseria gonorrhea. And of course, these bacteria are in the same genre, so that sort of makes sense. This has been replicated in many other contexts. The protection seems to be about 30 to 50%, depending on the study. And it's specific to gonorrhea, not chlamydia, so it's unlikely to be sort of an epiphenomenon. And it requires gonorrhea vaccines that contain this outer membrane vesicle. So from a vaccine point of view, that gives you some hint on where you could start looking at the cross-reactivity. And so we have a project ongoing, again, based in Kenya and also Uganda, where we want to look to see if people who had prior gonorrhea respond differently to the meningitis vaccine. We want to map out the antigenic determinants to figure out what is the cross-reactivity between the two different organisms. And then we also want to look to see if we can boost that the responses. So maybe the fact that the protection is lower than anticipated based on the sequences could be the fact that the cross-reactivity or the responses are too low. So just to conclude, there's been a lack of STBBI vaccines for many different pathogens. And you can ask the question, is this a scientific hurdle, which I think it is in some cases, but also potentially a lack of resources in others. So for HIV vaccines, we know it's not a lack of effort because there's been lots of different studies and trials, and likely it's scientific. So there's inherent properties of HIV that make it not a very good vaccine candidate, including the fact that you probably need sterilizing immunity, which most vaccines don't accomplish. For HPV, the natural history and underlying immunology tells us what's possible, but this needs to be translated. And I think in doing this study in Kenya, we've realized that there's a significant community interest, particularly among the sex workers who often know of someone who's had or died of cervical cancer in their community. And then for gonorrhea, there's this encouraging vaccine signal that needs to be amplified to achieve better protection. So I just like to thank, there's huge different teams involved in doing all this work, and I'm not going to name them all. But thanks to all of the study participants and all the different people who ran the HPV study. Thanks to the Gates Foundation and CHR for funding it. And thanks to Aida Sivro and Paul McLaren at Public Health Agency of Canada, who really helped a lot with the microbiome work and the HPV testing. And then to a number of other collaborators on these studies. And I'm happy to turn it over.
Thank you. Great presentation, great work done in Manitoba. So let's shift gears. Julie Lejoie is a laboratory scientist at the University of Manitoba, whose research program aims to understand the impact of sex hormones on the female immune system. So, Julie, the floor is yours.
Thank you. Wow. Hey. Well, the first slide, I don't have anything to declare, and thank you for having me at the Bug Day. It's been really interesting until now. So yeah, my lab mostly focused on the impact of sex hormones. So from contraception to hot flashes, why is it important to study sex hormone in the context of HIV or HPV? The learning objective for my talk is to understand the importance of involving the community in basic science, to discuss how contraception could affect susceptibility to HIV, and discuss a little bit how menopause can affect the immune response. My research program is really driven by the SWAP community, so the community that Dr. Falk and Dr. McKinnon talked prior to my talk. Really, we sit down together, we develop idea together. It's really a question that are driven by the community that we connect together with my interest, and we build a project that are a little bit more meaningful for the community. Like I always said, tomorrow I can discover the cure for cancer, but if the end user, the community don't want to use it, it's a loss of time. So it's really the idea of building a project with the community that makes it the most impactful. Why I study sex hormone? Well, we already know that there's difference between male and female susceptibility to infectious diseases. The one I'm mostly interested in is HIV. So HIV is more female are more likely to be are more susceptible to HIV versus to men. Male are more susceptible to other infectious disease. There's a list here, like you can see. When we talk about HIV, women are twice likely to be infected during vaginal intercourse versus men. And in Africa, where we work in Kenya, young women and female sex worker represent the majority of the new infection. So one of aspect in a woman's life is that a lot of us will take contraception to prevent pregnancy. And the contraception we are interested in our lab is dipomidroxyprogesterone acetate, which is called DMPA. It's a most widely used injectable contraceptive. It's used by about 42 million female worldwide. It's a progestin injection. It's injected every 3 months, so it's really convenient and also really affordable. It is less than $1 a shot, but it has been associated with potential increasing risk of HIV, SSV, and HPV infection. So the community, SWAT community, was really worried about their risk if they were taking that contraception. Birth control for them is really important, but they also don't want to increase their risk of risking to acquire HIV. So we developed a different project to look into that. The first project was to look into different group of sex worker in Nairobi, so people not taking hormonal contraception or newly involved into sex work. Some who have been involved into sex work for over 7 years, and women using DMP, and kind of compare their immune response. And when we look at the NK cells, so the NK cells are innate cells, they are not specific, they are really like our first soldier will get in there if there's an infection. We saw that people using DMPA had more activated NK cells. So their NK cell is like, oh, we are in to fight, but that also create more inflammation. And as Dr. Falk mentioned, inflammation in the case of HIV is not something we desire, because HIV will prefer to infect activated T cells. When we look at their T cells, actually what we found is that when people use DMPA, their T cells are like tired, they are exhausted. So they have more of those a marker we call LAG3. It's an exhaustion marker. And that's kind of like saying the immune response is not working well. Their cells are unable to fight properly. So for resuming that section, what we see is that DMP users have a different T-cell activation and immune profile compared to female sex worker not using DMP, which could explain in some part why using DMP with female sex worker should maybe come with a little bit more increase in education about prevention for using condoms, and really make sure that women are aware that they could potentially be at a little bit more risk of acquiring HIV. And then as a woman, you use contraception, you have a normal menstrual cycle, and something happened around 40, 45 years old, and it's the end or the menstrual cycle, or anyway, a period of chaos that appear in your life. It's called the perimenopause. It comes with a bunch of different symptoms: irregular menses, night sweat, hot flashes, weight gain, you name it, we almost all experience them. It's a decline on the estrogen and progesterone expression that we are having. That decline starts around 35 years old, but the symptom really appear more around 40, 45. In Caucasian women, the average age for perimenopause is 45 years old. It's lower for African women, where it's more around late 30s, early 40s. In general, women of color experience more severe symptoms, but it's really kind of a weird process. If you look into the clinical, like get your blood and ask your doctor to look, am I in perimenopause? Often the level of estrogen and progesterone is within range. It's really different between a month, and some women will experience the same symptom as a postmenopause woman with vaginal discomfort, vaginal atrophy, which other will not see. So there's something else that is just not just like the decline in hormone. There's something that's happening at the mucosal environment too. Unfortunately, the impact of menopause on our immune response has been really understudied. We don't know much what it means to age as a woman in terms of susceptibility to infection, in terms of what happened with our immune response. And that is especially true for key populations such as female sex workers and for women living with HIV. But worldwide, there's about 20 million living with HIV. And when we talk to SWAP, there's about 55% of the women on ART who are over 40 years old. So really understanding what happened with menopause was kind of a hot topic for them. So we talked to the community, and what the community told us is like, you know what, we have been in research, involved in different project research for many years, but then suddenly we are 40, 45 years old, and it's kind of, we are like past overdue. We are excluded of most of the research, but we want to participate in the research. And for women living with HIV, they were wondering about the side effect about their drug. Suddenly, the drug that I've been taking for a few years, I'm experiencing different side effects that I don't have. The doctor said I have undetectable viral load in my blood, but what about the female genital tract? Like, it's all weird down there. What's happening? So, and women not living with HIV were wondering, well, am I suddenly more at risk of acquiring HIV than I used to be? And so we developed a pilot study to kind of start answering some of those questions to be able to get more money to build bigger projects. And what we saw is that when we look at in the blood at women not infected with HIV or female sex worker, there's a difference in the immune response. So the premenopausal women have kind of a good balance between the Treg, which are kind of controlling everything, and those cells called Th17, who are more like inflammatory cells. While when we look into menopause women, well, they have a lot more of those activated Th17, who are inflammatory cells, and they kind of lose those regular T cells. So there's an imbalance that appears that drives inflammation. When we look at the female genital tract, we see that menopausal women actually have more of the HIV target cells, so those CD4, CCR5, CD69 T cell. And that could actually mean that as we age, we might be more susceptible to HIV infection. And while there's that context that, you know, as we age, we have less sex, female sex workers still have as much sex as they used before. So maybe targeting a little bit more prevention toward older women will be important. So in summary, our pilot studies show that menopause is associated with more activation and inflammation that could impact HIV susceptibility. And really, when you work with community as a leader, we are right now organizing some session around perimenopause and menopause to provide more information about the community, about what's happening in their next stage of their life, because we see that there's a lot of taboo and a lot of questions. So we're going to organize something with them to kind of like discuss hormones, and let's talk about hormones. And the take-home message for my my project here is really that engaging with the community, increase participation, increase adherence to follow-up, and really support meaningful design of studies. And when we study women, when we study female, it's really important to take in consideration the menstrual cycle, the type of contraception, their menopausal status, to really fully understand our data and make it significant for female to at the end improve women's health. And thank you, and we'll take questions.
Thank you very much. If we can get the Slido questions up, that would be phenomenal. I have as the Slido is coming up, I have a philosophical question for Keith. Given the decreased funding for HIV therapy, my question to you is anyone else stepping in? Is this going to be an ad hoc backfilling of missing resources? What's going to happen? What do you see in the future?
Thanks, John. Yeah, it's a very important question, and it's exactly the question that the community has been asking. The simple answer is no one has stepped up to take the place of the U.S. government. And in fact, some organizations such as the WHO and UNAIDS and others have been U.S. funded, and that funding has also been cut back. So we were looking to get support from other organizations, and they're going to be in a tight situation. The Kenyan government said that it would cover some drugs, but again, that's on the provision that the U.S. government would be funding them, and that's still not clear. So right now we've gotten a generous donation from the University of Manitoba, and we're working with philanthropy donors as well. So we think we can keep our clinics operating at a minimal level to provide HIV prevention and care services for the next few months at least. I think it's important that we at least have that for a foundation for our research, as well as for care for the people in that community. But to date, there's been no Gates Foundation or no Clinton Foundation or anything who has stepped up and said, we'll take the role of funding HIV medications throughout the world. So it's a big problem. Thank you.
So next question is, I think this is for Lyle. Thank you for your presentation. I'm wondering, based on your understanding of the HPV vaccine, if there are times when it can be provided to children under 9, for example, children who have experienced sexual assault. Great question.
Thanks, Suzanne. I'm not sure about the sexual assault part of it, but from the observation is that the vaccine works better prior to HPV exposure. So the timing of the vaccine from the recommendations is based on the likelihood that someone's not been HPV exposed yet. It's still worth taking after exposure, but it won't protect as well, and it won't protect the types where a person's been already infected. So I think like a younger person would still make good vaccine responses. You'd expect them to. So I think in that case, you could think about a HPV vaccine, but I'm not a clinician, so I'm not sure if there's a recommendation for that. But I think there's no reason why it shouldn't work.
Excellent. So I have a non-vaccine question for Lyle. Condoms serve as the ultimate barrier Or do they? Should we rely upon condoms to prevent one person's protect one person's mucosa from another?
That's great. That's a great question. I think the evidence for HIV is really good for condoms, and I think for a number of the other bacterial STIs, I don't think it's very good for HPV and for things like herpes, where there's more skin contact that can transmit those viruses. So, I mean, I think people should wear them for the pathogens where there is protection, but you can't expect protection for all pathogens.
Thank you. So a question for Julie, and it's a specific question and then a side question. Is there evidence of increased risk for women who are experiencing premature menopause? And then the side question is, how does hormone replacement therapy impact your observations?
Yeah, so for the premature menopause part, there's not much study about that. We know that people who get like their uterus and ovary removed could be a little bit at higher risk, but those are more like one-to-one base case. Like they have not really been a big, large study to look into that. Based on the preliminary data that I have, I will say that if you're premature menopause and have multiple partner, I will highly suggest to make sure you protect yourself. But like, there's not many study about that. What was the other part? Oh, the
hormone replacement therapy.
It's actually it's a big interest of mine to try to understand. I'm working with a gynecologist specialized in menopause here in Winnipeg, and her too. Like, there's basically no information. We know that when a woman starts to take topical hormonal therapy, it does improve like the epithelial barrier. It seems to be a little bit looking better, but really like a mechanism about the immune system, there's nothing known. So that's something I'm really interested into looking. Unfortunately, in Kenya, hormonal replacement is not something that is used by many women. So that's something that I'm not going to be able to really look into with Kenya. So I'm trying to see what we can do here to answer that sort of question. But it's super interesting and really important to know.
Thank you. Okay, so there was another question. There's an increased risk of inflammation and HIV with DMPA contraceptives. Do you see the risk increased with other contraceptives such as hormonal intrauterine device or oral contraceptive?
Yeah, oral contraceptive, we tried to look into that. We didn't see any difference. It was a combined oral contraceptive. With IUD, we know if the copper IUD, for example, does increase inflammation of the female genital tract. The hormonal IUD, what is the name? Levo. Well, the name is skipping my head, but does come also with change in the microbiome, which could influence the inflammation. There's not much study except for the MPA really, but I think there were a large clinical study who looked at different 3 different contraception and with risk of HIV, and now we are seeing more and more paper coming out from that study showing, oh, there's changes on inflammation, there's changes on microbiome. So I think it's something we're going to see a little bit more in the future, how really hormonal contraception does impact the immune response. Yeah, I think the other one is about increasing risk of STI and progesterone. But,
yes.
So DMPA does increase, could increase herpes and HPV. There's not much up there about what other STI with other contraception. So that's an area that's been really understudied and that they really deserve its own field. So hopefully other people will come into the dark side of hormones and start looking into more like how hormones are infecting STI risk.
Fantastic. So I have a question for Lyle and Keith, and this is an earth-shattering question. What advice would you give to your 16-year-old son who is about to head out into the world to do whatever 16-year-old boys do?
Keith, you should go for it. I have 6 years to think about it, so.
Yeah. Well, actually, we my kids are older, so they predated the school rollout of HPV vaccines, and we paid for it personally to make sure that not only our oldest daughter, but also that our boys got HPV vaccines. You know, I still think the most effective way of preventing STIs is condoms. So I've always advocated for everyone to be using condoms because it, I mean, antiretroviral therapy against HIV is great, but then you can be getting other STIs, as we saw in the talk from Dr. Hutchlet. So yeah, condoms.
Excellent. Okay. Has anyone looked at other types of oral contraceptives to see the effect of combo oral contraceptive on HIV?
There's a few groups who had looked into it, but it's often like a really small study, and it's really hard to really like have a really endpoint. When we look into susceptibility to HIV as the endpoint, you really need to design really large clinical trial. And just to look into oral contraception that I'm aware, I didn't see anything. So I cannot really answer that question.
Okay, another Julie question. Why is it that generally women of color experience more severe perimenopause symptoms than Caucasian women?
Yeah, there's a few hypotheses, but I think the main one is that women of color in general have a different microbiome at the female genital tract that is already toward more like a BV type, intermediate BV type. And with the changes in hormone, we know that this is more like it's also changed the microbiome toward a less healthy lactobacillus environment. So the hypothesis is like as you age as a woman of color, there's more risk of developing BV and having BV-driven inflammation, so driving more vaginal atrophy and vaginal dryness, inflammation. So that's sort of the hypothesis. But once again, when we talk about perimenopause and menopause, that's kind of like a big area in women's health that have been ignored for many years. So there's a lot of unknown there.
Excellent, thank you. So, at this time, circumcision is frowned upon and not covered unless you are older and having issues. But then it's extremely painful. Now that we know that circumcision could potentially decrease risk of HIV, would it be appropriate to reconsider having it done at birth?
Yeah, I'll take that one. I think that you really have to look at the context in terms of decreasing HIV. So what's the prevalence in the community? In Canada, in general, HIV in the general community is at very low levels. So at a sort of public health level, implementing a male circumcision program wouldn't really have much of an effect. However, in places in Kenya where first of all, there was not a lot of circumcision done, like around Lake Victoria and in certain communities like the Luo community. But HIV was tremendously high, amongst the highest levels in the world. Then it made sense that on a public health level, the chances of a man being exposed to HIV are very, very high. And so getting circumcision, becoming circumcised, either as a man or as a child, and they're actually in those communities considering more people are having their infant boys circumcised, or some are doing it sort of as a as a cultural transition from moving from being a boy into manhood. And so it has to be fit in with the cultural context and also with the risk of HIV. So I think in some communities it makes a lot of sense, but not as a general rollout. And I think in Canada it would not be a general public health measure that would be effective.
Thank you very much to our Keith, and thank you very much for our three speakers. Phenomenal research. We now have a 15-minute break. Remember to everyone, or a reminder to everyone, please complete the speaker evaluations, and we'll see you back in about 15 minutes. Thank you. Well, welcome back, everyone. I hope you had a relaxing break because we pick up speed again. I want to remind everyone, questions need to be submitted by Slido. Please make sure to fill out the evaluations. We're planning the 30th anniversary, so we need lots of suggestions. May not necessarily take your suggestion, but we need lots of suggestions for topics and speakers. Okay, our next speaker is Jared Bullard, who will speak about influenza always rearing its ugly head. And it's not a question of if influenza will arrive, it's a question of when influenza will arrive. So Jared is a professor and section head of pediatric infectious diseases. In fact, Jared has had multiple jobs, each one of them getting progressively more complicated. Jared works with children and pregnant women, birthing parents, and birthing parents living with HIV. He is also an expert in congenital syphilis and syphilis diagnosis, not to mention that he is a specialist in laboratory microbiology. Jared played an instrumental role at Chatham Provincial Laboratory during the COVID-19 pandemic. In his presentation, Jared will leverage his pandemic experience to discuss the various aspects of influenza. So, Jared, we look forward to your insights about influenza.
Awesome. Okay, well, let's do this. All right, so I just want to make sure that you guys can see my slides.
And please go to the presentation mode.
Yep, and it should be right now, I think. Awesome. So you might remember me from previous bug days. I think I presented about 4 or 5 years in a row. John could probably tell me that better. And so influenza is certainly a topic that I think is quite relevant, especially as we're heading into respiratory virus season. So hopefully by the end, we'll talk about a variety of things. But one of the things we're going to talk about, of course, is, well, what does this show up like? So when you're seeing someone with flu, what do we expect? What sort of complications can happen? And then how do we prevent and treat this particular infection? We're also going to talk about why we see a variety of different severities. So some years we have flu that's really not too bad. In other years, it's really quite hideous. So what's making the difference? And I think you'll also see in the news not unusually highly pathogenic avian influenza. And so we'll talk about some of the risks that might predispose for people to get this infection. So this was our reality back last year for several months. And so not an unusual story would be for a preschooler, usually 3 or 4 years old, to come into hospital after they had been at home with high fevers and a cough and a runny nose and just being hit by a bus. They were really quite unwell. They were just lying on the couch. They had no energy. They had no appetite. And on occasion, it would progress to the point where they were having trouble breathing and they would have to come into the hospital. And usually that's when we would become involved. And it would get so bad sometimes, of course, these kids would be admitted to our intensive care unit where they would have to be intubated. And then we would really struggle because we were wondering, is this all influenza? Because we would pick it up when we did some diagnostic testing. Or was it influenza and maybe a secondary bacterial infection that followed? So sometimes these kids would be at home, they'd be getting better from the flu, and then they get hit again, high fevers, really unwell, and it would be from bacteria like group A strep or Staph aureus. And sometimes, unfortunately, it's a combination of the two. Needless to say, when these kids are that sick, there is a risk of them dying. And certainly that's not unique to children. We see that in adults as well. What you should take away from this picture is that you can see that flu spiked hard in Manitoba. It was at one of its highest peaks in at least 4 or 5 years. And not surprising, really. That just meant that we're probably seeing this flu virus evolve a little bit. It also lasted quite a while. So that was a little bit different because flu typically does this huge spike and then comes down pretty quickly. For context, if you look at the orange bar, or I don't know, umber, I don't know what color that is, but it's RSV. And so RSV was not even close to the same as it was the previous year. And with nursivimab coming down the pipe, I think we're actually going to see a pretty dramatic difference. The black line represents COVID. And so you can see COVID used to have like high levels well above and beyond the other viruses, but it's really not the same as it once was. So flu last year was the problem, and it was predominantly our H1N1 variant. What we were seeing was not unique to Manitoba. So when we looked all across the country, what you can see here is that the peak was higher in terms of percent positive samples, and it occurred slightly later than in 2022 at about the same time as 23-24. And then 24-25 was just kind of combining the best of both elements. It had a really high peak, it had a long overall epidemic, and that was the problem, that this was just for so prolonged that we were seeing a lot of kids who were really, really quite ill. The key thing to take away from this is that when you break this down, you can make out that, yes, we have lots of flu activity in general, but influenza A is different than influenza B. Influenza A is the one that tends to reassort itself and change itself to the point where we can see these epidemics, and if it's bad enough, we can see pandemics. Influenza B doesn't really have that same genetic potential, so we will see it, but it doesn't, and it's not likely then to cause these vast changes or problems in the population as a whole. Who do we expect to get really sick? I mean, it's pretty straightforward, right? If you think about who you've ever seen getting really sick, it's usually those who are at the extremes of age. So think about these preschool kids, and in particular infants, and think about those over the age of 65. And I'm gradually creeping closer to that, so I guess that might be me soonish. I guess, no, not true. We've got time. But also think of people who have problems with their lungs for a variety of reasons, or other issues with their kidneys, their liver, they have blood disorders, they have diabetes. Sometimes we would see it in pregnant women. I recall a couple of cases as a fellow where we saw some really, really sick women during the H1N1 pandemic who were in the ICU. Think about people whose immune systems aren't strong for a variety of reasons, and also think about people who have a hard time clearing their secretions. So sometimes it's older people who have had strokes, and so they're not able to clear those secretions, and sometimes it's kids who are institutionalized with cerebral palsy or other neurological disorders. On occasion, you will see really severe disease in those taking aspirin therapy consistently, but think about it in terms of also people who are in chronic care facilities and personal care homes. Those would be higher risk. Now, you'll notice that it also says BMI is greater than 40 for exclusively adults. I don't quite believe that. That's something we saw a fair amount of as well, that sometimes when we had kids who were quite obese, that we would expect them to be sick as well. And that might be more mechanical than anything. So I kind of mentioned that you do expect to see a variety of different presentations, with pneumonia being the most common. Viral pneumonia can be atrocious. In other words, these kids only have flu. There's not a secondary bacterial infection. They progress very quickly. They don't respond to antibiotics, and the mortality is quite high. When we have bacteria in the mix, it's more treatable just intrinsically because we can give an antiviral and an antibacterial, and it does make a difference. And so you're seeing less likely that people will have problems and potentially more a fatal outcome. We also see things that involve the muscle. So if muscle ache is a feature of flu, you expect myositis can occur, myocarditis and pericarditis can also occur, and toxic shock syndrome also has been shown. Now, usually that's not exclusively because of the flu virus itself. It's more to do with Staph aureus and group A strep, which are known to have toxins. Guillain-Barré, or a neurological disorder, can also show up, and then Reye syndrome as well, or Reye syndrome. Not super common, but may appear. So what are the other impacts? Because we always think about it as physicians and healthcare providers as this is something that impacts our clinics, and it impacts the hospitals and the ICUs. But we do know that it's not just that. Usually what we're seeing is that kids who are more predisposed to H1N1 are way more likely to have higher attack rates. Normal. Kids spread viruses extraordinarily well, respiratory viruses. We expect that mortality is often higher in our older population. That's H3N2 more often than not. But keep in mind, as I said, that there's other impacts. So usually if you're sick with flu, you're out of commission for a while. And that can be you're at home in bed, which means subsequently you're going to miss a fair amount of work or school. And even if you're a parent with younger kids affected, you can see that you can expect that these kids are going to miss a significant amount of days at school. And as a result, you're going to miss work per 100 children with flu. Now, fortunately, we do have a variety of treatments you can see here, including oseltamivir or Tamiflu, zanamivir, peramivir, baloxavir, and amantadine and rimantadine, which are kind of on the back shelf now a lot more, and they're only good for flu. But on occasion, you will also see that we're not just treating you once you have flu. We'll know that you're exposed, and we'll give you these medications to help prevent you from actually acquiring flu. Which leads you to, well, what else can we do? I know. So this is a picture of my wife and I. We were at a resort in the Mayan Riviera, and it was for a destination wedding. And it was great because everybody showed up with the wedding party, about 30 of us, and we were getting our drinks at the bar as we were checking in. And as we walked to our room, I noticed actually, wow, I'm hearing a lot of coughing and sniffling from all the different guests. And sure enough, we had a lot of the people in this party that went down getting really sick and knocked out to the point where they couldn't leave their room for about 2 or 3 days. My wife and I also got a little bit sick, but it was congestion more than anything else. So we enjoyed the beach. We could still go to the gym. We got to drink as much as we wanted. And what do you think the factor was there? What do you think the difference was between people who were getting really sick and those who were just getting a bit congested? Which leads you to this picture. So this is actually my son getting the COVID vaccine by Dr. Joss Reimer. So I helped train her. So I wonder who the most nervous person was. Was it Donovan because of all the pictures? Was it Joss Reimer because I helped train her and I'm standing right there watching closely? I don't know. But when it comes down to it, flu vaccine is the single most effective intervention that we have. And typically, this is a trivalent product, which has H1N1, H3N2, so we're covering both extremes of age, and also influenza B. Typically, we're using the predominant strains that we see in the Southern Hemisphere for their flu season to help predict what we're going to give to the population. And as you're aware, these vaccines are now available throughout Manitoba. Unfortunately, sometimes people don't want to take vaccinations, and flu vaccine is no different. And I have heard many a healthcare worker tell me, I don't want to get the flu vaccine because it just makes me sick, which fine. But will it make you as sick than if you get influenza? Unlikely. And what you can see here is that flu vaccination rates in the province from 2018 are not great. And I can tell you in 2024-25, they were about the same, to be honest. And the vast majority of kids that we saw coming into hospital were from those areas where flu vaccination rates were at its lowest. Which leads you to this picture here. But, oh, hey, Karen, how you doing? Oh, your coffee smells good. Is that hazelnut? That's not, I don't know if that's funny or not. I thought it was funny. Anyway, this is a picture of the virus for flu, and you might notice a couple of different things. So if you look on the top, we have some surface proteins, hemagglutinin, neuraminidase, and both of these in influenza A have many, many different variations. When we're talking about the H component, there's up to 16, and the neuraminidase or N component, there's 9. And it likes to change that. It will modify those particular antigens, and it can do it a lot, or it can do it a little. When it does it a lot, that's when we see a pandemic. That means that the immunity in the general population is not significant enough to stop significant spread. And so you start to see everybody get really sick. But then as they get sick, more and more immunity builds up. So you might see a little bit of activity in the next year as we get a slight change. And we don't expect to see another pandemic until we have significant changes or shift. And subsequently, you will expect that to show up with way more cases as that immunity falls off. We've seen a lot of different pandemics over the years. H1N1 back in Spanish flu was what most of us think about. But if you remember, we also had the pandemic H1N1 or swine flu in the early 2009s and 10s. And that was a shift where that one actually took over and became the predominant H1N1 strain. So what about these sassy buggers? Are we worried about them? Are we not worried about them? Well, people aren't the only ones that can have influenza. And so birds, so fowl, poultry, are known to actually carry influenza A as well. And so sometimes we can have highly pathogenic variations of this. And so avian influenza, typically we all think about H5N1, and that is by far the greatest concern. The first human case was described back in 1997. And remember that if you get this, it's about a 50% mortality rate. And so you can try lots of different things, but overall, people do get quite sick. Fortunately, people are not good at spreading this to other people. And so as a result, you don't see human-to-human spread. And most of the time, it's because people have been exposed to birds, and that's how they would typically get it. You can see H7 and H9, but both are quite rare. And as mentioned, overall, it's not typically transmitted well in humans because we just don't grow it very well in our cells. That being said, on occasion, you will run into people who do get it. And so I actually talked to Dr. Goldfarb over in BC when this case happened last November. And so this kid was really ill, in the ICU, was on ECMO, was quite sick, got a variety of antivirals, and in the end did okay. But it was H5N1, and they knew that because influenza A was positive, but then when we went to subtype it, it was neither H3 nor H1, and I think that combination plus a significant conjunctivitis actually led to Dr. Goldfarb diagnosing this early. So what about these cute little ribs? I think ham. But the thing about them is that they do tend to be a significant mixing vessel. So they have receptors that both humans have and that both birds have. And as a result, they are predisposed to get flu from both species. And as a result, they can spread it to both as well. And that's the worry, that ultimately is kind of this combination of factors where you have birds easily obtainable, pigs as well, who are next to humans, where you can get this transmission and potentially have a very significant pandemic. In fact, during COVID, we were testing so much that we managed to pick up a swine influenza of our very own. So finally, what do we do about avian influenza? Well, the CFIA is regularly monitoring, so we're looking at all these different birds and flocks, and in the event that we have a problem, we know that we have to call, whether that's ostriches or it's chickens or turkey, any of those could apply. Keep in mind that the highest risk people would be those that are working directly with poultry, and as a result, we can give them a live attenuated vaccine, although for the general population, probably not required, but ramping it up could always be possible. So I had a couple questions, but I see that I'm a little bit over time, so I will quickly go through these. You can see that these are the ones that we would expect to include in the trivalent seasonal influenza vaccine. When it comes down to it, you don't have to worry about muskrats to the same degree as the other critters on this list. And finally, this is a bit of a trick question. Most Staph aureus and group A strep are things of concern. So with that, I would like to thank you for your attention, and I'm happy to answer questions after.
Thank you, Jared. And now I'd like to turn the floor over to Gloria Vasquez Grande, who will present Sepsis, a Call for Action. So Gloria is a specialist in critical care medicine and an intensivist at the University of Manitoba Teaching Hospital Network. Her research focuses on sepsis and optimizing antimicrobial use. And Gloria, thank you very much for joining us. If you don't mind going to the speaker presentation mode, that'd be great.
Hi, can you see my slides? Am I in presenter mode?
Not yet.
Not yet? Okay. Can you see then my comments?
Yes.
Okay. Better now?
Nope.
Okay. I'll upload the presentation again. Can you see at all my slides or?
Yes.
Oh, okay. I'll share again.
Perfect.
Perfect. Thank you so much for having me, and thanks for the introduction. Today, I would like to talk about a topic that is very dear to my heart, and it's about the sepsis as a public health issue, and how inequities and how much we can do about them. I would like to say that I have no conflicts of interest. So let's start with what is sepsis. Some of you may say, well, sepsis is an infection that causes organ injury, and it can be caused by a bacteria or viruses or a yeast. Others would say that they will use the sepsis 3 definition, and they will say, well, it's a life-threatening organ dysfunction that is caused by a dysregulated host response to infection. And then you will go on and tell me about the organ injury and the endothelial injury and about the molecular pathogenesis of sepsis. And you will all be correct. But I want to zoom out a bit. Okay, so what is sepsis? Sepsis is the final common pathway to death for most infectious diseases. We just heard Jared talking about influenza and how you can end up with organ damage in an ICU secondary to an infection that other times can only create the sniffles, right? So it's a very diverse disease, very heterogeneous, and many diverse infections can cause sepsis from not only diverse pathogens, but also diverse sources. And all converge when in the body's defense becomes self-destructive, basically. So sepsis is a global health crisis. It is not rare. Each year we see around 50 million cases and over 13 million deaths around the world. And that means that 1 in 5 deaths worldwide involves sepsis. And yet, despite being everywhere, it is most deadly in where resources are scarce. If we look at sepsis incidence in a world map, we can see that the largest regions is where sepsis is happening more instantly, and those are low and middle income countries. This happens not only for where sepsis happens, but it's also the same case for mortality. This has to make us think. 85% of sepsis cases and 85% of sepsis-related death happen in low and middle income countries. Income and survival are inversely related. As national wealth falls, sepsis mortality rises. Sepsis reveals inequities as much as biology does. Who gets sepsis? So if we look at sepsis incidence, it's biphasic, so it peaks in early childhood and again in the elderly adults. It's very surprising that to this day, 40% of incident sepsis cases happen in children that are younger than 5. And 25% of sepsis-related deaths are also in children. Everyone can get sepsis, but the vulnerable get it most. This incidence of sepsis that is biphasic also happens for mortality. So mortality is also associated in the younger and the elderly. But beyond them, who gets sepsis? Who's at risk? So everybody can get sepsis, everybody can get the flu. But people with chronic diseases, with no spleen, with weakened immune systems get sepsis more often, and they can get sicker. Nearly half of sepsis-related deaths are secondary or to other diseases or complications of trauma or non-communicable diseases and not a primary infection. So sepsis is not only the reason you show up at the hospital, it might be something that you acquire after. What is its etiology? Well, sepsis can arise from almost any source, from the lung, the abdomen, the urinary tract, or the skin. And it can, as we have mentioned, come from bacteria or viruses or fungi. But when we think about sepsis in the first world, we think probably more pandemic and respiratory tract infections. When we look at sepsis from a diarrheal diseases are still cause still 20% of cases of sepsis. That is another factor that tells us how sepsis is a disease of the poor and the disadvantaged. It thrives where there's crowding, poor nutrition, and limited access to antibiotics or clean water. We saw the same pattern with COVID, right? But we saw it closer to home. We saw it in our cities. We saw that higher death rate was associated with lower income in every city, and that the people who died from COVID were essential workers or more blue collar and less white collar. This has to make us think. What is the burden of sepsis? So yes, sepsis kills, and it also steals life. Beyond mortality, survivors carry lasting scars. It does not only happen in hospitals, it happens in the community, and it's a burden on the community, and it happens after the hospital admission if there's one. It tackles the brain, the cognition, and the function of each person. It not only takes away years of life and millions of years of life, but it also takes away from the everyday life and the quality of life that the patients will have. It affects, as I mentioned, cognitive function. So if a kid comes to the hospital and sees Jared with influenza, well, yes, the kid may die, and we will lose years of life because of that death, right? The potential that those kids have, if only they had had their vaccine. But it also, the survivors will have a toll throughout their life. They will not go to school, they will maybe achieve less, or it will take a big toll for them not to, and then overcome those. There will be post-traumatic stress disorder, depression, or other side effects from having had sepsis. Maybe they have required amputations because of the type of infection. Definitely families and this network of support suffers, and it disrupts the family structure. And the overall quality of life declines after sepsis. So this is not nothing. We have to be aware. What we call this is post-sepsis syndrome. And we care, not only because we care about the life of these patients, but also because these population, the survivors, have high readmission rates. They have high healthcare use and costs. They have very high mortality, worse quality of life and functional outcomes. And these are not isolated cases. They are a growing patient population, and we need to recognize and support them and put some solutions in place. So yes, sepsis has many phases. The newborn with pneumonia in Malawi, the postpartum mother in Dhaka, the trauma survivor in Winnipeg, or the neutropenic patient in Toronto. Biology differs, but the pattern is the same. So when we affront this medical problem, we think about all the heterogeneity. We think, okay, sepsis is an emergency. What are the barriers, right? And then we try to fix the barriers. And okay, this is a system issue, and we can create guidelines and try to collaborate with all the stakeholders and bring awareness and knowledge and disseminate. And then we come with our sepsis change of survival plan. Okay, sepsis awareness and prevention, early recognition, continuous source control, appropriate access to fluids, oxygen, and antibiotics. And then we will continue to follow these patients, and we will have a clinic after and continue to follow them years after to try to support them. But we will be missing the big picture. It's our clinician talking. Sepsis has many faces, but it's a socioeconomic problem. Education matters. Money matters. Empowerment of women really matters. It is a political problem. It should be a government priority. There are some drug shortages and vaccine shortages that we, the political system, has to solve. Our borders are a semi-permeable membrane. Diseases don't care that there's a border. Diseases are going to go through, but our resources stay at the borders, and we have to change that. There has to be a will. We're all in this storm that is sepsis together, but the boats are very different. Each country has a different kind of boat, and we do not help each other, death toll will continue to rise. We can change things. Education and sepsis outcomes are integrally intertwined. Where women are educated, children mortality drops significantly. For every one more year that those girls are going to school, the mortality of their future kids will drop. It's key to educate your women. Formal education is a social vaccine. Send girls to school and save lives. It's the most impactful single investment to reduce sepsis mortality. We have to do prevention campaigns for sure. Vaccination, as Jared mentioned in his talk, clean water, hand hygiene, prevent hospital infections, safe childbirth, and awareness. Each link in that chain, if social infrastructure fails, true prevention means building resilience at every level, from households to hospitals. So sepsis is political. We have to discuss access to care, to antibiotics, to vaccines, to clean water, to food, to everything. We have to discuss housing and transportation and inequities that exist. And we have to discuss climate, because with the warmer climate, more outbreaks are going to happen, and antimicrobial resistance as well. This is a global problem that we have to tackle together. Health equity is sepsis prevention. We have to integrate our thinking. It's not prevention or treatment. It's prevention and treatment. It's not a vertical approach per problem. It's a horizontal approach. It's not only investing in primary care or in specialty care. We have to invest everywhere. We have to continue putting our intentions in improving knowledge and action and implementation of new techniques and delivery and global and local health together. For this reason, we need leaders that work together and that develop sustainable goals. The Global Sepsis Alliance was born in 2010, and it created enough awareness that triggered the World Health Organization in 2017 to declare sepsis a major priority. COVID helped us learn that public awareness and education and the rapid knowledge dissemination helped us create new therapies for a disease. This has all informed our coalition strategy, and now we have an agenda for 2030, the Global Sepsis Agenda. This is going to make the next success story in global health. There are 5 major pillars, and the Global Sepsis Alliance is driving this bus in conjunction with the World Health Organization and the United Nations. There are 17 Sustainable Development Goals that have been an objective for all these stakeholders to try to improve outcomes. Poverty increases sepsis mortality, child malnutrition increases sepsis mortality, gender inequality, clean water. We have to all work together. What are you going to do about sepsis? We need you. Step up. You can move the needle. You can make a difference. We want you. Get involved. Become an advocate. Thank you.
Thank you, Gloria. So I'm a little scared of that the last poster that said sepsis needs you. I don't think any of us need sepsis. So on that note, we'll switch gears to Santina Lee, who will talk to us about measles, something that we had all hoped was gone and forgotten. Regrettably, it is neither gone nor forgotten. Santina is a pediatric infectious disease physician and medical lead for pediatric infection prevention and control at the Children's Hospital in Winnipeg. Santina is also an assistant professor at the University of Manitoba and a medical officer of health for communicable disease prevention and control. For the communicable disease prevention and control unit for the provincial public health program in Manitoba. Clearly, Santina doesn't sleep given all of her multiple jobs. So, Santina, please regale us with the latest in measles.
Thanks, John, for that introduction. And yeah, so we're going to talk about measles, and it's going to be a bit of a whirlwind tour. Hopefully some things that are maybe new or some takeaway points from today, but hopefully not completely new to you. Because in fact, measles has been bombarding us over the past year. It's everywhere in our media outlets. And so here are just some of the news headlines that we've had over the past year, ever since we started having a national multi-jurisdictional outbreak. So before I get into it, just in terms of disclosures, I have none that are relevant to today's presentation. And these are the objectives. Like I said, basically, we're going to take a whirlwind tour of what's going on with measles right now, with a specific focus on Canada and Manitoba. So let's take a step back and just think about where measles actually came from. And so measles itself, it's an old virus. It's been around for centuries. One of the first written accounts was in the 19th century by a Persian physician. And at that time, they noticed that it was very different in presentation as compared to smallpox. And then it spread globally, and part of its spread was due to colonialism. So it's been with us for a long, long time now. And there's a lot that we've learned, but a lot that we're still learning. In terms of measles in Canada, in Canada, measles was first notifiable in 1924, meaning that's when we started keeping track of statistics related to it. And in 1998 is when Canada achieved measles elimination status, meaning that for at least prior to that, there was no ongoing endemic transmission of measles. Now, it doesn't mean that after we achieved elimination status that we didn't see any measles cases. In fact, every once in a while, we have seen cases in Canada, and sometimes they're isolated cases, and occasionally those cases have small outbreaks. Typically, these cases are due to importation. So people who are not immune to measles go and travel somewhere where they do have ongoing transmission of measles and then come back with measles. However, 2025 marks, well, I wouldn't say something that we really wanted to mark, but that we've had the most number of measles cases in Canada since achieving measles elimination status. And it is very possible that we are going to lose our elimination status. Now, where is measles happening in Canada? The vast majority of the cases are in children, and predominantly in people who are not vaccinated. So 88% of all cases are unvaccinated. About 5% of all cases have an unknown vaccination status, meaning that there's no documentation, but very likely that majority of those 5% of cases are people who are not vaccinated. In terms of overall morbidity and severity of disease, hospitalization-wise, 7% of cases have required some kind of hospital care, whether that's on a regular medical unit or an intensive care unit. More recently, Canada has been doing enhanced surveillance to look at congenital measles cases, because this is basically the first time since vaccine availability that we have had measles cases in people of childbearing ages. And so this is a bit of a newer phenomenon for Canada and North America to see congenital measles cases. Now, to date, for this multi-jurisdictional outbreak, there has been 16 congenital measles cases that have been reported. And in terms of deaths, there has been 2 deaths that are associated with measles. I say associated because I can't say for sure that the ultimate reason for death was measles. However, 2 cases, and they were both in premature infants with congenital measles. So what about Manitoba? We see a lot of similarities of what's going on overall in Manitoba as in Canada. And so in 2025, we started seeing some cases in February, and then it looks like we peaked in May in terms of highest number of cases so far, and it has been decreasing, but we do continue to see a few cases every week. Now, again, it is predominantly in people who are not vaccinated. And I wanted to mention in terms of these case numbers, both from a Manitoba and Canada perspective, we know that these numbers are underreported because not everyone who gets measles and is infected with measles seeks healthcare or seeks testing because they feel relatively well and don't feel they need to go see someone about it. In Manitoba, the majority of the cases have occurred in Southern Health, with the second next highest cases in Interlake Eastern, and then a few cases in other regions, no cases in the North so far. Again, these are predominantly in transmission in communities with low overall population vaccine coverage rates. So the vast majority of cases, again, are in children. And similar to the national numbers, about 87% of cases are unvaccinated. In terms of hospitalizations, 15 of Manitoba's cases to date have required hospitalization, of which 2 of those did require ICU level care. The majority of people who were required hospitalization are young children as well. And it's predominantly due to respiratory symptoms requiring additional respiratory support, whether it's just oxygen or needing intubation, as well as some fluid management, dehydration kind of care. So far in Manitoba, we have not reported any congenital measles cases or any deaths. So let's just review a little bit about measles as a reminder to all of us. In terms of the incubation, there is a range up to 21 days, but for the majority of cases, they typically present at about 10 to 14 days after their initial exposure. And the symptoms start with a high fever, and then sometimes what we call the 3 Cs. So high fever, 3 Cs, meaning cough, coryza, conjunctivitis. And in this prodromal phase, you also can see Koplik spots, which are lesions in the buccal mucosa. Now, the Koplik spots are pathognomonic, however, they are quite transient, so you might not see them at all. As the fever continues, then the rash starts. The rash is a maculopapular erythematous rash that classically starts on the head, moves behind the ears, and goes downwards towards the rest of the body. Now, the rash itself, if all you're going by is the rash, it can be difficult to differentiate from other viruses, drug-related rashes, that kind of thing. So it is important to get the rest of the history. And if it is in someone who is not vaccinated at all, that's going to raise your level of suspicion that this is measles. Measles is not just any other respiratory virus that causes a mild illness. It is for many people, but also for other people, it is not. There are complications related to it. And here I've listed the various different complications that you can see. Some more common and some less common. Some of them occur pretty shortly after infection, and others, like SSPE, don't occur until many years later. So typically SSPE, you see about 5 to 10 years after the infection. And in pregnancy, getting infected with measles is associated with a higher risk of low birth weight, premature labor, spontaneous abortion, and then, as well as I was mentioning, vertical transmission, meaning congenital infection. So let's talk a little bit about diagnosis and treatment. First, about diagnostics. So there are 2 mainstays for diagnosing measles. First is PCR, molecular-based detection, and then second is serology, IgM and IgG. We typically rely on PCR modalities. And so the specimen, the preferred specimen is a nasopharyngeal swab for measles PCR. This is the same as, I think we all are familiar with swabbing someone to test for COVID-19. So it's the same, it's a flock swab in viral transport media or universal transport media. In terms of PCR, you can also send an oral pharyngeal sample or a urine sample. For the urine sample, if you send it early in symptom onset, onset. It is less sensitive as compared to the NP swab, but it can be helpful for people who are presenting later in the course of illness, say around 10 to 14 days after symptom onset. So NP swab is our mainstay when we're doing PCR, and then phlebotomy for serology. Now, serology can be a little bit tricky to interpret if it's in someone who has had some immunization in the past for measles. Treatment-wise, there is nothing specific other than supportive care. What about vitamin A? Were done in countries where there were higher rates of malnutrition and vitamin A deficiency. When those studies were replicated in countries like Canada or similar to Canada, where there is less malnutrition, less vitamin A deficiency overall in the population, the results were not replicated. So in general, in a country like Canada, where you don't see as much malnutrition or vitamin A deficiency, it's hard to say for the mild case of measles infection whether vitamin A is helpful or useful. However, if it's someone who is admitted to hospital, that is definitely a situation where we would absolutely consider using it, and I would recommend you talk to your ID colleague. I think we all know this, that measles is highly contagious. One person with measles can infect up to 18 people who are susceptible to measles. And measles is infectious from 4 days prior to rash onset up until 4 days after rash onset. That means rash is day 0. And so you got to count backwards and count forwards. It's so infectious because it is transmitted airborne, as well as through direct contact with infected droplets. Another reason for why it's so infectious is that we know from older studies that the measles virus can persist up until 2 hours in a room after the person has left that room. And so, as such, when you're in a healthcare setting, we need to use both routine practices as well as airborne precautions. And as part of routine practice, we need to do a personal risk assessment and determine whether or not we need to add on droplet and contact precautions, particularly if the person has respiratory symptoms such as coughing or rhinorrhea, congestion. If you do not have an airborne isolation room in your facility or your clinic, then the next best thing is to use a single room with the door closed. So yes, it's absolutely really infectious, but it is also absolutely very much preventable. Measles containing vaccine is highly effective. If you have received 2 doses of vaccine, it is 97+% effective. Now, I didn't say it's 100%. Nothing in medicine is ever really is 100%. So in an outbreak setting, we do expect to see some cases in vaccinated individuals. However, the vast majority of cases is going to be in people who are not vaccinated. Now, overall, to achieve herd immunity, we need a very high level of population coverage, at least 95%. And we're not near there. Depending on what age group you're looking at, in Manitoba, it ranges from 70 to 80% population coverage for the ages. So just a little bit reminder of who is eligible for measles vaccine in Manitoba. So we have our routine eligibility, meaning 2 doses overall, 1 dose being provided at 12 months of age, and then the second dose being given at between 4 to 6 years of age. However, related to this outbreak, there has been additional expansion of eligibility for infants who are 6 months to under 12 months of age. This is an additional dose. It does not replace the other 2 doses. And particularly, eligibility was targeted for those who are going to be at highest risk because the risk is not universal across the province. So if you have someone presenting to you that you suspect or has confirmed measles, please do let them know that they need to stay at home either until the test result is back or if they're confirmed until 4 days after the rash appearance. And all suspected cases need to be reported to public health on the same day, and labs do report all positive results to public health as well. If there is potential exposure in a healthcare facility, please do notify your IPNC as well. Contact management is very important once we have confirmed and identified a case. So there's and potential requirements for exclusion that will be managed by and led by public health advice. But you need to determine whether or not this contact is susceptible. So this is the criteria for deciding if someone is susceptible or not. The criteria is essentially the same between the general population and healthcare workers, with just a bit of stringency. So in general, measles was widely circulating before 1970. So anyone born before 1970, we would typically consider immune. Unless you're a healthcare worker, then we don't take that in itself as evidence of immunity. You do need documentation either through vaccination or laboratory evidence. And so once we have determined that the contact is susceptible, the next thing is to determine whether or not they are eligible for post-exposure prophylaxis in the form of either vaccine or immunoglobulin. So before I end, I just wanted to share a few resources that I think will be helpful. That was, like I said, a whirlwind tour, lots of information. There is the Measles Quick Reference Guide that we have developed. It's about 4 pages. That's the first link there. I've showed a screenshot of what the first page looks like. And the idea is that it's basically supposed to be one place where you can start to get all the information that you think you might need for someone that you suspect has measles or tells you that they've been exposed to measles. And then there's a few other links, including the second link being where you will find any locations that were announced as potential public exposures. So that's just in summary. There were some questions in the PDF as well, with some multiple choice as well with their answers. I'm not going to go through those because those are available for you. Thank you.
Well, thank you very much, Santina. Thank you, Jared, Gloria, and Santina. So while the questions are coming up, I have a question for the three of you. There was an article in the Winnipeg Free Press recently about the anti-science movement, and I'm curious, how do you see the anti-science movement affecting vaccine preventable diseases and the public health implications thereof? And I realize that that's a topic unto itself, but in a few minutes, what's your vision for what will happen locally and globally?
What a fascinating question, John. It's something that, what I talk about with my colleagues and my family all the time is that this anti-science ideology, it's fascinating and it's pervasive, and I don't even think it's restricted to just medicine. It's just what we see the most part, and I think from our perspective, vaccines, that's probably one of the big ones. It's a change. Like I would say in the past 5-6 years, especially over the pandemic, what used to be kind of a meaningful conversation with parents who were vaccine hesitant has turned not confrontational, but it doesn't matter what you're saying to them. I don't think that they are going to be guided by evidence or expertise to the same degree, and it almost borders on delusional. So it's really fascinating to see, and I think that that's something that we have to kind of address. Like how do you reach that group who doesn't really have an interest in necessarily hearing what you have to say in the same way? And I don't have an answer for that yet.
Okay. Well, the questions are up. So the first question is, what are good resources for influenza surveillance now that CDC is not as reliable? Well, I'll take part of that one, and I'm going to say to you that the Public Health Agency of Canada is shining with all of the surveillance that it's currently doing. But Jared, Santina, your thoughts?
Sure, I'll start then. Yeah, certainly the Public Health Agency of Canada does work very closely with the provinces as well to really keep track of what's going on. And it's not just limited locally, right, or even in Canada. It's taking into consideration flu activity across the world in the different hemispheres. So it's not, even if the CDC isn't necessarily doing as much leadership as they could be, there's still a lot of information that we can get in collaboration with other countries throughout the world. So,
okay, Santina, any thoughts?
Yeah, not much more to add beyond what Jared has said. As you know, stressed, like we look like when we're developing our or not developing, but preparing our next seasonal vaccine, we're looking at the Southern Hemisphere, right? So that's not even about the US and the CDC. However, even despite some concerns, and the political atmosphere down in the States. There's also from a state level, they also generate their own data. So there is, I think, still some potential reliability related to that. And then, of course, there's other countries such as in Europe, the UK, that we have been. So it's not like that it was just a one partnership that we had that we were relying on.
So Gloria, if there's one thing that you could change in our current approach to sepsis, what would be the one thing that you would see that could make the impact greatest?
Right now, I
Right
think
now.
education is like the single magic wand that we have. Hopefully in the future there will be more scalable access to care, but I would say right now it's education. In the past, what has dropped the mortality from diarrheal diseases, for example, is oral hydration techniques and how to make that scalable in the rural communities. But right now it's education.
Thank you. Now, next question is for Jared and Santina as pediatricians. What do you see as the most impactful approach when speaking with a vaccine hesitant person?
I'll start. Yeah, it's definitely challenging a scenario that I think we are all facing. And vaccine hesitancy is absolutely like a range, a spectrum of, sort of a little bit hesitant somewhere in the middle to like just not at all interested in having any conversation and vaccine refusal. I think, a big part is building relationship, building trust. And that goes beyond the conversation of vaccines. So starting that conversation, trying to just meet people where they're at, see what are their concerns, and, finding that common ground of, I am wanting to see that you're healthy, your child is healthy. I think we have similar goals, right? And then it's very often not going to be a single conversation that's going to change anything, but overall, and I think it's really also important that as part of that, we're not turning people away and saying, well, because you are not accepting vaccines, that we aren't going to provide you care, because I think that in itself erodes trust, not just your own relationship, provider, physician, patient relationship, but overall for everyone else, that is going to be meeting them when they need that. So yeah, it's step by step, it's slow. And if, someone is ready for one vaccine, not all of them, that's okay. That's great. Meet them where they're at and go with that.
Excellent. So Gloria, what one measure has improved sepsis outcomes over the past 10 to 15 years?
I think what has improved over the last 15 years would be more our common approach to sepsis and bringing up awareness. That has changed a lot. The mindset that everybody has towards sepsis. So being aware that it exists, knowing and suspecting sepsis has made us able to treat it faster and avoid the poor outcomes. However, if we think from the global perspective, I would say in the last 60 years, it would be rehydration techniques, as I mentioned.
Okay, fantastic. So another question, clearly everyone is very interested in influenza. What advantages and disadvantages would an mRNA influenza vaccine provide over the current influenza vaccines?
So I think what we saw across the COVID pandemic was that the main advantage of having mRNA was the scalability and how rapidly we could incorporate changes in a particular virus into a new vaccine, which was fantastic, right? that's probably above and beyond what we can do with our seasonal trivalent vaccine for flu. The main disadvantage, honestly, is that I think that mRNA is largely distrusted by a number of people above and beyond, despite the COVID vaccine literally being the most studied vaccine in all of human history in terms of its safety and effectiveness. So that would be it. So advantage, it's great. We could scale it up very, very quickly. The disadvantage would, I don't know that the uptake would be better with that particular formulation compared to the traditional one that we use.
Excellent. Well, thank you all very much. Excellent session. That we have a half-hour lunch break, and then we'll be back at noontime for the University of Manitoba Department of Medicine Medical Grand Rounds, where Drs. Julie Ho and Armel Villalobos will speak about xenotransplantation, the future or fantasy. So with that, we'll wrap up the morning session. Thank you very much for attending. Please fill in any evaluations, any comments. We'd love to hear them. Thank you very much, and we'll see you at 12 o'clock. Good morning / good afternoon, everyone from the Department of Medicine, and welcome back to those who were attending Bug Day earlier today. This is the Medical Grand Rounds section or portion of Bug Day. We have two distinguished members of the Department of Medicine, Dr. Julie Ho and Dr. Armel Villalobos, two practitioners that practice in different areas, but who have a joint interest in transplantation. I'm going to introduce Julie and Armel with 2 lines of introduction, but the introductions certainly don't do these two individuals justice given their academic productivity and everything that they do. Julie is a nephrologist with expertise in transplant immunology. Her research program focuses on improving long-term kidney transplant outcomes. And Armel is a specialist in infectious diseases with a specific interest in transplant infectious diseases and invasive fungal infections, such as aspergillosis. The topic is xenotransplantation, the future or fantasy. And this is a topic that's been hanging around for a long, long time. And it's, in theory, a brilliant concept, but it might be fraught with problems. And Julie and Armel are going to try and unravel this for us. So Julie, the floor is yours.
Hey, thank you so much both for the kind introduction and the opportunity to present. I have no relevant disclosures to state. I do have external funding, none of which are relevant to this presentation. Armel and I have a split presentation, and I will be focusing on the first learning objective, which is to understand some of the fundamentals of xenotransplantation, and leaving the last 2 learning objectives to Armel's Dr. Villalobos' part of the talk. So why xenotransplantation? Why is this something that, as Dr. Emble mentioned, has been around for a very long time, and why does it keep coming back to the forefront? And really what it boils down to is that the demand for organ transplant is vastly outstripped by the supply of organs. There's growing individuals on wait lists for heart, liver, lung, and kidney, with a significant proportion of individuals dying each year on the wait list for a kidney transplant, heart transplant, lung transplant, liver transplant. And so really, ethically, the question is who could potentially be eligible to get a xenotransplant? And in this opinion piece, and I don't necessarily agree with all the stated potential candidates, but it has been purported that electively planned transplants for those who are not otherwise medically suitable for organ transplantation may be considered as candidates for xenotransplantation. Those may be in several categories, such as too sick to wait for an organ transplant, highly sensitized patients who may not otherwise be able to attain a match for a human transplant. Or another example was high risk of recurrent disease, precluding candidacy, recurrent disease, precluding candidacy for things like kidney transplants, such that their risk of recurrence would be too high to facilitate human transplantation. And so there's a number of barriers to xenotransplantation. These reflect some of the biological or immunological barriers that researchers have been trying to address through gene editing. And so you've seen probably both in the popular press, but also in the scientific literature that there's been quite a bit of work with knockouts and knock-ins in order to try and achieve functional xeno organs for human transplantation purposes. And so they have several categories which need to be addressed in the gene editing process. One of them is human gene transgene expression for multiple complement thromboregulatory and anti-inflammatory proteins. The 10 gene edit kidney does include antigenic carbohydrate knockouts. And so the reason for this is there's preformed human xenoantibodies to alpha-1,3 galactosyl-transferase, which requires knockout in order to avoid hyperacute rejection from these preformed xenoantibodies. Of note, some of the gene edits do also ensure that the red blood cells do not express red blood cell antigens, therefore making these organs a universal donor, such as a blood group O organ. There's issues with xenogrowth after transplantation to ensure size mismatch is addressed. And in order to successfully achieve xenotransplantation apart from the gene editing, it requires novel immunosuppression in order to achieve sufficient suppression of a xeno response, as well as a cardiac or other organ preservation solutions. So we're going to talk through some of the different clinical experiences that have occurred. There's two major types of experiences. One is with human NDD, or neurologically determined donors who have received a xeno organ. And these are proof of principle studies to demonstrate the lack of hyperacute rejection and to assess for organ function in situ. There's also been human clinical trials of live human recipients in those who would otherwise not qualify for an organ transplant or die waiting for a suitable transplant. But I won't be discussing pathogen surveillance, but xenograft function surveillance is something that is of imperative for a successful transplantation. So we're going to go by organ group. Xenotransplantation has been around for a very long time, as mentioned. The very first cardiac xenotransplantation occurred with a chimpanzee heart in 1964. It was attempted again twice in the 1970s, but those individuals passed within hours from hyperacute rejection. And in 1984, baby Faye received a baboon heart. This was a very young patient with a congenital heart disease, and this individual died after 20 days. And so this, after this early flurry of primate xenotransplantation, there has been a lot of work that sort of circled back to the preclinical side, and also switching from primates to non-primates to pigs. As the primary model for xenotransplantation. Now you'll see in the references throughout this talk that it's a combination of references from very high impact journals, but also some from the popular scientific press, because xenotransplantation is so new and there's so many changes that there are some human cases that have occurred that have not yet made their way into the medical literature, and we don't yet know what their outcomes have been. But we know that in January of 2022, there was a compassionate case of two heart recipients. They occurred for an individual who was not otherwise a heart transplant candidate or candidate for an LVAD, who received a CRISPR-10 gene edited pig heart from a non-medical grade facility, which I think Dr. Villalobos will be addressing. This heart provided 7 weeks of life-sustaining treatment. However, this individual subsequently developed porcine CMV with concern for viral myocarditis antibody-mediated rejection, and subsequent heart failure. And the second recipient has not had the same amount of publications in order for us to determine their true outcomes, but they attained 6 weeks of survival. There have been 2 decedent recipients, and these are neurologically determined brain death recipients. And these individuals received 66 hours of function, although in one of those recipients, there was significant heart failure due to the size mismatch of this individual. Now, these heart transplants used novel immunosuppressive therapy for transplantation, utilizing anti-CD40 blockade, which is not currently used because the requirements to overcome a xeno response is more than what we would require for human transplantation. From a liver perspective, there's been transplants into both decedent as well as live recipients. There's been 2 decedent recipients, one at the University of Pennsylvania, one in China, as well as one compassionate case live liver recipient in May of 2024. The University of Pennsylvania recipient actually had an ex vivo porcine 69 gene edit liver, which showed actually intact liver function for 3 days. The reason for it to be ex vivo was they're developing this liver transplant approach as a bridge therapy, not as a destination therapy. The liver transplants that occurred both for the decedent and compassionate use cases in China were in vivo cases from pathogen-free facilities. And interestingly, while people expected there to be the cleaning functions or waste disposal functions of the liver being replicated, there was actually also protein synthesis that occurred, so xenoprotein synthesis that was developed. And the individual who received the liver for compassionate purposes survived 171 days after transplant. There's only been a single lung recipient, and this was a decedent or neurologically determined recipient who received a left pig xeno lung. You can see on the top panel on the left the preoperative CT scan of the decedent recipient, and on the right-hand panel is the pig lung. And unfortunately, this individual had severe primary graft dysfunction, secondary to both ischemia perfusion injury, as well as antibody-mediated rejection. They monitored for 216 hours, but certainly with the primary graft dysfunction, did not have achieve a great outcome. I want to highlight the immunosuppression at the bottom. You'll notice at the bottom for induction therapy, they used thymoglobulin and basiliximab and rituximab and eculizumab and tocilizumab, as well as for maintenance immunosuppression, you'll see our typical triple maintenance with tacrolimus, Cellcept, and steroids, but they added belatacept to that maintenance as well. And so significantly increased amounts of immunosuppression compared to what we would do for a human graft. From a kidney perspective, there's been several decedent recipients in 2021. And so the first individual in September received a bilateral nephrectomy and transplant, whereas the other decedent recipients that occurred at another institution, there was no native nephrectomy. Therefore, it was harder for them to determine whether or not there's true graft function that was achieved. There have been several live recipients. And again, these are all very small single case studies. One individual died after 2 months from unrelated causes. Another passed away after getting a nephrectomy at 47 days and passed at 86 days. Another returned to dialysis after 130 days. The most recent is from January of this year that we know about, where they're still dialysis free at 6 months as of September the 8th. But we don't, we're again awaiting scientific publications on this individual from Harvard. And lastly, there is an individual in China who received a kidney, of which again, awaiting data, but nothing published yet. And so I just want to, before I transition over to Dr. Villalobos, I just want to highlight some of the major challenges and barriers to non-infectious barriers to xenotransplantation. There's a number of ethical issues in terms of who should be eligible and how these organs are allocated, and then how to obtain consent, especially for organs which there's no dialysis equivalent, to obtain truly informed consent. There's regulatory issues in terms of how governments will regulate transplantation and regulate the organs that are being manufactured for commercial purposes. And always there is a risk when there is a commercialization. How is in situ growth to be dealt with? In terms of rejection, we have very poor treatments right now for human antibody-mediated rejection, and we'd anticipate that rejection risks would be much higher with antibody-mediated rejection and T-cell-mediated rejection for xenotransplantation. But some of our core treatments, including IVIG for treatment of antibody-mediated rejection, is actually not applicable or useful or available for xenotransplantation because infusion of human IVIG may result in transfusion of xenoantibodies, which can subsequently worsen antibody-mediated rejection. In terms of protein synthesis, we don't know the impact of xenoproteins and what their long-term functional or immunological impacts may be. And what is the impact of our immune compromise, which is going to be significantly more than human transplantation. And we completely do not understand what the impacts of microchimerism might be. The most common cases, or most commonly understood microchimerism, is human maternal fetal microchimerism. However, we don't understand what the impacts of human xenomicrochimerism might be resulting from xenotransplantation. So many potential non-infectious barriers. So with that, I'd like to finish with the last thought is xenotransplantation possible as either a bridge or as a destination therapy? I would argue it might be a good solution for bridge therapy, for example, for liver transplantation, where there's no dialysis equivalent. We're nowhere near to it being a destination therapy. Solid organ transplantation is not equal amongst organs. And then with that, I'll pass it to Dr. Villalobos to discuss the infectious barriers to xenotransplantation. So thank you.
Thank you so much, Yuli, for your presentation. So I'm going to focus on infectious complications related to xenotransplantation. So I don't have anything to disclose. And we're going to focus on the second objective, which is to identify key infectious risk associated with xenotransplantation. So when we try to estimate the risk of infection after transplantation, is really an interaction between two variables. On one side, the epidemiology of the infection, meaning how aggressive is an organism, the dose and the amount of the contact that the individual has with this organism, and also the intensity and how much opportunity the organism has to cause infection. And on the other hand, we have something that we call in transplantation the net state of immunosuppression, which is a group of factors that can contribute to the susceptibility of the host to an infection. A good example is COVID-19. For example, the same virus, depending on the host, depending if it's a newborn, a pregnant individual, a transplant recipient, the same organism can behave very differently among different type of patients. So our main concern in xenotransplantation, or one of them, is something that is called donor-derived infections. Donor-derived infections are infections that are transmitted from the organ donor to the transplant recipients. These donor-derived infections are well described, and at the moment they are uncommon in human allograft transplantation. It has been documented that they occur approximately 2.2% of transplantations in the US, and that is because in human transplants, we can actually test the donor, we can test the recipients, and that helps us decide if the organ is actually safe to use. And also, it gives us some information about what to expect, and even in some cases, give preventive medicines to avoid even reactivation or even passing of those infections to the recipient of the organ. So when we try to evaluate an organ donor, we hope to have a perfect donor, someone that doesn't have any active infections, that hasn't been in contact with viruses, with bacteria, that is fully vaccinated, that doesn't really have any high risk behaviors for sexually transmitted infections. But in reality, when we have an organ offer, this donor is just like one of us. It has been living its life, having fun, being exposed to viruses, parasites. They can have partially treated infections or even active infections at the moment of transplantation. And then it is a common practice that we use organs from donors that we know that they have latent infections, such as CMV and such as Epstein-Barr, which is actually routine and standard for us. And they are because we know how they behave, we know how to monitor them, and in some cases, we even have preventive medications while they presented. During the time of the procurement, we have a very limited amount of time to really make these decisions. The only tests that we have available are really serological tests. And of course, we're going to have some microbiology cultures and some samples where we're only going to get those results after the transplant. So why are we interested in using pigs? As Julie said, this has been a field of research for really many decades. And there are a few advantages in using pigs, theoretical advantages. Their organs can size to humans. There is significant experience breeding these pigs for commercial use. So there's experience in how to breed them, even on doing genetic manipulation. There is knowledge about advanced genomics, and even some of the most common viruses from pigs have been sequenced, and those sequences are currently available. There is some veterinary experience with these organisms in microbiology, even developing vaccines for them. And swines are actually resistant to some human viruses, to name some: HIV, hepatitis B virus, and hepatitis C virus. However, of course, there are significant disadvantages. For example, there are natural antibodies against alpha-gal sugars that at the moment that these free-form antibodies get in contact with the antigen that is found on pig cells, there is an inflammatory response that can lead to hyperacute rejection. And of course, there are very complex metabolic incompatibilities, and it's also histoincompatibility with humans. So zoonosis, which is the concern here, are infectious diseases of animals that are transmitted to humans the moment that the recipient receives a xenograft from a pig. Then the concern is a henozoonosis, which is an infection that can be transmitted from the pig to the human through a xenograft. And then that is quite complex to manage because the xenograft recipient is not only dealing with the human infections that can reactivate after transplant, but it's also having to deal with porcine pathogens that are able to replicate in the tissue that was transplanted and even potentially in human cells. So when we select a swine as a xenograft donors, there are significant screening that has to be done in place. Just to name a few, there are certain pathogens that are found in pigs that can also infect regular human individuals. For example, influenza, coronavirus, mycoplasma, of course, rabies, and some other mycobacteria. We do have tests available for most of these infections because they infect humans, so these tests are not new. And that doesn't really necessarily mean that this pig that has these type of pathogens should be excluded as a xenograft donor. However, there are also some pathogens that can affect immunocompromised transplant recipients that the pig can carry. For example, Toxoplasma, Strongyloides species, and Aspergillus, that for most of these, we do have microbiological assays, and the decision of whether to use these organs depends on the organism that the pig is carrying. However, it gets more complex than that because there's certain organisms that the pigs have. They are quite similar to some pathogens that immunosuppressed transplant recipients can also have. For example, porcine CMV, PLHV, which is porcine lymphotrophic herpes virus, and porcine adenovirus, just to mention a few. Do we have tests to even diagnose and follow? Not for all of them, just for some of them. And of course, even if we have one test, no test is perfect. More tests have to be developed. They need to be validated, not only in the tissues of pigs, but also standardized in humans. And of course, there are some pathogens that are only unique to pigs that are not really contagious and they cannot be passed to humans. For example, PERV, which is porcine endogenous retrovirus. And even though there are a few strains of PERV, it's a virus that has a history of significant research in the past that has been studied significantly. And so far, we know that there is no transmission to humans of this virus. However, it's still a low risk because we're still learning from this. And basically what we need is to keep building up the knowledge about this virus in particular. So we're going to talk about the timeline and what type of infections we can expect after xenotransplantation. So right after the transplant, the first 2 weeks, I would say the first month, is a period, as Dr. Ho mentioned, these patients are going to be deeply immunosuppressed. They just receive multiple induction drugs. And in humans, what we would expect as infectious complications are basically nosocomial infections, meaning catheter-related bacteremias, aspiration pneumonia, wound infections, C. difficile, and also anastomotic leaks, abdominal sepsis, and complications that are known to us. But during this period, we can also have pigs that are contaminated by bacteria, and they can also be contaminated by fungi through this whole process that can also be dealt with. So far in this first period, most of the monitoring that we have it could potentially cover most of the organisms that the patients could present, meaning the microbiological testing is good enough at least until this point to test that we will detect most of these infections, with the exception of a few bacteria, because pigs have actinomyces. They also have a Streptococcus suis, which is difficult to detect. But passing the first month post-transplant and between the first month to 6 months is also a period with significant immunosuppression. And then what we see during this period are two things. One, opportunistic infections, such as Toxoplasma, Mycoplasma, Cryptococcus, Nocardia in the humans, and also residual infections or reactivations of infections that can come back post-transplant. And in here, this is a period where we actually start seeing many viral infections. They are pig-derived pathogens, such as porcine CMV, PLHV, PCV, coronavirus, and PERV, and also many others that we potentially haven't even identified, that we haven't even able to document which one they are and what can they do. And lastly, imagine that we actually achieve a xenotransplant that lasts for a year. The expectation is potentially that the immunosuppression will remain really, really high even during this period, which that wouldn't happen in allograft human transplant. And we would expect to see opportunistic infections and additionally community-acquired infections such as pneumonia, UTI, respiratory infections, PTLD, and cancers. But the truth is that at this point is unknown to us what to expect regarding reactivation or viral infections coming from the xenograft. So at this moment, this therapy is definitely still experimental. Each xenotransplant is considered a clinical trial that has to be submitted to FDA, and it includes a package that tries to estimate the risk of infection, that tries to identify the nature, the intensity, the duration of the immunosuppression, and also consider the infectious exposures that the recipient is going to have. So in this package, basically, they evaluate who is the potential recipient, why does he need a xenotransplant, what will be the benefit, what type of exposures and potential latent infections that recipient could have post-transplant. They also look at the pig that potentially could be a donor. They go through all the microbiological screening. They try to make a plan about the immunosuppression that is going to be used and potentially all the monitoring that can be done post-transplant. Of course, there's only a few institutions that can do this around the world, and they have to have significant infrastructure, not only in hospital facilities, but also to breed, have labs and have companies that actually breed all these pigs in very controlled environments. So let's talk about the viral infections after xenotransplantation. This is a huge concern because there are multiple porcine viruses that can replicate in the cells of the xenografts. Just to mention a few, PERV, as I mentioned previously, porcine cytomegalovirus, porcine lymphotropic herpes virus, sarcovirus that depending on the strain, it can give pneumonia, it can give dermatitis in the pigs. And apart from all of this, apart from PERV, none of these viruses are likely to replicate to human cells, or at least that is what we know so far. Let's talk about a porcine endogenous retrovirus, or PERV. This is an ubiquitous genomic provirus in porcine cells, and there's definitely significant concerns of safety. And that is because they are functional PERV receptors on human cells, which have raised the possibility that xenograft-derived PERV cells could be inserted into the host genome and could potentially infect humans. In theory, the suspicion is that it could cause gene dysregulation and eventually cancer in humans. What we know so far is that although high titers of PERV strain could infect peripheral blood mononuclear cells, PERV has not infected directly primary human cells. And based on one clinical study, despite persistent circulation of these porcine cells in 23 patients over almost 10 years, there was no really documented PERV infection of humans. So far in xenotransplantation studies, there is no really evidence of viral replication, at least of this organism, or develop of anti-PERV antibodies in humans. And actually, there's a few companies in the United States that are actually able to breed swines that are free of PERV. So potential solutions, again, we need basically more clinical trials to understand this. We need to have better nuclear acid testing to prevent and identify these PERV reactivations in case that it happened. And PERV, one potential solution is a virus that is susceptible in vitro to nucleoside and non-nucleoside reverse transcriptase inhibitors, which are basically antivirals used for HIV infection, and they're commonly used at the moment. Well, let's move forward to coronavirus. So coronavirus can infect diverse species, including humans, and have the capacity to interspecies transmission, which is a significant concern when it comes to xenotransplantations. In the case of the pigs, coronaviruses really are enteric pathogens, so they cause gastroenteritis in the pigs. And at the moment, there is no evidence that swine can carry coronaviruses that can be pathogenic for humans, although here is a silver lining. We know very clearly that coronavirus can recombinate. So they can change, they can mutate, they can integrate, and they can eventually become infectious in humans. So that's what studied during the pandemic of COVID-19, because pigs actually have the same cell receptors, such as angiotensin converting enzyme 2, that SARS-CoV-2 glycoprotein binds to. So in theory, it's theoretically possible that could eventually adapt and infect, although that hasn't been observed. And during the pandemic, there were several studies in pigs where they tried to infect the pigs with SARS-CoV-2, and they were not really successful. Again, viruses are extremely easy to recombinate, mutate, and that's definitely a concern. Now let's touch on porcine cytomegalovirus. It's also called roseolovirus and is species specific, so it doesn't really cause a human infection. The problem is that since the CMV, the porcine CMV is in the xenograft, there can be endothelial activation causing systemic neutropenia, coagulopathy, and graft rejection, which is actually what happened in the first transplant heart recipient. So this patient, basically what happened is that the donor, the pig, was tested with PCRs for CMV in multiple times before transplantation, and he always tested negative with one single test. But the problem is that once that the pig heart was transplanted into a very immunosuppressed recipient, pCMV reactivated in the tissue of the heart, and then porcine CMV was detected. The problem, of course, is that the patient died from or with porcine cytomegalovirus. And the challenging part is that CMV, at least in vitro studies, is not susceptible to any standard human antivirals. It has responded to foscarnet in extremely high doses that will be basically toxic for humans. So this is a virus that does not have a treatment at the moment. And this is actually part of the studies done in Mass General from Harvard. When we can see from 2003 to 2008, they were using pigs that were not really infected by CMV. And what they did is that once they reintroduced PCMV into the graphs, you can see the mortality, how basically it moved from months to days. So this is definitely a concern, because although it might not infect directly a human, which is a suspicion that is not clear yet, it reactivates on the pig tissue, and in the context of an immunosuppressed individual, that leads to rejection pretty quickly. So let's move to the third objective, which is to explore microbiology safety in xenotransplantation. So there's a long way to go regarding safety and efficacy of the transplant, and basically because it requires human data too. Just to mention some of the challenges, we need to develop microbiological surveillance and exclusion criteria for pre-production and monitor recipients and contacts. As you can imagine, the number of companies that are trying to breed and produce these pigs in the United States for xenotransplantation has increased significantly in the past couple of years. We also need validated microbiological assays in pigs and in humans. We need management of novel immunosuppression regimens that we will be able to use in this context in cases of rejection. And of course, it comes a huge part of this, which is infection control. What happens when this individual goes home and has a viral infection or a porcine virus that is replicated in the tissue? What happens with the environment, with healthcare workers, with people that did the surgery? What happens with the veterinary that are actually breeding these viruses? And of course, ethical issues, unknown risk, and consents. Is this going to be, again, the $10 million drug that only a few people are going to have accessible? Or is this really a therapy that is going to be accessible to everybody? I think the answer is quite clear. So let's talk about the safety and measurements that can be put in place screening the donor swine. So at the moment, as I said, there are strict microbiological regulations to breed these swines, basically for human consumption, and the use of these tissues are not unknown to us. At the moment, we have, for example, heart valves, which are porcine biomedical products that we use. So there is some knowledge and some learning there in place. And at the moment, in xenotransplant herds, it's basically a very controlled microbiome. They control the diet, the proteins that they receive, filter water. Is a very special biosecure housing to prevent any type of introduction, accidental introduction of pathogens that are either porcine and humans. They restrict the use of antibiotics, and also they definitely need to do genetic modifications the way that they breed them, because these pigs are basically produced through in vitro, and that requires very sterile environments. There are certain pathogens, and the list, although it looks big, it might be even bigger, of pathogens that are not permitted in swines, so they can become xenotransplant donors. And of course, there's always the possibility of doing this xenotransplant in endemic areas when, for example, we have Nipah virus, when we have schistosoma, when we have porcine sarcovirus, and this is expanded in other geographic areas where they have other pathogens that could be incubating or latent in swines. And what happens with the xenograft recipient? So if we have a transplant candidate, this on the left, you're going to see a table of all the tests that we should do before transplantation to estimate and predict certain infections that can become an issue post-transplant. But apart from that, monitoring that post-transplant, we will have to measure and monitor multiple other viruses, including porcine viruses, plus the reactivation of human viruses that we will be expecting. So there are numerous pig-specific pathogens about which little is known. Their behavior and their pathogenic potential in humans remain uncertain. Validated diagnostic assays are lacking, and effective therapies are unavailable for most of them, as many antimicrobials are ineffective against porcine pathogens. So that makes us think, for example, we know that pigs can have adenoviruses, but what happens and how would a porcine adenovirus will behave in humans? What syndrome would it give, and what type of treatment could we offer? For example, we know that all pigs are colonized with actinomyces and nocardia. What would happen with a human? Are these pathogens relevant? Could they cause a bacterial infection in these recipients? So all of these questions are at the moment unanswered. And forgetting about bacteria, really the significant concern in xenotransplantation are viruses. Why? Because they're harder to diagnose. We have fewer assays. They're harder to treat because we have fewer therapies for viral infections than for bacterial. And many of the antivirals that we have already are quite toxic. Also, if you remember, certain viruses are immunomodulatory. They activate inflammation, they activate graft rejection, and they're associated to graft injury and rejection in some patients. And of course, cytomegalovirus, for example, and other viruses, it has been well described that it's a risk factor for invasive fungal infections and other bacterial infections. So what are they doing at the moment? These xenograft recipients, they are in risk of infection and graft dysfunction. They're going to be on anti-rejection drugs lifelong. So basically what they're doing is that they try to do a storage and a bank of different biosamples that should be stored to track serological changes, molecular evidence of infections. Samples are also obtained from close social contacts of the recipient, people they are in contact with that source the animals, also family around them, and even healthcare workers to see if there's any transmission, if there's any presence of any other viruses around the recipient that receive a xenograft. And by law, these samples need to be stored for more than 20 years to see if there's any footprint in the future that could precede potential mutations in viruses that can develop in the future. And all of this information, of course, is available for public health authorities. So now, what happens if we have an individual that receives a xenotransplant and comes into the hospital with fever? So we don't really know what type of signs of infections they're going to have. Very likely they will have unexplained fever, sepsis, leukocytosis, or the opposite, leukopenia. They could have pneumonia, they could have diarrhea. And all these signs are going to lead to a broad spectrum of infections, not only human, but also xenograft-derived infections. So it's quite challenging. Assessing transplant patients with fever at the moment is quite challenging. So even having a situation like this is going to require extensive testing, radiological studies, and also even potentially some empirical therapy. Now, the problem is that if we have a patient like this coming into a hospital, of course, it's a concern for other individuals, since we don't know a lot about transmission, and it very likely will take days to identify what is going on and what type of virus the xenograft recipient has. So far, the recommendation is that xenotransplantation requires universal precautions, although single negative pressure rooms could be used until more experience is gained. Of course, some consideration, just food for thought. We're going to need to sterilize and high-level disinfectation of instrument, educate clinical staff for precautions, develop institutional protocols. For example, what if a healthcare worker gets a needle stick of the xenograft recipient or of the graft, and other type of exposures? And also try to see if there's any preventive or prophylaxis that can be developed for some viruses. Also, what happens with these individuals want to have an active sex life. So educate sexual and close contacts, contact with bodily fluids, and also barrier protection for sexual activity. So a lot of unknowns about this. So just to summarize, to avoid the transmission of infection through xenotransplantation is going to involve multiple spheres. The first one will be infection prevention in healthcare workers and close contacts. So counseling caregivers, education for healthcare workers, infection control practices, potential screening, protocols, testing, and monitoring. Also, microbiological surveillance of the swines. So really have biosecure facilities that will specify inactivated immunization, control what they eat, limit the use of antibiotics, and also have a very strict screening protocols before the procurement of these organs. Also, at the moment when the xenotransplant recipient presents to the hospital, managed by syndrome, meaning consider human, but also swine pathogens, including isolation, send molecular testing, and potentially empirical therapies. And finally, surveillance of the recipient. So pre-transplant evaluation as much as possible, also taking care of him post-transplant really closely with PCRs and other type of sampling. And just to finalize this, this is the photograph of a few xenotransplant recipients being discharged from the hospital. And I wanted to include this just to put a human face into xenotransplantation, because at the end we are all here because of the patients and the need of organs. It is a problem. It is affecting thousands of people every day. So all these efforts are really with the purpose of serving our patients.
Well, thank you very much. What I'd like to do now is open up the floor for questions. And I hope we've got the questions from Slido coming up. What? No questions. I will ask the first question. So, realistically, when do you perceive that there may be xenotransplantation? Or is this something so far out there that it is really only a rescue or a palliative type of intervention?
So maybe, are you okay? If I don't, okay, yeah. I think we're a ways away yet. I think this is still very early stages. I know it's gotten a lot of press. I think there's a lot of barriers that have, as you know, we've elucidated in both our presentations, that we really need to overcome before this could be potentially widely available. I think, you know, not all organs are equal. You have some organs where, you know, if you don't get your transplant, you'll pass away. And I think in those situations, I think there's a lot more impetus to pursue something as high risk as this. For example, for the liver case, you know, is it possible to use an ex vivo porcine xenograft temporarily until, you know, liver is able to recover from an acute insult? Like, are there ways that we could use this as bridge to, but not a destination there? I think we're quite a ways away from it being a destination therapy. But those are just my perspectives. I think, you know, even just the ethical and regulatory issues will take some time, apart from the immunological and infectious barriers.
And I agree. I think that the answer is basically we don't know, right? Like we really don't know when this will be a therapy that will be a safe alternative for our patients. The reality is that with so much uncertainty, this is something that is currently done as clinical trials. And even though the knowledge is the best knowledge that we have had yet, and it's probably the closest that we have not been to understanding transplant, we're very far away from this being a realistic option available.
I would also argue that there's probably different interventions that we could do that might make more of an impact, that, you know, are worth pursuing. Like in, you know, not, I think it's important to pursue xenotransplantation for options in certain cases, but, you know, if we had 100% consent rate for deceased donor transplant, it would make a very major difference to our organ donor rates. If we could gene edit human organs ex vivo after retrieval and prior to implantation, I think we would have much better immunological outcomes while avoiding a lot of the xeno infectious risks. I think there's a question about life expectancy after xenotransplant. I would say that from the few cases that we've seen, it's largely dependent on the organ type. The best or longest has been a kidney recipient of, a graft survival of 6 months thus far. But whereas for the heart, the best has been something closer to 16 weeks, 12 to 16 weeks. And is there any pushback from Greenpeace or similar organization? And Armel, please jump in here if you ever want. There's absolutely animal rights organizations that have had major pushback, and that's part of the reason why these facilities don't need to be just biosecure, but actually like secured facilities that are. I know eugenicists, they not that they hide the facility, but it's not publicly known where the facility is located. There's major reason for pigs as opposed to primates is for this reason. That's why, although the primate model has a better immunological similarity to humans, this is why because pigs are already used commercially. I don't think I can answer the religion question. How frequently does religion end up impacting decisions? Yes, I apologize. Do you have a response to the?
No, not really. I don't really have an answer particularly to that, but I think that there's a lot of stigma. I can talk about that related to xenotransplant. Some of the main concerns are the ethical management of these animals, and also a major pushback, despite religion and ethics, is a genetic manipulation that comes to all this breeding of pigs. And also, from the infectious perspective, one of the major pushback, which actually was the reason why xenotransplantation stopped for decades in certain centers, is the risk of developing recombinating virus or potentially spreading viruses that didn't really exist. As we know that has happened in the past, we know that, for example, SARS-CoV-2 originated in a market when there was recombinant viruses that were combinated and eventually jumped and infected humans. So I think that there are a few concerns regarding the ethics, the management, and the breeding, the modification of the pigs, and also the potential of creating recombinating viruses and potentially viruses adapting from animals to humans with basically no treatment options.
Thank you. Is it possible to gene edit the animal organ? So there's several companies. One's Revicor, one's eGenesis. There's the ones in China. They are all gene editing the pigs to try and mimic humans prior to transplant. Some are 10 gene edited, some are 69 gene edited. But these are predicated on the assumptions that we know exactly which genes to modify. I think we can successfully modify genes that we know about, but it's the ones that we don't know that are likely going to be an issues with incompatibility. Do you want to alternate? I'll take. Do you want to take the next one, Armel, and I'll take Dr.
Yes.
Bose?
How do the risk of patients compare to those receiving a porcine valve transplant versus someone receiving a porcine solid organ transplant? The major difference is the immunosuppression, right? So the person that receives an organ from a pig is going to be deeply immunosuppressed, meaning they're not going to have good T-cell response. They're not going to be able to form antibodies, and that leads to replications. Patients who receive a valve, again, is from very controlled environment, again, genetical modifications to avoid transmission of certain viruses, but we're not expecting them to reactivate without any immunosuppression into the human.
So summarizing the therapeutic options for management of acute rejection in xenografts, and how is it different? So I would say that what we've seen with the xenografts is a predominance of antibody-mediated rejection, which we typically see less of for human transplantation because we try to avoid where we know there's preformed antibodies. Our major pillars for management of antibody-mediated rejection in humans is plasmapheresis, IVIG, and/or adjunctive therapies for which we have poor evidence. But unfortunately, the IVIG is problematic to use in xenotransplantation because the anti-Gal antibodies can be quite high in the IVIG formulations, and then you're subsequently infusing a preformed donor-specific antibodies. So those would be the major differences. I don't think there's been a lot of T-cell mediated rejection seen yet, but that's largely because we don't have a lot of long-term outcome data beyond that early period, which is usually an antibody-mediated rejection period. And then Armel, I'll let you.
Yep. What is the most rejected organ transplant? So human to human, like allotransplantation, lung transplant is the one that is more prone to rejection, basically because it's an organ that is in constant exposure to the external environment. Also, because of there is a large vascular and epithelial surface area, like physically the organ is bigger, that is highly immunogenic, and also it's a little bit more prone to ischemia reperfusion injury. So, and also there can be chronic lung allograft rejection. So the organ that rejects the most is lung in humans, and in pigs it will be the same answer, lungs.
Okay. Data on the transfection success rate for gene modification for the CRISPR gene editing. I apologize that I don't actually know what the actual transfection success rate is, although I do know that all the organs are screened quite intensively to ensure that like the ones that are used for transplant are have been successfully transfected. But that being said, I don't know what proportion of pigs may have been edited and not not subsequently suitable for transplant. Armel, I don't know if you know the answer to that.
No.
Okay. Excuse me.
Well, if we don't have any more questions, I'd like to thank both Armel and Julie for their outstanding presentation, and we can move to the next, our next series of group of 3 speakers. So Julie and Armel, thank you very much. We'll start the next session in just a minute or two as we let Jeff Martin get his slides up and ready to go.
You see them?
No, not yet.
Looks like I'm sharing it. Hopefully it works. Can you see me?
Yes, perfectly.
Okay, share screen again. Screen 1.
There you go.
Can you see it?
Perfectly. So I'd like to introduce Jeff Martin, who's going to present to us Organizing Chaos, the Incident Command System in Healthcare. And those of us who were in healthcare during COVID will clearly understand the Incident Command System and definitely the chaos. So Jeff is the Shared Health Provincial Director of Emergency and Continuity Management, bringing over 22 years of healthcare experience with a background in emergency and disaster management, policy, and process improvement. Jeff has contributed to major emergency response efforts, including the COVID-19 pandemic, mass casualty incidents, and high-consequence pathogen strategic planning. Jeff, hopefully you can bring chaos under control.
All right, well, I'll get started. So good afternoon, everyone. And thanks, John, for inviting me to present on Organizing Chaos this afternoon, the Incident Command System in Healthcare. What I submitted in terms of our objectives for the quick 15-minute presentation is describe what the healthcare ICS is and when we use it, identify how Incident Command System response is activated, and describe the Incident Command System operational cycle when responding to an unplanned event. So hopefully we accomplish that in our quick time together today. So the first slide is really a quick slide on what is it? What is Incident Command? Incident Command is a standardized, adaptable framework that guides how healthcare organizations manage emergencies and large-scale events. It defines clear roles, responsibility, and communication structures to support coordinated decision-making, resource management, and operational control during incidents. The main components, there's 4 of them. The first one is the notification and activation process, which I'll get into more in a minute. The second is an Incident Command System organizational structure or chart, which I will give you some examples to throughout this presentation. The next is an incident action plan, which is a document that when we're going into an incident command response is used to outline immediate objectives and actions to meet those objectives for that incident. And lastly, once the incident command is stood down after an event, there is a debrief and after action reporting process that summarizes what's gone on and lessons learned and what we should do better next time. From there, the main priorities of incident command are, the first being our life safety of all involved. Our second priority is always incident stabilization. Third, our property and environment preservation. And fourth, or not necessarily fourth, but an all-encompassing, is our continuity of health services during these types of events. So why do we use it? So the use of the incident command system turns emergency response from an ad hoc reaction into a disciplined, coordinated system. Command is important, and when I show you the organizational structure chart, you'll see that it's really clear on how reporting goes. I hope that my internet's okay. Is everyone okay with hearing me? Just like I had a little pop-up.
You're good, keep going.
Okay, thank you. So clear chain of command is important. I'll give some examples and show you that in a moment. It's really a quasi-military system, so it's really top-down and very structured, which is why we use it. Second of all, it's important to understand that it's scalable. So the incident command structures themselves, we can add positions, activate positions, deactivate positions, depending on what we're responding to, which is a very good addition. It's common language when multiple stakeholders are activated, so we often intersect with outside organizations and stakeholders like the Winnipeg Police Services, the Winnipeg Paramedic and Fire Services, the Emergency Response Services, etc. And all of those organizations also use the incident command system in their responses. So we're talking the same language when we're working together in collaboration. When I say to them, this is our liaison officer, or this is our operations chief, they know exactly what that is and what they do. And then lastly, why we use it is that it is a coordinated system level response that includes the communication, resource sharing, situational awareness across the health system. So all of our health authorities within Manitoba and many of our facilities have an incident command system in place for response to unplanned and disastrous events. Okay, so moving on then to when do we use it? So we use incident command and activate incident command to support decision making to fill any gaps of activated contingency plans. What I mean by that, in contingency plans, for example, some will be familiar with a code red is a fire in the hospital system. We talk about color codes, code yellow, missing patient, code orange is the disastrous event that overwhelms our emergency departments and so on. We also have contingency plans for power outages, labor unrest, coming up to the adverse weather problems that we may have with the winter. And those plans that we have in place are good for response, but they're not always all inclusive around decision making and what we need to do to maintain continuity of health services, which is the second bullet point here. And so often we activate command to support a contingency plan and fill in any of those gaps that may be not in the plan. I can provide you a really quick example. Not that long ago, the medical device reprocessing department at the Health Science Center had a significant fire. We activated the code red plan within the Health Science Center to respond to that fire, which worked well. Fire was under control. But they also activated instant command for the second bullet point, which is continuity of health services. So because there was a fire in the MDR, all of the equipment that was sterilized within that department was now contaminated. So how are we going to continue the specific continuity of services for the surgical slates when we didn't have all the equipment that we needed and devices that we needed sterilized to perform the surgical slate? And so command was activated to mitigate that risk and figure out how we're going to maintain surgical slates given that challenge. So that was an example of a combination of the two. And lastly, when we use it to support prevention response to disasters, and we most recently went through one of the most significant one with the wildfires throughout the summer this year. Levels of ICS in health, there's 4. The first one is the site and program level. So across Manitoba, the sites, healthcare sites, all will have a incident command system within their sites, as well as within the programs within shared health, like ERS and diagnostic services, et cetera. Some examples of activations for these site program levels of recent, well, HSC not that long ago had a ED flood because one of I think it was a patient knocked the sprinkler head off in one of the nearby rooms or washrooms. I can't remember all the details, but of course caused a significant flood damage and impact to continuity of ED services. So they activated command to support that response. The Grace Hospital had a flood at their access center that in January because of a bursted pipe, and how do we maintain all the services of the access center? They activated command. ERS activated command this past summer because of critical staffing issues and so on. So that's some examples of activations in those levels. The next level is the regional health authority level, which is synonymous with service delivery organization. We tend to use those interchangeably. We have 6 within Manitoba, all of which will have an incident command system. Recent activation, WHA not that long ago had an activation for community scheduling issues that they had within their region. So they used command to mitigate those risks and respond to that problem. Then we have the unified command. This is where we collaborate. This is where more than one authority or site need to collaborate to respond to an event. A very good example here will be any mass casualty event like the Carberry incident that many would be familiar with. Fort Gibraltar had an incident with children and an event there. And then there's been others as well in terms of unified command where everyone gets together. Fast moving incident, let's solve the problem, work together, usually multiple incident commanders, and we get this done in short order and pull everybody together using that process and system. We all actually most recently unified command, January of this year, we had a snowstorm in the beginning of January 2025 that activated unified command. Then on the provincial health side, we also have provincial command. This is always approved by the government of Manitoba. I'll talk about that in a second. It usually involves, not always, all health authorities. It's usually for slower moving incidents, and there's typically only one incident commander, although we know in COVID we had 2. So it's not a steadfast rule, but it's usually one incident commander. As I promised, here's an example of an organizational chart for incident command. This is a very simplistic one that would be used for a very small site or possibly a personal care home. In terms of what I was talking about earlier about chain of command, obviously these positions that are here report up to the command team and the incident commander, so that's a good example. In terms of responsibility in small organizations that may not have enough people to fill all these positions, one of the principles of command is that the top of the chart, the incident commander assumes all of these roles until they're filled by a person. And so if it's a smaller organization or care home, they may take on a number of these roles and maybe another 1 or 2 people takes on a number of the other roles just to make it work. But when we get into the larger structures like the Health Science Center, I'll see if I can zoom in here. Whoops, kind of going quickly. Whoops, there we go. See if I can zoom in here. There we go. Health Science Center, far larger, as you can tell, organizational structure. This is where you really look at scalability. So we talked about why we use it. Scalability is a big one. You don't always have to activate all of these different positions. And we talk about chain of command. A good example here was all of these positions that are identified in their command structure report up to a position here, which reports up to here, which reports up to command. And so in absence of this one, the operations chief is responsible for all of these positions, et cetera, et cetera. So that's a good example of scalability and chain of command. Then I'll show you a quick example of what the provincial ICS structure looked like for wildfires. This was baseline structure. This is what starts our process once we activate command. We then, maybe I'll zoom in on this one too, so you can take a quicker, better look at it. This one here is, again, same scenario, but what I was going to mention about the government activation piece is that in regular business, our SDOs or health authorities, CEOs, who are typically their incident commanders for those regions, in regular day-to-day operations report directly to the ministry. In an activated provincial command, they report to the incident commander of that event. And for the wildfire, that was Dr. Chris Christodoulou for Shared Health. So to change the reporting lines of these CEOs and incident commanders for the SDOs, the deputy minister and ministry have to approve the activation to allow that change to happen and for that reporting line to go through a different mechanism. So that's an important part about provincial structure. And of course, in terms of scalability and as well as adaptability, that is the starting structure, but that wasn't how it ended. There was far more positions added around health partners and others as the event unfolded. Moving on, how does it work? Operational cycle for ICS. The first part of the operational cycle is notification, which typically goes through an administrator on-call process, which is very robust in Manitoba. We have on-calls for all of our health authorities, many of our hospitals, shared health exec, et cetera. From there, the notification of an event goes to an incident commander to make a decision on whether or not to activate the incident command system within the organization. If that happens, typically my area is notified through the ERS on call. We then send out usually a rave notification, which is an application software, or some of you may be familiar with Tiger Connect, to get people into the room to have the initial incident briefing. And once we get everyone in the room, we discuss and have a debrief of what the incident is that we're talking about. We then talk about, bring up an IEP and talk about immediate objectives and actions. And of course, how long do we want to go before we meet again to break down barriers and respond to the incident. And that's usually, it could be anything. Fast moving events like an MCI, it's every hour typically. It could be every day. It could be once a week. It really depends on what's happening. After the debriefing, that turns into a command meeting that then cycles over and over and over again until the incident is over. And in some cases, we also have section meetings to support the command meetings that I'll give an example to at the end. And then once it's all said and done, we have post-event debrief and after action reporting. That's a typical cycle for health in terms of incident command. I'll give you an example with high consequent pathogens because I thought you guys would likely like this example. So here's how it works for a real example on high consequent pathogens, of which we actually had a scare not that long ago at St. Boniface Hospital with Nipah virus. So let's use an example of someone walks into the Grace Hospital and is suspect Ebola. The physician at the ED at the Grace Hospital goes, oh, this is concerning. Their role is to call the high consequent pathogen ID physician on call, who then would have a discussion about the case and the scenario. If those two decide that this is still a risk, that would be escalated to vectors, pulls in a few other experts. And now we're into the operational cycle of an activation in the position in the middle with the big diamond that says patient requires care, activate HSC, HCPU. If that happens, then obviously they require care and or testing. That would be the trigger for us to then call a briefing meeting, which is the red box, Provincial Unified Command. We send out a Rave Tiger Connect, get the people in the room that need to be in the room to deal with this event. HSC activates their command on the operations side to make sure they're ready to accept the patient. And then we repeat, likely an operational cycle for this is every hour, repeat that cycle until the event is under control. We admit the patient and we move on. So that's a real example of how a command would be activated and how the operational period cycle works. And then I also have one more diagram here that articulates this as more generalized, doesn't have to be HCP, it's really how any of them work. Something happens, notification comes into on-call. On-call gets a hold of the commander to decide whether or not to activate a command. We start an incident briefing. It turns into a command and general staff meeting at an operational period of whatever we decide, 1 hour, 1 day, 1 week, whatever it may be. That cycles over and over again until it's complete, and then we have a post-event action after the event is concluded. It also shows on here a secondary process, which is through section chiefs and briefing or branch meetings. I was going to just quickly mention, I'll go back to show you that just so you can maybe understand it. So if we go back to here and look at the wildfire provincial activation of the summer, not only do we have command meetings, so let's just say the incident command meetings were Monday, Wednesday, Friday for fire. That would include everyone at the top of the chart, plus the operations lead, planning lead, workforce lead, logistics lead, finance leads. But then in between the operational period of Mondays and Wednesdays, those leads would also have what we call section or branch meetings with their folks around their objectives and actions, and then would feed back up to the command on Wednesday, and that cycle would repeat with that extra meeting for each of those leads in between the command meetings and briefings and command meetings. So that is it in a nutshell. Real quick, down and dirty review of incident command. I submitted a few questions that you may want to answer. I can give you the answers. They're all D for these questions. Hopefully you're able to gather that from my presentation, although it was quick. And if you have any other questions, that's my name, my number, and my email address. And that's all I have, John.
Thank you, Jeff. So don't go away. We've got some questions for you at the end. So
Sure.
why don't we switch gears to something that does not involve incident command, but it's Mara Goodyear, who will talk to us about opportunities and challenges for improved diagnosis and prevention of syphilis. And Mara is a postdoctoral researcher in the lab of Dr. Caroline Cameron in the Department of Biochemistry and Microbiology at the University of Victoria. And Mara's research focuses on studying the bacterium that causes syphilis, Treponema pallidum. And I'm sure you'll remember from previous bug days, we have a lot of syphilis in Winnipeg and in Manitoba. So Mara, the floor is yours.
All right. Thanks for the introduction and the opportunity to speak today. So yeah, my name's Mara. I'm a postdoc, and today I'm going to share a bit about the research that we're doing in the lab where I work, and this lab is led by Dr. Caroline Cameron. So talking about opportunities and challenges for improving diagnosis and prevention of syphilis. I have no disclosures to share. The objectives for the talk today are to understand the epidemiology of syphilis, understand limitations with current diagnostic tests, and to know about the current approaches to developing syphilis vaccines and improved diagnostic tests that are underway in the field. So starting with some of that epidemiology, worldwide there's about 8 million new infections per year, and this results in over 200,000 deaths per year. In Canada, these numbers are from 2023. There were around 12,000 cases of infectious syphilis. This was a 77% increase from 2018. And if we look at this by sex, this was a 200% increase in females. These rates are rising faster in Canada than other places and faster for syphilis than for other STIs. We look at the burden of congenital syphilis worldwide. It's the most common infection associated with fetal loss or stillbirth. Over 1 million pregnancies are affected per year, and this results in around 500,000 adverse pregnancy outcomes. In Canada, there were 53 cases of congenital syphilis in 2023, and this is over a 200% increase from 2018. So these numbers really speak to the need for new biomedical tools for preventing and diagnosing syphilis. So here we're looking at a timeline of major discoveries related to syphilis diagnosis and prevention. So it was in the early 1900s that the bacterium Treponema pallidum, or I'll call it T. pallidum, was identified as the causative agent of syphilis. Penicillin was used to treat syphilis in the 40s. Diagnostic tests were developed in the 40s and 60s. One vaccine trial took place in the 1970s, but has not been reproducible. And you can really see since then there's been limited progress in the field while we're still seeing increasing cases of syphilis. So looking at some of the challenges, reasons for this limited progress in terms of new diagnostic tests and a vaccine for syphilis. So first, the bacterium T. pallidum, it's a really unique pathogen and it's a really complex pathogen. And I just want to highlight some of these reasons here. So historically, it's been unculturable. So it wasn't until 2018 that a method for actually growing the bacterium in vitro in the lab was developed, and it still requires co-culture with mammalian cells. It's also a really fragile bacterium. This also contributes to making it challenging to work with in the lab. We look at the genome of T. pallidum, about 30% of it is unique, so we can't draw on information from other pathogens. It has few outer membrane proteins. These would typically be used as targets for things like vaccines. And historically, the syphilis field has been underfunded, and there are few investigators worldwide who actually work with the bacterium that causes syphilis. We also have a limited understanding of what's needed for protection against T. pallidum. So natural infection does not induce immunity, so people can have syphilis more than once. So this leaves us with few molecular targets for vaccine and diagnostic test development, but leaves us with lots of opportunities as well. So I want to talk today about research in the lab where we're looking to develop new diagnostic tests and a vaccine to prevent syphilis. So I'm going to review our platforms for the development of these tools. So the Cameron lab primarily studies the bacterium T. pallidum and its pathogenesis. So how does it cause disease? So here we're looking at a diagram of the different stages of syphilis. And we want to take what we know about the bacterium and what we know about the disease to inform diagnostic tests and vaccine development. We'll start with looking at our syphilis diagnostic projects. So what's already being used? So what are current methods for syphilis diagnosis? They're primarily indirect serological tests. So this means they're detecting the host's antibody response to infection. There are treponemal tests. So these detect specific antibodies to T. pallidum. The issue is these are unable to differentiate active versus past infection because people will have these antibodies even after treatment. And there are non-treponemal tests. The issue here is these are detecting non-specific antibodies, so they're prone to biological false positives. And confirming a case of syphilis requires the use of both a treponemal and a non-treponemal test. So you need two tests, and the results of these two tests can be complex to interpret. There are some point-of-care tests available, but again, they can't differentiate active versus past infection. So what we're looking to do in the Cameron lab is to modernize syphilis diagnosis by developing a direct diagnostic test for syphilis. So a test that would directly detect the bacterium instead of the host response. So we start, I'm going to walk through a workflow for developing these tests. So we start with what we know about the bacterium. And what people have shown is that certain proteins from T. pallidum can be detected in clinical samples from individuals with syphilis. So we've studied these proteins further to identify what we call proteotypic peptides. So these are shorter amino acid sequences on these proteins that are completely unique to T. pallidum. So they're not found in human proteins and they're not found in other bacteria. We've then developed monoclonal antibodies that are specific against these peptide sequences. So they bind these peptide sequences. And we use these monoclonal antibodies along with collected patient samples. And the idea is that these monoclonal antibodies will bind these T. pallidum proteins if they're present in patient samples. And this use of the monoclonal antibodies in this assay is really important because it allows us to enrich these T. pallidum proteins from the samples. And this gives us a better chance of detecting these bacterial proteins that might be present at low abundance in clinical samples. And we have two ways that we can detect these peptides. One is using mass spectrometry, and the second is using an antigen capture-based assay. And that's an assay that we're looking to develop into a point-of-care test that could be used globally. So on the next slide, I'll show a bit more about how that antigen capture test works and some results from our preliminary pilot study. Okay, so if we start on the left of the slide here, we're looking at how this assay works. So it uses a pair of monoclonal antibodies, so the blue antibody and the purple antibody. And these both bind the same protein from T. pallidum, just at two different locations. So the first antibody is used as a capture antibody. It's coated at the bottom of a well. You then add a clinical sample, and if this protein from the bacterium is present, the antibody will bind it. We then apply a second antibody as our detection antibody. It will also bind this protein and allow us to detect that this interaction and binding has taken place. And in the assay we've developed, these antibodies are against a T. pallidum protein called TP0369. So on the right, we're looking at results from this pilot study where we've used this antigen capture assay to screen 14 different plasma samples from different locations and from individuals at different stages of syphilis. And what I'm outlining in the orange box here is where we've been able to use this antigen capture assay to successfully detect this diagnostic protein in plasma from 4 patients. And we're currently working to further optimize this assay to enhance its sensitivity, and then to also expand it to use with different types of clinical samples. All right, so I'm going to switch and talk a bit about our syphilis vaccine development project now. So starting with a bit of background about prior vaccine trials. So the one I mentioned from the 1970s, it used whole treponema pallidum, which is an impractical vaccine. It had a really impractical vaccine schedule, and as I mentioned, hasn't been reproduced. More recently, people have used tested subunit vaccines. So these use individual proteins from the bacterium. They do provide partial protection. The issue here is that producing some of these proteins in the lab can be difficult and might be incompatible with manufacturing constraints for producing a vaccine. But we can look at what we have learned from these prior vaccine trials. So first, we know that proteins on the surface of the bacterium that interact with the host are important vaccine candidates. We know that it's going to be important to conserve the structure of proteins produced for a vaccine so that they look the same way when we produce them in the lab as they would when the bacteria is making those proteins during infection. And we're probably going to require multiple proteins in a vaccine. And what we're trying to do is to develop a vaccine that's going to do two things. So first, we want a vaccine that will prevent local infection. So this means it would prevent the development of the lesion during primary syphilis, so that T. pallidum can't be transmitted person to person from this site. And then we also want a vaccine that will prevent disseminated infection. So preventing T. pallidum from spreading within the body of an individual. So that would prevent it, for example, from crossing the placental barrier to cause congenital syphilis, or prevent it from crossing the blood-brain barrier to cause neurosyphilis. So this is what we call our two-pronged approach to vaccine development, trying to prevent local infection and disseminated infection. So our collaborators at the University of Washington have identified two vaccine candidates. These are proteins from the bacterium. They're called TPRK and TPRC. And these vaccine candidates, they've shown, are able to prevent this localized infection. And then at UVic, we've identified a third vaccine candidate. It's called TP0751. And this protein, when used as a vaccine, is able to prevent disseminated infection. So now what we want to do, it can be difficult if we don't want to have to produce 3 different proteins to use in a vaccine. So we want to use protein engineering to now combine all 3 of these vaccine candidates into one vaccine, into one protein we can produce. And what we're actually able to do is use one of the vaccine candidates, the protein TP0751, as our scaffold for this protein engineering. So TP0751 is conserved among T. pallidum strains. It has this really stable protein structure. So similar proteins are used in other vaccines, and similar proteins are used in other protein engineering applications. So here, what we call these proteins we produce, we call them chimera proteins because they're incorporating pieces of different proteins. So here we're looking at, in the middle, our TP0751 scaffold protein. And what we do is use protein engineering to take epitopes from our other vaccine candidates. So those are orange and blue. And we add these into the loops of this protein structure. So this allows us to produce a single protein. We can produce it at high yield, it's soluble, stable, and has endotoxin levels below the FDA threshold. So work that is currently ongoing in the lab is along our chimera production pipeline. So we started with chimera version 1, which I just showed on the last slide too. So this is where we used our scaffold and then added in 3 epitopes from 2 other T. pallidum proteins. We've then done additional epitope prediction, and now we have a chimera version 2. And this now incorporates epitopes from 7 different T. pallidum proteins. And this chimera expansion is where our work currently is, and future work is looking to explore different formulations for this vaccine, for example, a subunit or an mRNA vaccine. So to summarize, what we do in the Cameron lab is we use what we know about the bacterium and the disease syphilis to inform biomedical innovations. For our direct diagnostic test development, we can successfully detect T. pallidum proteins in easily collected patient samples. Our goal is to then multiplex this assay, so we're detecting multiple proteins, and then to develop this into a point of care format. For our syphilis vaccine development project, we've produced a single chimera construct that now incorporates multiple protective epitopes, and we're working on the best formulation for this chimera. And throughout these projects, we really try to prioritize manufacturing requirements. So what are we going to need to actually use this as an application, and to also develop platforms that can be used globally, such as a point of care test. And with that, I'll thank all of our collaborators on these projects, our funding sources, and thanks for your attention and looking forward to questions.
Thank you very much. That was quite the production. Now we'll shift gears from syphilis to legionellosis, or Legionnaire's disease. Craig Dirksen is the Executive Director for Shared Health's Capital, Clinical Engineering, and Facilities Management portfolio. His career has always been in healthcare, and he is a member of several Canadian Standards Association technical subcommittees, including healthcare, heating, ventilation, and air conditioning. So Craig is a vital member of our infection prevention and control group, always jumping to the rescue with something, a rabbit to pull out of a hat somewhere. So Craig's presentation today is going to be controlling Legionella in the healthcare environment, facilities, water management. And for those of you who can rewind the mental videotapes to the 1970s, you'll hopefully be able to hear the words Legionnaire's disease. And thankfully, with good facilities management and control measures, we've been able to keep the word Legionnaire's disease out of common vocabulary. So Craig, the floor is yours.
All right. I think everybody can see the screen and hear me. So thank you, John and team. It's great to be presenting again at Bug Day, knowing that together our clinical teams and our support teams, which deliver and take care of our buildings, the old ones, the new ones, we work together, supporting care, and never were negatively impacting that care environment. So on today's topic, it first has to be stated that Legionella exists naturally in many water sources, and hence it can carry on into our building domestic water systems. Now, municipalities don't like that, don't like to hear that. They won't state or acknowledge that they have Legionella in their water, but our water systems are closed loop. We get something from our municipality, and then from there, we need to control it. And once our piping is contaminated with Legionella, we are at risk. So we aren't adding anything in that hasn't already been given to us by our municipalities. However, our water distribution systems can amplify this bacteria by allowing its growth or even promoting its growth. And this is due to two key factors: water temperatures, which can provide an ideal temperature growth range for bacterial growth, and low water flows that allow the buildup of biofilms, stuff that's just coming out of our water. And it attaches, and that really just helps support the growth in our piping system. So now, Legionella are bacteria which are found in nature, and particularly in aquatic environments. They tolerate a broad temperature range, although below 20 degrees Celsius and above 46 degrees Celsius, these bacteria are dormant. And if we get above 60 degrees Celsius, they will not survive, and they will be eradicated. So in Manitoba, where our municipal water temperatures coming into our buildings is between 5 and 10 degrees Celsius from our municipalities, we're generally good on our cold water systems. Even in a large building, what can happen is the pipes and the cold water pipes run through the facility in a long way. We may get up to room temperature, but even at that, we're just beginning to get into the area where Legionella may grow in our piping. The challenge comes on our domestic hot water side, where up to 46, we can actually be promoting bacterial growth. So keeping our temperatures above 46 degrees would be desirable, but that moves us into another problem: the risk of scalding skin in minutes and even in seconds. Hence our dilemma. And you look at this quick chart here.
we often used to run our water temperatures up to 60 degrees Celsius to be able to kill that Legionella. Problem is, if anybody gets exposed to that hot water in and of itself, 5 seconds and we have a 3rd-degree burn. So quick Legionella history, and John alluded to it. Legionella was first identified and subsequently named to recognize an outbreak that occurred in 1976 in Philadelphia at a Legionnaires' convention, where it was suspected that the hotel water fountain, or could have been the building's ventilation system, infected 221 members, 34 of them who succumbed to the disease, the Legionellosis disease. That's a 15% fatality rate. Well, this was the first time it had been identified as an individual bacteria. Retrospectively, it's been agreed that it's probably been since at least the 1950s that we've had outbreaks, possibly even earlier. Now, if there's good news related to Legionella, as opposed to, some other waterborne diseases like E. coli, Cryptosporidium, Giardia, is that Legionella almost always has to be inhaled to cause the disease. It's a respiratory disease. So it's not ingestion of water with Legionella, but rather through aspiration of contaminated water. Now, where do we see this aspiration occurring? Well, it happens in our sink taps, which have a laminar flow screen. It happens in shower heads, hot tubs, hand wash sinks, therapy pools. It's even been attributed to spray off of toilets. The other is on our heating and ventilation systems. We have large cooling towers that are attributable to a lot of the challenge in public settings. And then also sometimes people still use domestic water-based humidification systems. And some of you may even have one of those type of humidification systems at home where there's a drum that rolls around through water. Watch that. Very challenging. So now there are hundreds of cases internationally each year that occur, some with low mortality rates, others, particularly with health, with at-risk populations like we have in healthcare, or as it was discovered in 1976, an older population of a legion at a Legion's convention with the elderly are at high risk. Now, worldwide outbreaks are significant with varying impacts. In the US, they believe they've had 10,000 cases in 2018, and that number is felt to still be about 2 to 3 times underreported. A lot of times it gets attributed to other pneumonias, Pontiac fever. The US averages about a 9% mortality rate on those infected. Now, when you are infected, it's a 2 to 14-day incubation period until it can be until it develops. And so therefore with that, it's really a challenge to determine the source. We have a very mobile society. Where were you the other day? I was on a plane coming back from Quebec City yesterday. So was I exposed in Quebec City? Was it the fountain, or was it some other water source? Now, rates in the United States, as this graph shows, have multiplied since 2000, where it was a half a case per 100,000 people to over 3.5 cases per 100,000 people by 2018. And it's begun to taper off, but that was a 9-fold increase. Now, PHAC reports that in Canada, we only have about 100 cases a year. However, current in 2025 in Ontario this year, they've had 296 cases reported, largely driven by an outbreak in the Middlesex, London, Ontario region, where they've had 106 cases. All of those cases, those 106 have been tied to a cooling tower at a meat processing plant that that was not managing its water there. Ontario has an average rate of 1.8. Still, at that rate, it's half of the United States' current rate. But that London Public Health Unit was up to 17.7 cases per 100,000 people. Concerning was that 71% of those people were hospitalized. Now, Manitoba averages around 3 or fewer cases. In fact, from 2000 to 2013, over those 14 years, there was only 32 cases reported, and that included some cases that came out of an outbreak, or at least positive results and possibly some outbreak in 2016 at the Victoria Hospital. It was actually tied to the new oncology unit there, coming off of their hot water system. Going way back, and yes, even as far back as years that precede John Emble and I starting at Health Sciences Center, in the very late 1980s, the rehab hospital at Health Sciences Center had an outbreak. So while I would like to talk about water quality issues as a whole, all of the coliforms, E. coli, Legionella, crypto, turbidity, taste, we're only going to focus on Legionella. Why? It's because in our healthcare settings, our long-term care settings, and even in some public health settings, we're doing two things. One is we're caring for people who are immunocompromised or whose health conditions make them susceptible to being infected. And secondly, we have many aspiration sources in healthcare, sinks that we're putting into each one of the rooms, patients who require showering, and then in some cases, we have large building chillers that are very close to the hospital setting. We'll touch on that again at the end. So now, why are we seeing more Legionella cases since the 1970s? Well, couple of reasons. First of all, I guess I've been able to identify it. But secondly, we lowered our hot water temperatures because we began to say, oh, we need to conserve energy. And then we needed to lower the temperature because we needed to prevent scalding. Well, both of these things moved us down below 40, into the 46 degrees Celsius range or lower, and we ended up into that growth risk category. Oh, we've been conserving water, so we've gone to lower flow taps and toilets and shower heads. So now we have more biofilm residing inside of our pipes. That's just a harbor. That's just a growth zone to support bacterial growth. We have more patients in our hospitals who are in immunocompromised states. Our building systems are more complex. Sometimes they're designed more complex. Sometimes over the life, as we've renovated our buildings, we've cut this, capped that, and we haven't necessarily resized and managed dead legs on our piping. So as owners and operators of facilities, we need to do a risk assessment plan, then develop a water management plan. And today's whirlwind points, here are just a few key elements, but the first one I want to state is that the presence of Legionella bacteria in your water system is not in and of itself sufficient cause to say, well, then we have Legionellosis in our patients. It needs growth factors, and it needs to be transmitted, aerosolized, inhaled, in order to create this. So now it seems that every time I present at Bug Day, I bring out the hierarchy control, and there's a few reasons. First, I'm an engineer, so just as clinical training is as much about a process as it is about specific clinical knowledge, engineering is similar. We have training on a particular discipline, but we also have a process of thinking. So when we have a hazard, say water quality, in this case Legionella, we can control it in one of 5 ways. The hierarchy of control for Legionella would look something like this. Well, can we eliminate the Legionella from the water? Very challenging, could be possible. Well, should we avoid tap water, and should we use some special clean water substitute? Maybe. Can we stop bacterial growth? Possibly. Can we kill the bacteria? Oh, yeah, there's choices. Can we eliminate aerosolization? Well, we certainly can look at that. Those are our engineering controls. What administrative controls can we use? Well, keep immunocompromised patients away from aerosolized water. We used to not shower our patients in those types of units. And could we even, on a PPE standpoint, could we maybe mask our patients to prevent them from inhaling? Now, there are several key resource documents for developing a water management plan. In other words, these are the tools which your building facility staff should be using in working with your clinical team, your infection prevention and control, your chief nursing officer, directors of patient care, even your chief medical officer. They all need to be a part of this. And yes, there's a Shared Health Manitoba guideline as well that speaks to this for the Manitobans who are listening in on today's session. The key point that I must make is that these documents are all about risk management approaches, not the elimination of Legionella. We are identifying a risk. We're not eliminating risk. And then we're managing risk. Again, we're not eliminating it. Just like we do in all of our infection control activities, clinical or in those construction, renovation, and maintenance, we manage the risk that we have. So what do we have to do? What are the key elements that come from all of these documents? Let's condense this down in just a few slides and some notes. So the bottom line is we need to identify our building water systems where control measures are needed. We need to assess how much the risk the hazardous conditions are in those water systems can pose. We need to apply control measures to reduce, underlining reduce, not eliminate the hazardous conditions. And we need to make sure that our program continues to run. I'm going to move really fast here. This is a plan, do, study, act, or some people would say adjust strategy. This is an excellent chart from a CDC document, one of those reference documents. And when you get the slides, you can look these ones up. So firstly, who in your facility is aware of these risks and who is responsible? You need to form a team if needed, or maybe it's clear responsibility. That moves us then into the next steps where we begin to describe those building water systems and identify and assess our hazards. And that's the next step. And are our patients in our facility critical? Are they immunocompromised? Do they have cancer diagnosis and treatment? Or is their current health condition something that puts them at risk? The risk also depends on the setting. Patients attending a clinic are unlikely to be exposed to aspirated water. So the risk is probably considerably lower. We also need to assess the piping distribution, the type of hot water distribution, determine are there any particular building challenges? Are you in a building that used to be an inpatient unit that used to have washrooms for patients in each room, but now you're using it as some type of a clinic? Maybe the oversized piping is not seeing good water flow and we're seeing biofilm build up and low water flow. Those could be raised concerns. We then need to look at our critical control points. Where would you measure? If you're going to regularly test, where would you do that? When you flush your piping, how are you going to do that? Are we always going to test, or are we going to rotate at the same location, or are we going to rotate through different locations if we test? And what's the frequency? What will be normal? And then what happens if we start to see positive results? So what are the control measures when we have water issues? I can't dive deep here, but the first step is not to go out and buy something. The key is follow your plan. Most large facilities, particularly those with patients or residents, will have a recirculating domestic water system. If you do, that has the advantage of keeping the hot water piping up to temperature, which is a good thing and keeps you out of that can keep you out of the Legionella growth zone. If you have a recirculating system or not, do you know? Well, when you go in the morning, if you're the first person in and it takes 2, 3, 5 minutes to get hot water, then likely you don't have a recirculating system. But if it doesn't take too long, you likely do have it. Is your facility monitoring temperatures? Is it automated? Do you have a building automation system that automatically alarms to your staff? Do your staff regularly flush the system? And I don't mean weekly. I mean on maybe every 6 months. Do they flush the hot system, the cold system? Do they check the hot water tank? Do they flush and inspect those tanks? If you have a very high risk facility or a facility where you've had Legionella in the past, whether persistent or intermittent, you need to then consider some of these engineering approaches. We have chosen, we kind of like the low maintenance copper silver ionization systems. We have several at Health Sciences Center and a few other sites in Manitoba. But again, we don't just put them in carte blanche. I get asked often, oh, can I have $100,000 to put a system in? I go, well, what's your water testing results? And they go, we don't do water testing. I said, so then you don't have a Legionella problem because you don't know that you have a Legionella problem. You need to get a water management plan first. And just into the last slides here. So when you do determine to test, there's a question of how frequently and what are the thresholds? Well, there is no exact number for a threshold, assuming you've never had any previous clinical evidence of Legionella. But due to your risk assessment, you need to do testing. You're going to set up a frequency. Maybe it's quarterly to start with. And then depending on results, if you never see results, you can maybe move to every 6 months. If you do see results on a regular basis, you maybe need to go more frequently. In complex sites, you may want to go to you may have more than one hot water system. You may also, so you'll have separate testing plans. You may also, in some larger systems, have a bunch of end runs, distal locations, different risers. You're going to want to test those at different times and samples. So what happens when you have a positive sample? Well, I usually email John Emble, but you need to talk with your infection prevention and control folks. You need to then enact your water management plan. You need to know what are your next steps. Do you begin to perform testing? Do you screen and observe? When do you flush the system? How are you flushing? Do you use heat? Do you use chemicals? I think the first step is just going with flushing, and then you follow up later with testing once the system stabilizes. You need to check to make sure that your system controls, your hot water tanks are maintaining temperatures. Are they calibrated? Are all your pumps working? And then there's the end question, are we going to start screening patients to see if they have legionellosis, so that we get ahead of the curve on that? That needs, of course, to be a clinical medical decision. So the final notes and takeaways, these 4 points on the slides are the keys. Even if you determine not to test, that is your plan. And you need to monitor it. You need to look, is there clinical evidence? And yes, in 15 minutes, I can barely scratch the surface. So don't forget those large cooling towers. If you're one of the facilities, one of the few larger facilities that have central chiller plants and then central cooling towers. If those cooling towers are close to your patient building, you need to ensure that your facility folks are using a Legionella control chemical in the cooling towers. It can tell you in Manitoba, all of the sites, and so those sites would be sites in the big hospitals in Winnipeg, and Brandon all have cooling towers, and I know they all have access to use those chemicals. And then check, are you humidifying air, and how are you using it? If you're using steam, it's not an issue. If you're using reverse osmosis, it's not an issue. Those are the approaches and the items that you need to do. So that, I think, is it.
Well, thank you. So now why don't we transition to a few questions and answers. We'll pull up the questions from Slido. So, for this session, there are loads of great questions. We'll begin with the first one. So, when do you potentially expect a vaccine for syphilis?
Yeah, so we're still in the stages of developing our vaccine candidates. And so the work on the proteins and the different formulations is expected to take 1 to 2 years. And then after that, we still need to do preclinical tests. So in the rabbit model, those will take 2 to 5 years before we could get to the point of doing actual clinical trials with a vaccine candidate. So work is ongoing, but not an immediate availability of a vaccine.
So I'm going to ask you sort of a side question. Treponema pallidum and Borrelia burgdorferi are both spirochetes.
Mm-hmm.
There was a Lyme disease vaccine, or maybe there is a Lyme disease vaccine for animals.
Yes,
what has been the major challenge with syphilis? Because if we've created something for dogs, or is it the market? But you'd think that with the explosion of syphilis in North America, and particularly in Canada, we'd be inching closer to some form of eradication or preventative measure.
Yeah, I think a lot of that has to do with like a historic underfunding of the field of studying syphilis. STIs come with a lot of stigma. And then just the fact that T. pallidum is really difficult to work with. So like I mentioned, it was only 2018 that we had this method to even be able to grow it in the lab. So you can think of, it was discovered early 1900s, and then not till 2018 that we can grow it consistently to study in the lab. And even then we still have to grow it with mammalian cells. So you have these background contaminating proteins. So it really just complicates all lab experiments that you want to do with T. pallidum. So it's really complex to work with. And then, yeah, there's only a handful of labs around the world that actually work with the bacterium. So just less knowledge in the field about T. pallidum and what we can use as vaccine candidates.
Thank you. So the next question is a dilly, and it says, say I have a very ill child in my clinic, private one. I think he has measles and need to send him to children's ER. would we as private clinicians be expected to notify Shared Health, i.e. measles in our clinic, or who should we notify? When should you be notified? What should we do with child/ER? Okay, great question, and it's a monster. And the reason it's a monster is that there's many levels of notification. Thankfully, we're not at incident command level yet, but the very simple steps are: you call emergency, you say that you've got a potential measles. Once that child gets to emergency, a mask is put on the child, they're put in an isolation room, and then whatever investigations are required are taken from there. You, as a private practitioner, will notify public health, and public health will work with you to do contact tracing and hopefully resolve the problem. And that, in a nutshell, is what will end up being a very big undertaking. Okay, the next question. Can environmental services teams assist with mitigating Legionella outbreaks, perhaps work collaboratively with facilities management maintenance on some strategic drain treatment, I guess, plans?
Preventive maintenance plans, I think, is
Oh,
where.
preventative maintenance plan. Okay, there you go.
I have not seen much. I've not seen anything in literature that talks about Legionella coming from the drains, from the drain lines. There's certainly other things of concern that have been talked about coming out of drain lines through that. Primarily, it's the more aspiration that occurs. So through a tap, it's the aspiration that is occurring through the tap, not so much the splash, the specific splash out of the drains. I could be wrong. Now, do we need to look at drain treatment? There's lots of talk about that. There's CSA standards that say that we should be doing that. We're going to be trialing some products that will, like, there are some chemicals out there that can help with that. And the other is there's now some automated systems out there that are looking at that. So, but should EVS be a part of mitigating Legionella outbreaks? I'll say yes, because EVS should be turning on every tap every day. So even if a shower isn't getting used, even if a tap isn't getting used, that sink should be getting cleaned every day. So that assists in mitigating, because we're getting water flow through each of the pipes, and they can also help report when there is any discoloration in the water, which is another good indication of problems.
Thank you. I'm going to ask, although the question isn't here yet, but the question for Jeff is, what did you, and I probably should say, what did Shared Health learn in terms of incident command from the COVID-19 pandemic and how we handled the pandemic? Oh, we can't hear you.
Okay, there we go, John. Well, I think the lessons learned out of COVID-19 was how we intersected with each other on all levels of command. So as we are aware, in the COVID-19 scenario, we had a provincial command that was led through Dr. Rusin and CEO Lynette Saragusa. But we also had commands activated at regional levels, at site levels, and how all those intersected to respond to the events was what I think the biggest takeaway was, and how we made sure that those intersected and worked together throughout a command activation. I think that was the biggest one from an ECM point of view. There's certainly other takeaways around command, around how fast information was coming through, and how we managed the command structures to get really quick decision making done, because the information was changing so quickly through COVID that as they got down to the different command levels, it was like almost like new information was coming in between operational periods, and it was hard to keep up with all that information. So there's some lesson learned around that. But in general, I think from the program perspective for emergency and disaster management and contingency management for Shared Health and others, it really, I think, highlighted education for folks around the importance of command. And prior to COVID-19, and that command lasted, what, I don't know, 3 years, 4 years almost, or not quite, but a long, long time. And so people really got familiar with the structures, the way that they work together. So going forward now, we have a pretty good sense as to how that works, and people aren't in the dark around incident command, what it means and how it's activated and used.
No, certainly. The word incident command is not foreign to any of us. So a Craig Dirksen question. What are some basic strategies to look into water testing, drains, etc., as a baseline in smaller rural hospitals? How can this be communicated to frontline staff of how to decrease biofilm growth? Oh my, that's I think that's a PhD thesis in evolution.
Yeah, I think it gets a little deep there. So the first part of the question, what are the basic strategies to look into water testing as a baseline in small rural hospitals? It's actually the same if it's a small hospital or a large hospital. You need to take a step and say, what's my water management plan? What are the types of patients that we have in this facility? What are the risks that we have in this facility? Water temperature, type of piping distribution, and the like. The second part, how can we communicate what is our plan to decrease biofilm growth? Other than saying run your tap a lot and try and flush the water, getting old biofilm out of piping is not going to come because I open up a tap. It actually is going to take your plumbing staff to get involved. And, you know, if you have a large 2-inch water line serving it, they're going to have to pipe and try and flush it out. There are pictures that we could show at a point in time of, you know, a large 2-inch pipe in any building that actually is only about 1 inch or 3/4 of an inch open in the center because of all the calcification and all the biofilm. So don't know that there's a lot the frontline staff can do other than, I'm going to go back to the same thing with EVS. If you're noticing brown water, if you're noticing odors or weird tastes, report that into your facilities group and get them to work towards that. So, but it all starts with having a water management plan, and that isn't a big servitude type document. It's a document that just guides and says, this is who's responsible and this is how we communicate. And when we have positive samples, which I can tell you from my years at HSC, we have had positive samples. We don't run around like chickens with their heads cut off. Got to use that one in here. But we go through the steps and we move forward, and we ask our clinical team to conduct vigilance as they deem necessary. And then we move forward. Some of our events have taken 9 months to get out of until we finally felt that it was clear. So that's why it takes having a very well documented plan.
One last question, and hopefully a real short snapper. And I hope the answer is going to be yes, we do. So for Jeff Martin, is there a plan/standard operating protocol for province/shared health emergency response coordination with the Canadian Armed Forces in the event of a major emergency on CFB Winnipeg?
Canadian Forces Base, I'm assuming that is.
Yes, Canadian Armed Forces, yes.
The short answer is specifically no. In general, with command activation, yes. So a good example would be, we just did an exercise with the Airport Authority, for example, Winnipeg Airport Authority, around a plane crash. We certainly have protocols around response to a specific event that happened at the airport. It would be fairly similar likely at CFB. Again, it depends on what the incident is, but in terms of the health lens and responses to specific areas within the city, we're fairly well set up to respond through a command structure and an operational structure for whatever it may be. Do we have specific SOP? No. Do we have an ability to respond effectively? Yes.
Thank you. That was the perfect answer. Okay, we will shift gears. Thank you, Mara, Craig, and Jeff. Outstanding presentations. So let's shift gears, and we'll now head into the next group of 15-minute presentations. The first of these will be hyperbaric oxygen facts and myths. Yoav Keenan will present this presentation, and Yoav is a professor of medical microbiology and infectious diseases at the University of Manitoba. He is the section head of adult infectious diseases and the scientific director of the National Collaborating Center for Infectious Diseases. Yoav will, of course, tell us why he is ultimately the ideal person to speak about this, given his background in dive medicine. So Yoav, the floor is yours.
Can you see my screen now?
Yes, perfectly, but if you can do the presenter mode, that'd be great.
Yeah. Okay, good afternoon, and this is a talk about hyperbaric oxygen. I would like to start by thanking the organizers for inviting me to speak about this, and thanks specifically to Dr. Emble and his team for the 70th anniversary for Bug Day. It's an incredible accomplishment. I'll talk about hyperbaric medicine myths and realities. Based on my experiences as trained and practiced in hyperbaric medicine and diving medicine, and delivered training for healthcare workers in that field in my past life. I don't have any relevant conflict of interests for this talk. Okay. So today I'll talk about what is hyperbaric oxygen therapy, what are some of the physical principles of hyperbaric oxygen, how it is administered, what are the indications for use of hyperbaric oxygen, as well as risks and complications associated with hyperbaric oxygen therapy. I have some trouble advancing the slides. Okay, hyperbaric oxygen therapy is medical treatment delivering 100% oxygen at increased atmospheric pressure inside a specialized chamber, with the aim of elevating dissolved oxygen levels in the plasma far above normal. This is an example of a hyperbaric multi-space chamber that can be used by multiple individuals, and also is adapted to delivering complex therapies for hyperbaric oxygen. How does it work? It works based on physical laws, and I won't go into the many formulas, but the laws, the important laws are Boyle's law, Henry's law, Charles' law, and Dalton's law. And I have a cartoon to try to explain those. So the orange bubble that you see here is explains Boyle's law that states that with increased pressure, the volume decreases. So if you increase the pressure from 1 atmosphere to 2 atmospheres, the volume is decreased by half. Dalton law is the total pressures are the sum of the partial pressures. And Henry law is the one that is very important in hyperbaric medicine, because the amount of the dissolved gas is in a correlation with the partial pressure of the gas. So if you increase the pressure, for example, in hyperbaric chamber, you can increase the pressure to 2.8 atmospheres, where you have enough dissolved oxygen to supply a resting human body. Charles' law is the relationship between volume and temperature. And all of those together are what shape the physiology of the use of hyperbaric oxygen, where we rely on hyperoxygenation to restore tissue oxygenation in ischemic and hypoxic states. Hyperbaric oxygen produces vasoconstriction that reduces edema while maintaining oxygenation of the affected organ. And angiogenesis and wound healing happen with prolonged exposure to hyperbaric oxygen, as it stimulates blood vessel growth and tissue repair. The seminal paper that basically carved the way for or paved the way to hyperbaric medicine is by Boerema in 1959 at the Journal of Cardiovascular Surgery, where they placed piglets in a hyperbaric chamber and exsanguinated the pigs, basically replacing their fluids with ringer lactate and plasma. They did it at 3 atmospheres pressure. And the piglet survived for 45 minutes without having red blood cells, so that the paper was life without blood. And from there, developed lots of practice of hyperbaric medicine, and the Undersea and Hyperbaric Society defined hyperbaric oxygen as a medical procedure that is critical, that requires physician and prescription and oversight. All patients have their entire body placed within a hard-sided hyperbaric chamber, and the American Society of Mechanical Engineers and Pressure Vessels of Human Occupancy need to approve by code. National Fire Protection Agency codes and standards of hyperbaric chamber all need to be applied to deliver safe hyperbaric therapy. At a pressure of no less than 2 atmospheres, while breathing, a physician prescribed medical grade oxygen, and generally the treatments last between 90 and 120 minutes. In the US, this is a discipline of hyperbaric medicine that is recognized by the American Board of Emergency Medicine and the American Board of Preventive Medicine as warranting status of subspecialty. There are indications that are approved for use of hyperbaric oxygen therapy and include acute and chronic indications. In the acute ones, there are diseases and entities that are caused by bubbles, and we basically use the Boyle's law that you saw before to decrease the size of the bubble and to improve oxygenation based on Henry's law. And those are air and gas embolism, for example, and decompression sickness. The other indications that benefit from delivering hyperoxygenation to ischemic tissues or tissues with poor supply, or for changing carbon monoxide half-life. Chronic indications are more in the arena of insufficiency and because of occlusion or delayed radiation injury, as well as some chronic bone remodeling treatments, such as vascular necrosis and osteomyelitis. Health Canada basically copy and pasted the indications by UHMS, and so I won't go into all of them. They are not really different. The types of chambers that can be used to deliver hyperbaric oxygen are monoplace, where you place an individual into a sealed compartment with visual and audio contact so you can monitor the individual, as opposed to a multiplace that you can place multiple individuals and have slightly different breathing conditions for each individual and modify it according to their needs in one session. And those chambers are also able to accommodate more complex patients that require support staff attending with them, including healthcare providers, including in some extreme situations, which I had the privilege to work in the past, to deliver mechanical ventilation, etc. Those require specific equipment that is not the regular equipment that you will see in an ICU in the hospital. What are some of the indications that are relevant to infectious diseases? It's bug day after all. So first I'll talk about clostridial myonecrosis. What is it? It's a rare, rapidly progressive muscle necrosis. Systemic toxicity accompanies and is associated with high mortality rate, generally caused by Clostridium perfringens and other species. And it frequently follows traumatic wounds or post-operative and iatrogenic injuries, but can sometimes occur spontaneously in the immune-compromised. The standard of management is surgical debridement and broad spectrum antibiotics, and it frequently requires intensive care support. Hyperbaric oxygen affects Clostridium that is not able to thrive when you increase oxygenation, and it's generally a strict anaerobe organism, and increasing the oxygen tensions inhibits the growth and toxin production by the organism, and it enhances oxidative killing by neutrophils while reducing edema and facilitating oxygenation of the tissue. In cases that we treated, what you see is better demarcation of the dead tissue from the live viable tissue, and it allows and aids the surgeons in in debriding the tissue until they encounter viable tissue. The evidence comes from case series and retrospective analysis, no prospective trials. In some of them, up to 50% improved survival. The problem is it's small numbers and inherent biases there. I gave one of the references. Another infectious disease indication that is in those 14 indications that I showed you earlier includes necrotizing soft tissue infections. That is based on case series and decent-sized prospective studies, as it's a more common entity than the previous one, the Clostridial myonecrosis. Results are variable because variable infections with different anatomies and microbiology are included in the series, and variable antimicrobial and surgical approaches are applied. And those are critical and make a difference. So some show increased salvage of limbs and better ICU outcomes when hyperbaric oxygen is used as adjunctive to antimicrobial and surgical therapies. But there are some studies that have shown even increased mortality that is attributed to the delay in the most important component of management, which is the surgical debridement. And I direct you to the study by Shupak that showed in 37 individuals, those that the 25 that were given hyperbaric oxygen fared less well than those that didn't. Like any other medical therapy, it has complications, and those can be divided to those related to pressure, and those related to oxygen toxicity. In the pressure-related complications, middle ear barotrauma is common. It can be associated with ear pain to perforation of tympanic membrane. Sinus barotrauma is associated with facial pain. It happens during any individuals who have upper respiratory infection or allergies. Pulmonary barotrauma with a pneumothorax is a risk. Dental barotrauma, when there are incomplete fillings, reports of teeth collapsing. So that is also an important component. And the prevention for all those is slow pressure changes, slow increases and slow decreases. Oxygen toxicity, as CNS or central nervous system toxicity, can lead to seizures. And this is directly correlated to how high the pressure is. And it becomes more common above 2.8 atmospheres, so 18 meters diving simulation can bring about seizures, and it happens more commonly in individuals who already have a lowered seizure threshold, such as in carbon monoxide toxicity or in Clostridial myonecrosis. So people who are septic or who have other reasons why they would be more prone for seizures. Pulmonary toxicity can manifest as cough and chest pain, and there are some ocular effects that are reversible, including myopia. Metabolic effects include hypoglycemia because oxygen increases the consumption or use of sugars. And the prevention for that is limiting the duration of treatments and providing air breaks generally after 45 minutes of breathing hyperbaric oxygen. In addition to those, the chambers may be, especially the smaller chambers, may be associated with claustrophobia, anxiety, and thermal discomfort as you feel more warming when the pressure is increased and cool when decompressed. It causes vasoconstriction and can trigger decompensation of congestive heart failure, and it's contraindicated in an existing untreated pneumothorax. There are additional risks, and the American Medical Association recognizes it as a practice of medicine, therefore, and requires chamber design, safety, and inspections to be regulated, proper training and credentialing of staff that operate the chamber, strict prohibition of flammable materials and products that produce vapor because of extreme risk of fire. And that includes individual patients' garments. You need to replace and not allow any street clothes within the chamber because of the risk of oils and other things that may elicit fire. And patients must be continuously monitored throughout the session. And all staff must be trained and to manage rare but potentially catastrophic emergencies. Reminder of that was this year in the US, Thomas Cooper, a 5-year-old who was killed in an explosion of a hyperbaric chamber, injuring his mother's with him. In summary, hyperbaric oxygen therapy is a medical procedure procedure that requires equipment training and protocols, requires maintaining skills in it. There are established indications for use, and the mechanism of action can decrease bubble size and improve tissue oxygenation. The field is plagued by limited prospective trials that make the level of evidence supporting the indications problematic, and it can be useful as an adjunct therapy in selected infectious diseases. There are potential harms that are the effects of pressure, the oxygen toxicity, and the risk due to the flammable nature of oxygen-rich environment. And with that, I will stop.
Thank you very much. Interesting. And I'm sure there'll be lots of questions. So I do hope that Marissa Azad has joined us. I see her name. So Marissa is going to give us a very interesting presentation entitled "The First Use of Bacteriophage or Phage Therapy in Canada for the Treatment of a Periprosthetic Joint Infection." So Marissa is a specialist in infectious diseases at the University of Ottawa. Her research interests focus on the diagnosis and therapeutic strategies for the management of prosthetic joint infections. Marissa recently led Canada's first successful treatment with bacteriophage therapy for the management of a prosthetic joint infection. So, Marissa, the floor is yours.
Can you guys see my slides?
Yes, but please put it on presenter mode.
Okay, give me
Perfect.
1 second here. Is that good?
Perfect.
Okay. Thank you so much, Dr. Embel, for inviting me to be here. There's been some amazing talks today. We have a lot to cover, so I'll just jump right into it. These are my conflicts of interest. So I'll start by discussing my approach to orthopedic infections and my clinical practice. And then we'll jump into what phage therapy is, and then we'll get into our single patient trial. So very briefly, implant-associated infections are particularly difficult to not only diagnose from a microbiologic perspective, but they're very difficult to approach from an infectious diseases perspective. But I like to break it into 4 major points. So I like to focus on the microbial niche or the anatomic location of the infection, whether it be an infected hip or a knee, for example. You also have to take into account the implant type itself. So if we're looking at orthopedic infections in particular, are we looking at a titanium implant? Is this a Prostalax spacer, or is this a different type of metal or mixed metal that we're trying to diagnose this infection with? And with every anatomical niche, microorganisms or pathogens will change their microbial expression profiles, and there will be a huge shift in their proteomics to try and exploit that niche and form that biofilm. And then I'd like to zoom out and look at the host patient themselves. So is this an immunomodulated patient, or is there some sort of primary or secondary immunodeficiency? And then lastly, I look at the mechanism of infection or pathophysiology when approaching orthopedic associated infections. So most of us have family members who've undergone some sort of joint replacement surgery. We have an aging patient population as well as an expanded list of indications for joint replacement surgery, not only in Canada, but around the world. And for those unfortunate few who go on to develop this particularly devastating type of implant-associated infection called prosthetic joint infections, or PJI, although the incidence is quite low, it's 1 to 2% of these patients who go on to develop PJI, it's actually up to 15% of these patients who will go on to develop chronic recalcitrant periprosthetic joint infection, or PJI, with each revision operation. And this poses a massive burden on Canadian healthcare systems. I see these patients every week. It's absolutely devastating. They're difficult to diagnose, they're difficult to treat, and I have patients on operations number 10, 12, all the way to 20 plus. And there's a significant associated morbidity and mortality with these infections. And we really need to do more to try and treat them and diagnose them. So this is just 2 examples of plain film x-rays from patients that I see, unfortunately, too often with chronic recalcitrant PJI or joint infections. And as you look at these plain x-rays, you may notice, well, there's not really any joints here. The joints have been completely resected from the shoulder on that left image, and that right hip joint has been completely resected. And this, unfortunately, is a story that I see far too often. We have patients who the surgeons will try to eradicate the infection by removing the artificial joint itself. They will try to resect all peri-implant tissues that may appear grossly infected. These patients also underwent something called sacrosterectomies, where they'll try to resect out any grossly infected or osteomyelitic bone. And even with these patients undergoing multiple resection operations, receiving years and years and years of antibiotics, they still are septic. They still develop infection. They still develop bacteremias and bloodstream infections with the culprit pathogens. For these two patients, it was Staph aureus. So why is it? Why is it that these infections are so difficult to manage? And it's this image here. This is a really nice scanning electron microscopy image our lab took of MRSA, and it's the biofilm. So I don't need to explain to this group what the biofilm is. That's a whole different topic in and of itself. But we have biofilm formation occurring not only on the implant itself, but peri-implant tissues and associated bone as well. So even when you resect everything, you just need one bacterial cell to be left behind. Surgeons don't have microscopic vision, unfortunately, and these infections persist for decades and sometimes lifelong. So if we look at this in a bit more detail, I don't have tons of time to talk about this, but we spoke about the biofilm at the crux of these chronic infections. We have to look at virulence factors, tissue invasion, abscess formation, intracellular infection, the inoculum size, the mechanism of infection. How do these organisms, how are they introduced into the joint space? Is it at the time of surgery? Do you have contiguous spread? Do we have associated bacteremia or bloodstream infection? Then you have to look at the implant itself, the biocompatibility. Do we have appropriate osseointegration of that titanium joint, for example? Do we have too much inflammation, or are we stepping more into foreign body reaction, which in and of itself can promote biofilm formation and cause chronic infection? And then you have to look at things like the hydrodynamics, the cyclical loading of that joint when you're designing these implants, for example, which is something that our lab is looking into. And then the host itself. We have bacteria such as Staph aureus, Salmonella, a variety of other pathogens that can actually be taken up through something called a Trojan horse mechanism into macrophages and other immune cells and be deposited at other joints around the body, even without clinical bacteremia. We also have internalization of these pathogens into bone cells or osteoblasts themselves. And all of this can contribute to chronic infection, evasion of antibiotic activity, evasion of host innate and adaptive immune responses, as well as surgical resection. So what can we do? Because that's quite a grim picture. So our lab is focusing on three major aims. The first is we're developing novel, rapid, and accurate diagnostics for PJI. The second is we're developing new molecules to prevent biofilm formation and new anti-biofilm implants. But lastly, for today's discussion, we're looking at new treatment strategies such as phage therapy. And this is our TEM image of our phage that we used in our first clinical trial. So very briefly, what are phage? So phagein means to devour. Viruses here are ones that can infect and replicate bacteria, and they tend to be remarkably species and or strain specific, which means that they're remarkably non-toxic. Whereas antibiotics tend to be far more indiscriminate. These are very specific to bacteria only. They do not infect human cells, which is part of some misinformation surrounding phage therapy. Phage, I'll touch on this in the next slide, but they, in the environment, allow for a massive exchange of genetic information in microbial communities, which is very interesting. And we're just starting to kind of decipher the indirect and direct influences that phage have on our immune systems. And another aspect of phage, which makes them remarkably safe if you know what you're doing when you're designing them or hunting for them, these are ubiquitous biological entities. We are bombarded with phage all the time, even right now as we give our talks. They're very diverse in structure in terms of size, morphology. There was a cool study done a few years ago looking at 1 milliliter of ocean water on microbial mats containing 9 times 10 to the 8 phage. So these are the most abundant biological entities in our biospheres. Phage structure, this is just a handful of phages in terms of the structures, but classically we know this capsid tail fiber structure, right-hand corner here. We have our capsid head, which contains genetic material and allows for the mediation, the delivery of genetic material into our host bacterial cell. And then we have our syringe-like mechanism with our tail and tail fibers that are attached to the capsid, and they bind very specifically to structures on bacterial surfaces, such as lipopolysaccharide, flagella, porins, teichoic acids, etc. Phage replication, we have 2 major cycles of phage replication. When we're designing phage and hunting for phage for clinical applications, we really want the lytic or virulent type of phage. And we can talk about that later if you have any questions, but it's an interesting point because most of the phage that we find in the environment are actually temperate or lysogenic. So basically, lytic phage, they will take over the host cell machinery to make new phage components. And the newly constructed phage will then burst out of the bacterial cell to infect nearby bacterial cells. And it's really cool because you can get these phage killing waves. So you get interesting pharmacokinetics. And then there's the second cycle where you have lysogenic or temperate phages, which we tend to move away from clinically because we want to kill the infection or lyse the cells. So in this cycle, the lysogenic phage will integrate their genome into the host bacterial cell chromosome, or they'll be maintained as an element. We get replication along that host cell, and we have the phage we passed on to daughter cells without cell lysis. Now you can flip to the lytic life cycle through a variety of environmental stressors, such as pH changes, temperature changes, starvation responses, toxins, etc. And then lastly, very briefly, there's something called pseudo-lysogeny, which is interesting. It can result in theory for chronic infections, and you get new phage produced without cell lysis, which is interesting. So phage functions, I could talk about this for an hour, but in the environment, as I mentioned, phage result in a massive amount of horizontal gene transfer. And as I said before, you have to know what you're doing when you're designing these, because most people think, well, phage are going to kill bacteria, you know, they're great for preventing and eradicating infections. But the reality is that phage can actually encode and harbor a variety of antibiotic resistance genes and can actually confer resistance between pathogenic to non-pathogenic bacteria, which happens in the environment all the time. Temperate phages are associated with microbial fitness. We can actually protect the host from phagocytosis. You can enhance host pathogenicity. You can even enhance bacterial metabolism. And then, of course, there are phage-encoded toxins, such as the C. difficile toxin or botulinum toxin. So you really have to understand how to design these things. They regulate bacterial populations. We have interesting predator-prey dynamics with phage and various bacteria. We have the concept of the healthy gut phagome versus the diseased gut phagome. Phages are even passed down from mother to child, and we're starting to look at what the clinical relevance of that may be. And then, of course, there's phage that can potentially modulate not only the innate immune system, but the adaptive immune system as well. So next, I'll briefly get into our studies. So we just published on our clinical trial, and we're working on another set of clinical trials right now with phage in the treatment of chronic or life-threatening joint infections. So as you can see, this is an X-ray of our poor patient. Her name's Thea. She's a lovely, very brave woman. And you can see that this X-ray in and of itself is showing that we have a very severe PGI should this become infected. She had a life-threatening PGI. She had on the right hemipelvis at least 10 major operations. She had a severe drug allergy, something called DRESS, to 2 major antibiotic classes, or glycopeptides and or beta-lactams, which prevented me from using 2 major antibiotics to treat this infection. She had a very resistant strain of Staph epidermidis, which was her culprit pathogen. It was highly virulent. And on top of all this, she had something called daptomycin-induced toxicity. So she had severe nerve pain and myalgias and muscle pain with the only antibiotic I could give her. And this was despite having years of antibiotics. She presented to my clinic with sepsis, a sinus tract, and she was very, very sick. And her mortality was imminent. So very briefly, this was her IDs. You can see she has a draining abscess or sinus tract of her hip. She was very, very sick, and we didn't have any treatment to give her, and she would not survive another surgery. So this could also be a whole topic in and of itself, but when we were designing the methodology behind this, do we look at a monophage preparation versus a phage cocktail? And there are pros and cons versus both. We went with a monophage preparation because—
5 minutes, please.
Okay. We had some negative interactions between their phage. What dose do you use? If you go above 1 × 10⁻11 PFU per mil, we can get fibril formation. You can get, again, negative synergy. Frequency versus sequential dosing. You should not withhold standard of care treatment, which includes concomitant surgical revision or resection, as well as standard of care antibiotics, how you deliver your therapy, duration, pharmacokinetics, and then, of course, regulatory hurdles. So this is just to show that when we proceeded with our study, we adhered to USP standards and compassionate use recommendations for phage therapy. The regulatory hurdles in Canada were immense for this study, but our research team got through it. I feel like I aged 10 years with this study, but the next set of studies that we're doing, things are much smoother. There is a lot of misinformation surrounding phage therapy, and our group, in addition to the basic science and the clinical trials we're doing in this area, we are working with governmental bodies to try and combat or curb that misinformation regarding phage therapy. As I said before, if you know what you're doing, you're working with a reputable lab, you understand the science, you understand the infection, phage therapy can be safer than antibiotics. So back to our case, we administered the phage at 7 × 10⁹ PFU per dose. It was a monophage preparation, BID, or twice daily, introduced both within the infected hip and systemically through intravenous routes. We gave concomitant rifampin and daptomycin. She had an interesting immunologic phenomenon where she had a bit of an anaphylactoid response within days 1 to 5, which hasn't been reported in the literature. She had a bit of a hepatitis, which has been reported in the literature. It's self-resolved, and her inflammatory markers had normalized within 12 months follow-up, which is quite remarkable. She had complete wound healing with cessation of purulent drainage from the hip within 1 month post-phage delivery. She had improvement in mobility and pain within 3 months post-phage delivery, and at 10 months post-phage delivery, our CRP and ESR inflammatory markers had completely normalized. Importantly, no recurrent surgery for the first time in 10 years, and she's currently doing extremely well and living at home with sustained clinical control of infection. So very briefly, next steps. There's a lot more work we have yet to do in this area. We're currently working on a targeted phage therapy case series, and then next we'll be working on RCTs, as well as adjunctive basic science papers, looking at binding, pharmacokinetics, things like that, as well as co-packaging phage with antimicrobial peptides to try and enhance their antibiofilm activity. So thank you very much. That was a lot to cover. Yeah, that's all I have to say. Thank you. And if you have any questions, this is my email.
Well, don't go away, because we've got the question and answer session in about 15 minutes. So
perfect.
We'll switch gears, and I'll introduce Sarah Forgy. Sarah is a pediatrician and infectious disease physician. She was the dean of the she is the dean of the College of Medicine in Saskatchewan. Part of that, she spent 21 years at the University of Alberta, where she held a number of leadership positions. And before that, she was in Winnipeg as a pediatric infectious disease physician. So Sarah is going to tell us all about what germs know, and I fear that they actually know a whole lot more than we do. Sarah's presentation is entitled, What Do the Germs Know? Life Lessons from the Microbial World. Madam, the floor is yours.
Thank you so much, Dr. Emble. And I think Zoom seems to be upset with me because it's now telling me to open my settings. So I'm just going to try and get my PowerPoint open because I have it all ready to go. It's right here, but I don't think you can see it.
Not yet.
Okay, let me try again. Zoom will not get the best of me. Okay, let me try again. Share. It is not allowing me to share. Dr. Emble, I am happy to talk without slides.
Madam, I will leave it to your discretion.
So, hi, everybody. I am so excited to be here. And can I just start by saying thank you to Dr. Emble. Dr. Emble and I go way back. We're really not that old, but sometimes I think we may be getting older. Dr. Emble worked with me when I was a medical student at the University of Manitoba, and then when I was a pediatric infectious diseases fellow, and we did a lot of work with adult infectious diseases. And he's always been a hero of mine. And when I moved to Alberta, I actually did, with his permission, Cowboy Bug Day. And so we had a couple of events called Cowboy Bug Day, and we had Dr. Emble come and speak. And it was an homage to his Bug Day in Manitoba. So, John, congratulations on so many years of amazing education. So I will start with disclosures. I have none to disclose, and I would also like to acknowledge that I am on Treaty 6 territory and the traditional homeland of the Métis, and I pay my respects to the First Nations and Métis ancestors of this place, and I love to reaffirm my relationships with all of my Indigenous colleagues. So my objectives today are to really tell you a little bit about what do the germs know and life lessons from the microbial world. So I have three big objectives. I want to, by the end, I hope you appreciate the impact of microbial diversity. The second thing is, I hope you can apply some life lessons from microbial behavior of how microbes can be models for innovation. So bacteria, as we all know, I love bacteria. I know Dr. Emble does too. They've been on this planet for more than 3.5 billion years. They are the oldest form of life on the planet. And by recent estimates, our bodies have over 40 trillion bacterial cells. Bacteria are everywhere, inside our bodies, outside our bodies. Some we cannot live without. I'll tell you more about those, and some of them are bad. We just heard about the joint infections. We've heard about hyperbaric treatment for different ones. But these ancient creatures have outlived and will continue to outlive all of us. So I just felt it would be appropriate to learn something from them, especially given how, even though I continue to practice in infectious diseases, I've taken on more leadership roles and noticed some things that are kind of similar. So I don't know if you knew this, but for many of us as modern city dwellers, and I had a beautiful PowerPoint slide of some very nice primates, there's been some recent studies showing us that modern city dwellers have lost about half of their gut microbes. And we know that some of these gut microbes have actually been, they're in primates' guts. They were likely in our common human ancestor. And over time, as we've moved to cities, we've increased our sanitation, we've increased our antimicrobials and changed how we've eaten. We've lost about half of the diversity in our gut microbes. So what does it mean when we lose diversity, and what does a diverse gut microbiome help us with? Well, we know it does lots of things. So I like to think of our gut as really being a community of different bacteria. And we know that these different diverse bacteria help our immune system. They educate our immune system, which means people who have a diverse gut microbiome, especially when they're infants, actually have less chance of allergies, less chance of developing autoimmune diseases, and it also decreases inflammation. These diverse bacteria in our guts also help us with digestion. So they help us digest complex fiber that we wouldn't be digesting on our own. They also give us some bonus nutrients. So diverse bacteria will help produce short chain fatty acids like butyrate, and also vitamins like B12 and vitamin K. We know we're hearing a lot, especially more recently, about the gut-brain axis and how gut microbes actually can influence neurotransmitter production. So serotonin is one, dopamine. And so if you've got a higher gut diversity, studies have shown that you have lower rates of anxiety, depression, and cognitive decline. And the other thing that these good bacteria, normal flora, we like to call them different things, but really communities of bacteria, diverse bacteria in our guts can do, is they can actually prevent other more bad organisms from causing infections. So when I teach medical students about Clostridioides difficile, or C. diff infection, I have an analogy, and I have a picture. I'll have to get you to close your eyes and picture this yourselves. But imagine the hospital parking lot, and it's completely full of cars, all different kinds of cars. And you've got one car that is constantly circling around, and that is C. difficile. And so that is that bacteria. It's floating around in your gut, and it's looking for a parking space, and it can't find it. So we all know that the first step in a C. diff infection is that you have to be colonized with the bacteria, you have to have that car driving around. And we know that to be able to, quote unquote, resist that infection, if you have good bacteria, normal flora, a diverse flora in your gut, there's no parking spaces. But if you disrupt that normal flora, so if you give someone antimicrobials, if they happen to go on chemotherapy, even high levels of stress, a bunch of parking spaces can open up, and you start to lose a diversity in your gut. And what can happen is that C. difficile that's driving around can actually find a parking space. If it's the right kind of C. difficile, it's got the right mix of toxins, can actually bind, start causing damage with the toxins. You get tissue damage, you get diarrhea, and you get lots of problems. So that diversity in your gut is really, it's an important thing that you need to keep. So when I was teaching the medical students a few years ago at the University of Alberta, I had a student actually create an Instagram site for me. And we would post these different ways of remembering things. I had a picture of your gut with a good, diverse, normal flora with lots of parking. So it was a picture of the parkade with all of these cars, and then a picture late at night where there are almost no cars and where C. diff could bind. So one of my colleagues were in intensive care, and he actually sent me a picture of two cars very close together late at night in the parkade. And he said, "This is my colon," which made me laugh. And what happened was he came in really late to see a case, and there was nobody else in the parking lot, and he parked, and another car came and parked right up beside the driver's side door. So we actually had to climb in through the passenger side, but it did make me laugh that he called it his colon. So what can you do to try and repopulate your gut or change your flora? We know with Clostridioides difficile infections that you need to remove the offending antimicrobial, that you need to start different antimicrobials. And for some, they actually, with really refractory cases, they will do fecal transplants. And that's to try and restore that diversity. The other thing you can do, if you're not in that state, but me and you, what can we do? There's lots of things we can do. So having a high fiber, plant-based fiber diet, that's a prebiotic diet. So these are things that your gut bugs like to eat. You can also eat a lot of fermented food. That's the probiotics. So things like certain kinds of yogurt and kimchi, things like that with naturally fermented food. And when I think about, well, what can we learn from that? And it's really, I like to think about those communities in your gut are very much like teams that we work with as humans. And it's really good to have diversity. And what we need to do, very much like we need to do with our gut, is to actually provide lots of support. So that includes when we're hiring people into our team to make sure that we've got unconscious bias training, that we've got really good policies and procedures around equity, diversity, and inclusion and accessibility. But also once colleagues are here and you've got diverse teams supporting different people on the team and being aware that different people, just like the bacteria, have different needs, because really diversity, I think, makes a much stronger team. So that was, hopefully you have seen how appreciating diversity of the bacteria in your gut can also be applied as a life lesson in the human world. And so the second thing I wanted to tell you about, another life lesson, is around microbial behavior. And just before I joined this Zoom, I actually ate my lunch, and I'm sure many of you have recently ate your lunch, and your internal organs are hard at work digesting, and your stomach is actually bathed in liters of gastric juice with lots of enzymes that help to break down the food. There's concentrated hydrochloric acid, and it's one of the most inhospitable environments in our bodies. And until about the mid-80s, it was always presumed to be sterile. And the question was, what germs could actually survive in all of that acid? But Helicobacter pylori is a germ that changed all of that. In 1981, there was an internal medicine resident, Dr. Barry Marshall, who met Dr. Robin Warren, who was a pathologist. And they noted from biopsy specimens from stomachs that there were some very strange looking spiral bacteria with patients who had gastritis and sometimes ulcers. And in 1982, they cultured this bacteria, called it Helicobacter pylori, and proposed that it caused gastritis and ulcers. And I tried to publish a paper. It was the lowest ranked paper in one of the gastroenterology journals the year that they sent it in. And so to prove, and I'm not saying that anybody should do this, but to prove that Helicobacter pylori actually caused gastritis and then ulcers, one of these researchers actually drank a whole cultured drink of H. pylori. And they did go on to win a Nobel Prize by doing this, but probably not what we would want our medical students to do or colleagues to do. But what was really fascinating about this bacteria, and it disproved, that this inhospitable environment was sterile. There's a layer of hydrochloric acid in your stomach, in all of our stomachs, and then there's actually a layer of mucus that protects the stomach cells underneath. And what happens underneath the stomach, underneath that mucus, is that the stomach cells produce urea, and it's a byproduct of cellular metabolism. So what Helicobacter pylori does is it comes in, it floats through the acid, it uses flagella, it moves, and it basically burrows through the mucus till it gets to the stomach cells. And it actually produces an enzyme called urease, and urease breaks down urea, which is a byproduct of that cellular metabolism, and converts urea to bicarbonate and ammonia, which are basic. So what it does is it makes an environment where it's bound, where the acid gets neutralized, and other H. pylori, the daughter cells, they start to multiply, because within a week of an infection with H. pylori, the stomach pH rises, and H. pylori creates an environment where the other bacteria can thrive. So I had a colleague in pathology, Judith, who said to me, I think we all need to be a little bit more like H. pylori, where we create environments, even when it's toxic all around us, we create an environment where those close to us can thrive. And I just thought that was a really neat life lesson from Helicobacter pylori. And then the last thing I wanted to tell you about is how bacteria can serve as inspiration for us, especially related to models of innovation. So bacteria, as you know, are single-celled organisms, and but what they do is they start to multiply, create daughter cells. And if you've got one or two bacteria and they release a toxin and they're in your body, this is not going to have a huge effect. But what's really fascinating, I find, about bacteria is as they start to grow, they secrete these proteins, and they're called autoinducers. So you have a few bacteria and they start to multiply, and then they make more of these proteins called autoinducers. And what the autoinducers can do is actually trigger gene transcription when there's enough of it. So you get bacteria multiplying, 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 making these peptides, and it actually allows the bacteria to talk to each other to say, we're at a critical mass now. We've got these proteins, these autoinducers, and the autoinducers trigger the cells to actually shift their gene expression. And so this was very first studied in bacteria that would glow, and they had to reach a certain point where they talk to each other. It's called
1 minute.
quorum sensing, and they would start to glow or have bioluminescence. It's also a way that they can all, and when they reach a critical mass, produce toxins all at once, or they can make a biofilm, which we had heard about in the previous session. So what's really been novel is there's several researchers, one called Dr. Bassler, and she's at Princeton, and she's actually looking at something novel, which is an antimicrobial that targets those autoinducers. So you'll still have bacteria there and they're growing, but if you target the way that they communicate with each other through these autoinducer proteins, you actually reduce their ability to make toxins, to make biofilms, and so it's a novel thing. So I was thinking, well, what could we as humans learn from that? And I love working in teams, bringing people together, but sometimes there's ways where we can block the communications between each other. And I've been thinking about it a lot recently with social media and our use of cell phones and how much, and these studies have shown that there's increased anger, there's increased disgust and fear in the world related to our use of social media. And I think of it like a block of the communication. So we feel like we're communicating with each other, but we're actually not, because there's something that's blocking us, and it's the cell phones and the social media. So that is the end of my little journey into what can we learn from bacteria and the different germs in our body. So I hope from that you've learned that diversity is more than just the presence of bacteria. It's about purpose. When we think about the microbes and the germs in your gut, each one plays a specific role. And when you've got lots of diversity in there, there's lots of balance, just like when there's diversity of humans on your team. When I think about Helicobacter pylori, we need to create environments where everyone can flourish, just like that bacterium does. So we should all be a little bit more like H. pylori. And even if hostile environments are hostile, we can help transform them and help other organisms thrive. And then finally, when I think about communication and how bacteria quorum sense or talk amongst themselves, it's a really neat way that bacteria can work together to make toxins, to make biofilms. And it's just like humans, that we can work together, but sometimes there's novel things that will actually stop us from communicating with each other and blocking that. So thank you very much. This is Dr. Embel. I am happy to answer questions.
Okay, so why don't we switch to the questions and answers? We'll spend 10 minutes instead of 15, and we'll eat into the break a little bit. So this, I think you have to understand that when we put Bug Day together, we never know how all the presentations will fit together, because we don't know precisely what each of the speakers is going to speak about. But today's presentation, this group of 3 presentations in particular, worked out perfectly, because Sarah talked about the bacteria that began hundreds of millions of years ago, and then we had 2 presentations about old therapies that have made a resurgence. Bacteriophage therapy that's actually been around forever, and the same with hyperbaric oxygen. So the first question says, we have used hyperbaric oxygen for non-healing diabetic foot ulcers. I care for these ulcers daily and have not seen any that have received this treatment yet. And the reason you have not seen it is that to use hyperbaric oxygen therapy for diabetic feet would be misguided. The reason that I say that is that there are basic steps, no pun intended, of course, that need to be taken before we embark upon more advanced therapies. For 90+% of the diabetic feet, the key is complete pressure relief. If pressure relief from the ulceration is not achieved, then using advanced therapies isn't going to improve the outcome. So before advanced dressings and other advanced therapies are undertaken, the basics have to be addressed. And I think that's true for everything. Dr. Keenan, any commentary?
Yeah, I agree. So for the vast majority, it has, there are many other modalities that need to be used before. There is a small set that needs to be carefully chosen and that has to benefit from the tissue oxygenation. There needs some equipment to measure it, to identify those subset, the small subset, as you said, 90% are not candidates. There might be a niche for a small subset. It's not available in Manitoba and it's not used in that indication, but globally it is used, and the trick is identifying who are the ideal minority that would benefit from it.
And that minority in diabetic feet, it's often in palliative cases where there is no other option, and it's basically to help control pain in individuals that are not surgical candidates and not amputation. Okay, so let's shift gear, and it says, just wondering, RE proton pump inhibitor impact on normal gut flora. What is your opinion on probiotic benefits, risks? What strains are best? What dosage? How often?
That is a lot in one, that is packed into one. So we know that proton pump inhibitors absolutely have an impact. It actually, because the hydrochloric acid in your stomach is actually a barrier to some of the pathogenic bacteria causing infections. We know that, if I'm a pediatric infectious disease specialist, and if I'm sending a child on a PPI, if they're going on a trip somewhere, I will say that they're at higher risk for certain infections. So we do know that there's that effect. So your question about probiotics and the many pieces after that, it all depends on the population that you're dealing with. So a lot of my work, again, in pediatrics, I have a hospital-based practice. We do use probiotics in premature babies, and that is around necrotizing enterocolitis. So certain things that we know that our premature babies are susceptible to has been very well studied. When we're talking about other populations, like if this was an adult, I would send them to one of my adult colleagues. But when people ask me for my advice, I talk about fermented foods. When I think about and just it's really more of a philosophy around this. We have so many different communities of bacteria in our guts. So to say what is the best probiotic, it's actually not one. It is many of them. And so the fermented foods, and the neat thing that I know about is that about 2/3 of our gut flora is unique to us. And a lot of it is inherited from your mother and from your family and from other exposures. So to say, just take one thing, it's going to make everything better is not the answer. So really, it's more certain populations, certain situations like those premature babies.
Thank you. Can we scroll down to the question about phage therapy? There we are. So phage therapy, and I think we need to have a bit more of a discussion about this. By displaying small, oh my gosh, we've lost it. Perhaps you can, there we are. By displaying small amount of protein on a phage, can we train immunity to fight against some bacteria, just like a vaccine? It is highly specific. Can we use phage in treatment in targeted drug delivery / cancer? Are there any evidence of phage resistance, like antibiotic resistance? Great, again, a monster of a question.
Yeah, that's an excellent set of questions. So I'll start with the last one because that's easiest. So phage resistance definitely occurs similar to antibiotic resistance, but the mechanisms are slightly different. So that's one of the arguments for using phage cocktails versus monophage preparations. In theory, it can kind of prevent or curb phage resistance from occurring. And there are a variety of mechanisms. So one of them is the CRISPR-Cas system. You can have modification of those host cell receptors, such as LPS modification, so that the phage itself cannot bind to the target bacteria. And there are also restriction modification systems. There are a variety of mechanisms where you can get phage resistance. Now, in terms of the first two questions, this is very, very interesting. So there's some research groups that are using phage as like a payload system where you can bind through a variety of mechanisms such as photodynamic effects, where you can bind these molecules or prodrugs to phage. And there are certain phages that are actually very long and narrow and have more surface area to kind of load various antimicrobial or even anti-cancer molecules to that phage, and they can target cancer specifically. We have cytotoxic effects. You can finely tune antibody responses through these mechanisms. You can do gene replacement therapy. You can introduce suicide genes, cytokine delivery, and finely tune various immune mechanisms through phage.
Thank you. Now, there's a question that was just a little bit lower that is a fascinating and exceptionally complicated question, which is a Sarah Forgy question. How much damage are we really doing to our gut microbes by drinking diet pop? Do we know how long does it take to get back to what it was? This is actually an incredible question, and a topic of immense interest right now. Sarah, any thoughts?
I don't know the answer to that, John.
I don't either. But
Yeah. It's an interesting question. Like I know I was thinking back, there used to be some studies looking at some of the artificial sweeteners and otitis media. This is going way back. But some of the artificial sweeteners actually had an antibacterial effect. I don't remember exactly what it was, but I don't know the answer to that. I'm happy to answer the H. pylori question where it lives.
But before we shift gears, there is a body of thought that highly processed foods do change the gut microbiome.
Agreed.
And that leads to, it's not just the food, not the highly processed food itself, but the change in the gut microbiome that may change metabolic activity in the human. Great topic. Okay, let's switch gears to Helicobacter pylori as the last question, and then we'll have a brief break before the grand finale.
It does. So, yes, and I totally agree with you, John. Like the highly processed food, like it's much better to stay away from the highly processed food. I just didn't specifically know about the diet pop. But absolutely, it can live in the environment. It is more frequently acquired from other humans, so it's fecal oral spread. Often you can see it being transmitted from mom to child, but in crowded conditions within families. And I've seen some studies looking at animals as well. So cats can carry it sometimes. And then I have seen also cows, so possibly via milk. But the most likely thing is it's from another human who's carrying it. And then either direct contact, so like you're sharing utensils, or kissing, and then close contact through like fecal oral spread as well.
Thank you very much, Dr. Keenan, Azad, and Forgy. Great session. We will see you back in 9 minutes to begin at 3:15 Winnipeg time with Philippe Lagassier-Weens. So thank you, everyone. Welcome back. This is the home stretch, and for those of you who have been to Bug Day before, you know that the last hour is where the eclectic, the unusual, and the creepy crawly often appear. And we have three speakers who are well known to Bug Day. And we'll begin with Philippe Legassier-Weens, who will regale us with What's Biting You, a primer on tick-borne diseases. Philippe is a medical microbiologist at St. Boniface Hospital and a consultant for the Winnipeg Regional Health Authority Travel and Tropical Medicine Clinic. And Philippe is also an assistant professor in the Department of Medical Microbiology and Infectious Diseases at the Max Rady College of Medicine. Philippe, the floor is yours.
Thank you, John, and thank you for inviting me once again. I have the challenge of presenting a little bit about ticks, and it's a challenge because there's a lot of controversies around ticks, and I hope that this short talk will help clear some of this up. And forgive me for speaking quite quickly because I have a lot of material to cover, so I will keep the pedal to the metal. I don't have any conflicts, so we'll leave it at that. And I want to start by telling everybody that there are three things that ticks have taught me over the course of my medical career. One is that ticks are not all created equal, and this is extremely important. There's differences in habitat, differences in how competent they are as vectors, differences in the reservoirs that they are in a geographical area, differences in behaviors. For example, adult males will almost never transmit Lyme disease, whereas the females will frequently transmit Lyme disease if they're infected. And even within one species, there are multitudes of differences. And this is important because not every tick bite is created equal. So in the vast majority of cases in Manitoba, for example, a tick bite is actually very innocuous. It's probably a Dermacentor species tick. They don't transmit Lyme disease, and most people who've had a tick bite can be reassured. Another important thing, geography is important. The diseases that you can get in the southern US are very different than the diseases you can get in Manitoba. Until recently, the diseases you got in Ontario were very different than the ones you might get in Manitoba. But of course, this is changing. So we're going to hear a little bit about that in the next talk. And lastly, tick-borne diseases are some really weird and wacky things. So without any further ado, I am going to move right into Lyme borreliosis. This is probably the one that a lot of people wanted to hear about today. So I'm starting off with that one in case John has to cut me off a little later. Pearls. So the one slide you should remember from this talk, Lyme disease is caused by Borrelia burgdorferi. It's transmitted by Ixodes species ticks. And in North America, it's almost exclusively Ixodes scapularis. It is a disease that has three stages, like syphilis: local, disseminated, and late disease. The diagnosis can be clinical. Erythema migrans is a clinical diagnosis, the classic rash we hear about, or serological, looking for antibodies. And an important point is Canadian diagnostics are excellent. We have great diagnostics here, right here in Canada. Two-step serology is highly specific. Sensitivity is very, very high in later presentations. That means later than 2 months or so, but it's actually quite low in early disease. So it's not unusual to get a negative test in an early diagnosis. And the treatment will depend on the stage or the symptoms and the site of infection, but usually involves doxycycline. Rarely amoxicillin if it's contraindicated, or ceftriaxone in unusual circumstances. This is the public enemy number one, Ixodes scapularis, the tick that transmits Lyme disease, and a few other diseases that we will talk about. It contains a number of different species, but in North America, it's Borrelia burgdorferi. However, there's other species in Europe, like Borrelia afzelii and garinii, which can transmit borreliosis. In North America, it's typically active from snow melt to snowfall, so all summer. In the spring, as soon as the snow melts, they're walking around, and they are walking around until the ground is covered with snow. So the season is quite long, and it is not impossible to acquire Lyme disease in October and November. As we know, right here in Winnipeg, it's the end of October, and we don't have any snow on the ground yet. Adults are smaller than the dog ticks that we commonly see here in Manitoba, and they can be easily missed. And the nymphs, as you can see in this picture, are really, really tiny. Compared to a penny, it's roughly the size of this guy's nose or the L on the Liberty. So they're very tiny and are frequently missed on people, and they can transmit disease. This is just a map telling you where we find Ixodes species ticks in Lyme borreliosis. I'm going to just bring the attention to this blue area of the map, this light blue area where Ixodes scapularis is found. And it is the one that we encounter here in Manitoba, but also all across Eastern Canada, right to the Maritimes and stretching down into the states through the Eastern Seaboard, down into the southern states. And central United States. So a widespread of geographies will support the life of this tick and therefore the presence of disease. Clinical presentation. I'm not going to go through all the details of this slide. I want you to remember that it is 3 phases. In the early stage, which is usually less than 1 month, the classic presentation is erythema migrans. This bullseye or ring-like rash occurs in about 80% of those infected. It's usually non-painful. That contrasts with cellulitis. And remember that. It expands slowly, and some central clearing is not always seen. Early disseminated. Imagine that this bacteria is now spread through your body. You can get erythema migrans in multiple locations. You can get something called Borrelia lymphocytoma. You can get some neurological signs like meningitis or nerve palsies like Bell's palsy. You can get rarely encephalitis. And the really, really important one is the one that you have to keep in mind is the carditis. This is what will kill people with Lyme disease in the early disseminated phase. It infects their heart and creates heart blocks, which can lead to fatal arrhythmias. And that's a really important one to keep in mind. And then late arthritis, about 60% of people who don't get treated will develop some arthritis, usually large joints, usually the knee. Small joints are less commonly affected, but can be seen. And then more rarely, you could get chronic neurological diseases, neuropathies, encephalomyelitis, and encephalopathies. And in Europe, the variant that exists in Europe can lead to something called acrodermatitis chronica atropicans, which if you break down the Latin is dermatitis of the extremities that is chronic and results in atrophy of the skin, which is usually a bluish and red discoloration of the hands and feet. Just some photos, eye candy for everyone. We have on the right-hand side here, early local, that's classic targetoid rash, which may not be targetoid, but is usually painless, maybe associated with some symptoms of fever. And then on the left-hand side, we have multiple EM, again, looking quite similar, but this is the early disseminated stage because the bacteria has disseminated to multiple locations on the skin. This is acrodermatitis. Now, just a few points on post-antibiotic Lyme arthritis. This is somebody who has failed to resolve their symptoms after treatment for Lyme disease arthritis. About 23% of people will develop persistent synovitis that no longer responds to therapy. They could develop autoimmune-mediated synovitis, similar to rheumatoid arthritis. But it is well known that after 2 antibiotic treatments, further treatments will not benefit Lyme arthritis. And that's when you should start considering treating these more like chronic immune-mediated arthritides and refer them to rheumatology for consideration. Repeated antibiotic treatments do not help. And then there is this syndrome of prolonged non-specific symptoms after Lyme disease. It is felt to occur in about 10 to 20% of patients. They're non-specific symptoms like fatigue, musculoskeletal pain, neurocognitive, brain fog, non-specific subjective symptoms waxing and waning. They can be quite debilitating, and we need to recognize this is a true condition that can occur after Lyme diagnosis. But the key point that I want to make today is that there is no evidence that repeating prolonged antibiotic treatments help this condition. There were 4 placebo-controlled randomized trials with a total number over 500 people that show no benefit to prolonged antibiotic treatments. And we do have patients that repeatedly request this, but the evidence is really not there to support using prolonged or repeated antibiotic treatments for these symptoms. It's not to say that they're not relevant and important symptoms. What I'm bringing home as a message is that they don't get better with antibiotics. Diagnosis of Lyme disease is usually by serology. We do a 2-step, an enzyme immunoassay, then a Western blot. Remember that early Lyme is a clinical diagnosis. Serology is not required. and is in fact only positive in 20 to 40% of cases, so low sensitivity in the early stages. However, in the late stages, cardiac, neurological, or joint or articular Lyme disease, the sensitivity is nearly 100%. So we don't typically miss a serological diagnosis in later disease. A little bit about treatment before I move on to the other diseases. Oral treatment is sufficient in almost all presentations. Retreatment is rarely indicated, except in the case of persistent arthritis after an initial treatment. Carditis is the most feared presentation. You need to get patients into the hospital to be monitored if they've got carditis. The heart block can lead to fatal arrhythmia, and they may need to be temporarily paced. Post-treatment Lyme syndrome does not respond to additional courses of antibiotics, and DMARDs or surgery may be indicated, but that's usually rarely. And this monstrous table, I'm not going to go through this. It tells you what the treatment options are. You don't typically need IV therapy unless we're talking carditis or encephalitis, or sometimes in persistent arthritis after oral therapy, but almost all the time we're treating with doxycycline. Now, jumping to the next big one here in Manitoba is anaplasmosis. It's usually a non-specific febrile illness. We diagnose it usually by a blood smear or a PCR or serology. The incidence is increasing. Geography is again associated with Ixodes scapularis, exactly like Lyme disease. And you can actually get Lyme disease and anaplasmosis at the same time. This disease is also treated with doxycycline, so you're inadvertently treating that possibility whenever you have a patient that you're treating for a case of Lyme disease. The clinical presentation, it's usually in the summer and fall. It's got an incubation period 1 to 2 weeks, and usually fever is the dominant symptoms. Fever, headaches, myalgias. A rash is very, very rare, and that's a key clinical sign. It would suggest your patient might have Lyme disease, or in the States, Rocky Mountain spotted fever, because it's unusual to get it with anaplasmosis. When we're dealing with the diagnosis, we want to be able to get a microscopy of the blood or Buffy coat. This is low sensitivity, so PCR or nucleic acid amplification tests, that's NATs, are a mainstay. Unfortunately, it's only done at the NML here in Manitoba, so it's difficult to get a result quickly. And serology can also be ordered to diagnose anaplasmosis. The treatment, as I said, doxycycline. You should also use doxycycline to treat anaplasmosis in children. It's not really a contraindication anymore because we know short treatments are not concerning to children. It is now acceptable to use short treatments of doxycycline in children. Even in pregnancy, as you can see, alternatively, rifampin can be used as treatment in pregnancy. And Babesia, the trifecta of Ixodes spread disease. This is the last one. It's a parasite. It's in a way related to malaria. It's a protozoan parasite. The vectors are the same. The incidence is increasing in North America. I believe we've had a few cases this year. And the presentation can be quite variable, from asymptomatic to absolutely fulminant, leading to ICU care or even death. A little bit like malaria. Immunocompromised patients really do require special consideration because they can be much worse off. And the diagnosis, like malaria, is by microscopy primarily. There's also PCR tests or serology available, but not locally. And the treatment is with atovaquone and azithromycin. So that's your pearls. But if for more details, remember 20% of infections are asymptomatic. So this is probably more common than we think. The presentation in immunocompetent host is usually fever. It can be isolated with no other findings at all. It can present as fever of unknown origin. And on physical exam, it's really, again, just fever. And rarely you'll find splenomegaly. Some lab tests can be helpful. Certainly anemia in hemolysis and thrombocytopenia, like in malaria, is notable. And other findings could be noted similar to malaria in labs. Now, severe disease is important. It's usually defined as more than 4% parasitemia. Risk factors are being more elderly or having asplenia, malignancy, HIV, or other immunocompromise. And the complications, I'm not going to go through them, but think severe malaria. This is malaria-like. It's severe malaria, presents very similarly. Relapsing disease, however, is more common with Babesia than it is with malaria, particularly in immunosuppressed patients. And in severe disease, mortality is quite high, upwards 3 to 9% in hospitalized patients, and in severely immunocompromised, 1 in 5 will die. So this is a serious disease. The diagnosis, as I said, is blood films. It's a Maltese cross is what you're looking for on your blood smear. And remember that here in Manitoba, to diagnose malaria, we use a PCR-like test. It does not detect Babesia. So you need to be sure you say not malaria on that requisition and request Babesia diagnostics. You can also do PCR. It's not widely available, as you can do serology. Treatment is with azithromycin and atovaquone. I'm not going to go through the details in the interest of saving a little bit of time. And in the immunocompromised, I'm just going to highlight the fact that we tend to use IV azithromycin for treatment, and we tend to treat much more aggressively. In high-risk immunocompromised people, we will treat for 6 weeks because of all those relapse, and we also insist on repeatedly having negative smears for 2 weeks in immunocompromised individuals. Tularemia is an important one. We've had several tick-associated cases in Manitoba recently. As I said, it's caused by Francisella tularensis. It can be spread by almost any kind of tick. Anything that feeds on rodents or rabbits that can acquire tularemia from them and then feed on a human can give you tularemia. There are 6 forms of the disease. I'm not going to go through them. And the treatment is an aminoglycoside or tetracyclines or fluoroquinolones in less severe cases. This map here tells you where we find tularemia, essentially across the northern part of the planet. And here in Manitoba, it's usually that dog tick that is the problem, the Dermacentor variabilis. But other ticks can be involved. As I said, anything that eats blood from rodents and rabbits can transmit it. Clinical manifestations, those are those 6 clinical syndromes, but I'm only going to show you a picture of ulceroglandular because it's the most common one. It's typically a non-healing ulceration associated with lymph nodes that are swollen in the axilla or arm if the ulcer is on the hand. Fever can be prolonged. It can give way to a diagnosis of fever of unknown origin, and it does not respond to beta-lactams. And that's a key hint that it might be tularemia. The biggest hint is exposure to ticks or other animals that carry tularemia. Always important to get a sample, ideally a piece of tissue or an aspirate. Swabs of ulcers and other sites of infection are also potentially helpful, but really important to tell the lab. A, it can be transmitted to staff in the lab if it's not known that it was tularemia beforehand. And B, we need special media to grow tularemia. So you need to tell us that tularemia is suspected when you send it to the lab. So that's a very important point for people who are making this diagnosis. The treatment, as I said, for severe is an aminoglycoside. For milder cases, a doxycycline or ciprofloxacin can be used. This is the before last one, Rocky Mountain spotted fever. I'm concerned about this one because while we don't see many cases, the dynamics are changing and may spread to Canada. It's an obligate intracellular bacteria called Rickettsia rickettsii. It is primarily transmitted by Dermacentor variabilis. We have lots of those ticks around. The presentation is fever and rash, then shock and arrhythmias, neurological symptoms. Before antibiotics, mortality was upwards of 80%, and now it's about 3%. And the diagnosis is almost exclusively clinical. If you wait for diagnostic tests here, your patient will die. Treatment is with doxycycline. As I said, Rickettsia rickettsii, it's spread by ticks, by a variety of ticks, but primarily Dermacentor variabilis and Dermacentor andersoni. The distribution of the ticks is illustrated here. On the bottom right, you see the cases of Rocky Mountain spotted fever. Despite its name, it's primarily the central and eastern US that sees cases. There are cases, however, in Montana and nearby states. Cases are very, very rare in Canada so far. We've a few cases in Alberta, but there's a lot of vector. So there's probably not a whole lot of barrier to introducing this in Canada. The diagnosis is primarily clinical. It's this classic rash. It involves the hands and feet and palms and soles. So it's one of those more unique rash, 90% after 2 days of initial symptoms. This should be your hint to treat. Don't wait for diagnostic tests because it can proceed to encephalitis, myocarditis, arrhythmias, neuropathies, nephritis, lots of severe disease, ICU care, and potentially death. As I said, diagnosis is primarily clinical, but serological testing is usually the form of confirmation. It should be acute and convalescent samples. And you can also do PCR of blood and skin lesions. And sometimes you can do histopathology with immunostaining, although that's a rare modality these days. So think mostly serology. It's all done at the NML, which means that you won't get results for a few weeks, which is, again, so important to get that clinical diagnosis quickly. Treatment is doxycycline. It's the only treatment that's effective and known to be highly effective. It's the treatment for all patients, including pregnant women and children. You need to treat for at least 3 days after defervescence. Usually takes 7 to 10 days, but upwards of 14. Do not wait for a clinical for a definitive diagnosis. Treat on clinical presentation. Mortality is 23% with the delayed treatment versus only 6% for early treatment. So early treatment is key. This is my last syndrome, alpha-gal syndrome. It's a bit of a new kid on the block. It's wild and wacky, and it's not a pathogen. It's not a bacteria or a virus. It's actually acquired anaphylactic allergy to red meats resulting from a tick bite. And if you say that's weird, it is. It's most commonly associated with Amblyoma americanum bites, whose habitat has now stretched into the Maritimes in Canada. We don't see it here in Manitoba. Other species can be implicated. And basically, it happens because there's this carbohydrate that's on the cells of all mammalian species called galactose alpha 1,3 galactose. And all mammalian species except primates have this. And what we think is happening is the tick feeds on other mammals, and then it regurgitates this particular carbohydrate when it goes and feeds on a human, who then produces antibodies to it. And then they have circulating antibodies to red meat of all other mammals except for themselves, because it wasn't recognized as self. We don't have it. And these individuals will have this sort of delayed anaphylactic reaction to eating mammal meat and other mammal products like gelatin. The diagnosis is clinical. If you eat red meat and then half an hour to an hour later, you've got hives and wheezing and itchy eyes, watery eyes, flushing, hypotension, this is a strong sign that you've got this alpha-gal syndrome. We can only treat it by avoiding mammal meat. So you can eat fish, you can eat mollusks and seafood, you can eat reptiles if that's your thing, like alligators and crocodiles. You can eat birds like chickens or other birds, but you can't eat mammals. The allergy can actually resolve over years or decades as long as you don't get further sensitized from ticks or further sensitized from meat. And remember, that includes all meat products that are from a mammal. So that includes things like gelatin, which is quite common in broths and stocks and all sorts of things like that. So it can be difficult to avoid, and it can be very problematic to people. So an interesting newer diagnosis related to ticks. And that's it. Remember, animals get ticks too, so keep a lookout for your dogs and cats and snakes and koalas, and also your otters and other mustelids.
Thank you, Phil. We'll be calling environmental services about the number of creatures you've got in your backyard. Okay, so let's shift gears. Wayne Gesquire will talk to us about walking pneumonia, whether it's actually still walking amongst us. And it's interesting because a year or two ago, there were a number of reports from the United States about cases of walking pneumonia, something that we hadn't heard about in quite a while. So Wayne is an infectious disease consultant at the Island Health Authority in Victoria, British Columbia, and he's a clinical assistant professor of medicine at the University of British Columbia. He is also the chair of the Infectious Diseases Update held annually in Victoria, now celebrating its 27th year. Great symposium. Wayne, tell us about walking pneumonia.
Hello, John, and thank you very much for the opportunity to present. I assume you can see the slides, yes?
Perfectly, yes.
Perfect, thank you. Well, walking pneumonia, what is it and how do you manage? So I thought we'd get into this pretty quickly and get this, great. I think a lot of us at the end of a day at a conference, we kind of feel like this information overload. It's sort of like drinking out of a hose. And our last presentation by Philip Weens was wonderful, but yeah, what a lot of information. So what are my objectives today? I'm going to talk about and discuss the epidemiology of mycoplasma pneumonia or walking pneumonia. I'm going to review the clinical presentation of mycoplasma and discuss guidelines of empirical outpatient treatment. You know, this is full circle. Dr. Emble and I worked in a lab long ago in Halifax, and I was working on this pathogen when John and I met. So, like all good presentations, I'm going to give you the answers right away. So here's the take-home pearls for today. Mycoplasma pneumonia is the second or third most common cause of community-acquired pneumonia. It's the cause of walking pneumonia. Its prodromal symptoms include headache, fever, people with dry cough, and sort of it's really difficult to sort of identify what is really going on. It is frequently undiagnosed due to a lack of specific diagnostic criteria and diagnostic tests, rather. And so really, we don't have an easy test like blood culture, sputum. Chest x-rays, often they do not show an infiltrate. Or if you look at the infiltrate, you go, well, that tiny little thing is making you sick like this? Really? So that's another tip. Finally, management with antibiotics, generally azithromycin, 3 to 5 days, doxy or levo or moxifloxacin for 7 to 10 days. And there's no vaccine that's effective against this infection. And I just want to kick in doxycycline. There's a pearl we use. Fever of unknown origin. No one should be left without a trial of doxycycline in anybody with a fever of unknown origin. So we just heard previous presentation as a good example, and hopefully this is as well. So of all these take-home pearls, maybe you can pick one is your pearl. So case presentation. We've got a 44-year-old female who I saw recently, flu-like illness for 10 to 14 days, cough, fever, chills. She's treated by her GP with amoxicillin TID for 7 days. That seems appropriate. She's otherwise a healthy lady. She's assessed and she's no better. So she presents the ED. She's got a white count of 15. She gets an NP swab that's negative for SARS-CoV-2, influenza, and RSV. And this was done in December. There's her chest x-ray. So you look at this and go, okay, that's an abnormal chest x-ray. That looks pretty impressive. Maybe we'd like to get more history from this patient. So negative past history, she's usually healthy. She's on no prescription meds, negative for smoking, alcohol use, recreational drug use, lives alone, works in a clinic with all adults at risk for primarily administrative work is what she does. Her function query is basically negative. She has no recent foreign travel, so that's reassures Pierre. So, okay. Questions. If you're an ID guy or you're inquisitive, what's the likely cause of her pneumonia? And 2, hey, if I don't know, what antibiotics would you use at this point? And of course, there was her chest x-ray. So what is the likely cause of her community-acquired pneumonia? Well, blood cultures, sputum cultures are negative, and that's common, right? You know, if you're in a community or in a walk-in clinic or even seen in Emerge, you're not going to get these results back in a few hours. So she could have an atypical organism that didn't respond to what appears to be appropriate amoxicillin therapy. So typical ID, what did I do? So I called microbiology and I said, hey, remember that NP swab that you did? Can you go and run that same swab for mycoplasma? They said, yeah, absolutely, we can do it. And there it is. It was positive. So though mycoplasma pneumonia is common, it is rarely confirmed with diagnostics. And so, you know, yes, if you're in the walk-in clinic or emergency room, you're in the hospital, you've got an NP swab, maybe, not all, but maybe your microbiology can take that swab and run it for mycoplasma. So what's the etiologic causes of community-acquired pneumonia? Number 1, first and foremost, is strep pneumo, 60 to 70%. But you can see number 2 there is mycoplasma pneumonia. It's not insignificant, followed by Haemophilus, Legionella, and it goes all the way through. And yes, down to the bottom, you get influenza and other viral causes, including COVID-19, SARS-CoV-2, and RSV. So what is walking pneumonia? Walking pneumonia is a common subtype of community-acquired pneumonia, typically caused by difficult-to-detect bacterium Mycoplasma pneumoniae. There's a number of atypical pneumonias in this group that causes pneumonia like we saw in this lady's chest x-ray. Infections caused mycoplasma are generally mild, but can sometimes be severe. So here we are. Here's your table of typical, atypical pneumonia. So sorry for the pun. So we've got mycoplasma, chlamydia pneumonia, and no, that's not the chlamydia that causes the STI. That's chlamydia pneumonia, which is a respiratory pathogen. And then there's Legionella. So let's look at mycoplasma. So it's estimated worldwide can be 12%. In Canada, it's this 23%, maybe even higher. It's a droplet spread person to person. Its incubation period 1 to 4 weeks. Serology, acute and convalescent. Our lab in the West Coast stopped doing this. You can ask for PCR through the NP swabs. And culture, no, you cannot easily get culture. And this is just something that's definitely don't even bother asking for. Clinical clues. It's a gradual onset, flu-like respiratory associated with extrapulmonary manifestations, which I'm going to get to. And treatment, yes, doxy, macrolides, or fluoroquinolones, and I'm going to get to that in more detail. So mycoplasma, 20 to 40% of the community-acquired pneumonia is due to this pathogen. We talked about it, respiratory spread. It's not covered or effectively treated, rather, by beta-lactam antibiotics. In other words, this lady's amoxil. In the US, there's something like over 2 million cases identified annually. Highest rate appears to be in the 50 to 20-year-olds, but it's also seen in older adults, more common in females than male, and I don't know why it's more so in females. Children, yes, and adults, we see bronchitis and pneumonia. Here's a MMWR graph just published in September of this year, and you can see the top 3 curves here are the youngest group, with the oldest being towards the bottom here, but you can see kids generally are the highest likely to get it, and this is, you can see, fall, spring, summer, and here are fall again. And here it is. This is a study done out of Sweden and Stockholm over 5 years. This sort of see the cyclical, again, seasonal, associated with the fall in October onto March. And so you can see here it is again, October, and here we are. So we're starting to see mycoplasma again. And last year, I saw a significant number of cases. Mycoplasma pneumonia outbreaks, it's sporadic, but it also can be in family clusters. High rates seen in schools, military recruit camps, sports teams that sort of congregate together, hotels, motels as they're traveling, and of course, nursing and long-term care facilities. Mycoplasma can be identified and seen. So what are the common manifestations of mycoplasma pneumonia? Pharyngitis. Lots of causes of pharyngitis, pneumonia, tracheobronchitis. And with the tracheobronchitis, it's typically this dry cough, but it can be mucoid, fever, headaches, malaise that linger on. There are a lot of other causes of tracheobronchitis, dry hacking cough, pertussis, other viral infections. Pertussis is a bacteria, but other viral infections can do this. Illness onset can be gradual and sort of gradually progresses. So, not to be outdone, here we are, some skin manifestations. Mycoplasma, you can see these lovely target-like lesions. You can see in the hands, palms of the hands, you can get stomatitis and typical rash here as well. Classic ID question, quiz. Hey, what are the causes of rashes in the palms of your hands and potentially soles of your feet? Top of the list, viral HSV, various other viruses, but mycoplasma, bacterial, we can see syphilis, post-streptococcal drug reaction, and of course, Rocky Mountain spotted fever is also included in there. So complications, complications are uncommon, and occasionally, like this patient requiring hospitalization, and deaths are not very common at all, okay? Complications involving the respiratory system include exacerbations of asthma, severe pneumonia, but there's other non-pulmonary complications, encephalitis, gastroenteritis, hemolytic anemia, and on, septic arthritis, and of course the skin disorders, erythema multiforme, Stevens-Johnson, and erythema nodosa. So diagnosis, how do I diagnose this? Well, you don't, right? It's not easy. Cultures are slow, turnaround period, very difficult. So it's problematic. It's lack of knowledge, lack of diagnosis when it comes to mycoplasma. So what do we need to do? How do we treat it? Effective treatments for mycoplasma pneumonia include either a macrolide, azithro, clarithrol, or erythro, doxycycline, or respiratory fluoroquinolones, levomoxy. What doesn't work? What doesn't work is the penicillins, the cephalosporins, the carbapenems, the piptazos, the vancos, all those other big antibiotics, big guns we use. They will not treat these atypical pathogens, including mycoplasma pneumonia. And there's no effective vaccine. So what I thought I did was I decided to do is that, well, let's use a syndromic approach. We treat people with pneumonia using our sort of first line approach. So here it is, outpatient treatment of a communicable pneumonia. What are the guidelines? This went through 4 different guidelines, and you get 4 different recommendations. Up to date, maybe that's what you like to use, suggest Amox plus AZ. Okay, that's pretty good. That's probably what I would suggest. Bugs and Drugs says Amox, and if high risk, then you can consider adding AZ. Ontario Guidelines says amoxicillin or doxy or a macrolide. And these Canadian guidelines, which was, I think, when I Googled what are the guidelines in Manitoba, they did say amoxil plus AZ or doxy. So there's the guidelines and alternative guidelines to people who are intolerant. So let's take this approach. Management of community-acquired pneumonia in adults, risk stratification. So here's a great sort of a QR code. You can sort of put it there through. And let's take the patient I initially presented to you. That patient, when I used this risk stratification guidelines, didn't tell me to use doxycycline. Interesting. So let's look further at guidelines. So treatment decisions based on risk assessment. So most of our patients are going to sit inside of this group if it's an outpatient. It talks about consider outpatient, no comorbidities. It says amoxil or doxycycline. If it's an outpatient with comorbidities, it says amoxiclav plus AZ or doxy. So, I think of this lady, if it was somebody who is in a college or high school student, I absolutely would want to cover these individuals for mycoplasma. And I guess the question you say, do I use 2 antibiotics? Or should I just use 1? Maybe wait. Interesting to discuss. You sort of wonder, can you get away with 1 antibiotic? Can you get away with just doxy? Or do you feel comfortable saying, hey, why don't you use amoxicillin plus azithromycin together? And so I think that these guidelines, I wish I could say there is one drug, covers everything. Yeah, there it is. Here it is, the fluoroquinolones. But I know that my colleagues will have my hide if I recommend and tell you to use these fluoroquinolones for every community-acquired pneumonia. So what I'd like to say is, I think that we need to consider using either doxycycline or macrolide in patients with community-acquired pneumonia, young and old. So I would like to advocate that if you want to use 1 drug, use doxy. If you want to cover all pathogens, we think we need to use double therapy. Okay. Finally, it's that time of the year, since I talked about pneumonia, I'm saying this is respiratory vaccine time of the year, yes, get your influenza, COVID-19, pneumococcal vaccines, and many provinces are now using the pneumococcal conjugated vaccines, whether that be the 15, the 20, or the 21, RSV vaccine, and don't forget the Tdap. So last two slides, I love this slide. This was a study done on Canadian adults are not aware they lack recommended vaccines. This was a study done in 2016, 2019. And what they did was they asked patients one simple question: are you up to date on your vaccinations? And 88 respondents, 88% of the respondents said yes, they were up to date. So what we did was we took those people who said yes, and we actually looked at what vaccines did they actually have based on their age and risk group. And we found that only 3% were truly up to date. So I may not be up to date. You may not be up to date. Be honest with yourself. If we're not necessarily up to date, what about our patients? Finally, you can co-administer vaccines, and it's recommended with one same visit. And yes, there have been patients who got 6 or 8 vaccines in one sitting. Yeah. So don't forget, vaccinate this time of the year, since we're talking about pneumonia. Finally, immunize children to prevent illness. We immunize adults to prevent severe illness and death. So take-home points: pearls, mycoplasma pneumonia, very common, cause of walking pneumonia, prodromal symptoms, frequently undiagnosed, difficult to diagnose. X-ray can be misleading or not very positive. So I'm advocating that, since it's such a common cause of pneumonia, think about using either azithromycin or doxycycline as treatment for your patients with pneumonia. And there is no vaccine for this infection. So, and by the way, children and older adults seem to be at higher risk of complications of mycoplasma. So thank you very much. I'll take questions.
We'll do the questions at the very end, the last 15 minutes.
Perfect.
So we'll introduce Pierre Plourde, who needs no introduction, but we'll do it just for those who don't know Pierre. Pierre is the Medical Director for Travel Health and Tropical Medicine Services with the Winnipeg Regional Health Authority, and Pierre is a professor in the College of Community and Global Health and the Department of Medical Microbiology and Infectious Diseases with the Max Rady College of Medicine. Pierre's presentation is entitled, open quotes, "Where to Next? The Effects of Excess on Human Health." And this should be a bone-chilling presentation. Thank you, Pierre.
Yeah, now for something completely different, for sure. I have no conflicts to declare. So I know you had a land acknowledgement this morning. So I'm just putting this up and not reading it, just to point out what I've highlighted here in the very middle of the slide. And so instead of reading the land acknowledgement, I just want to take this opportunity to set the tone for my presentation, to remind us all that the acts of colonization, which are part of our history, that have caused deep and lasting harms, continue to this very day. And my presentation today is actually largely about acts of colonization, and hopefully sow some seeds as to how we might begin processes of decolonization. And you'll see why I think we need to do this sooner rather than later. So our current model of successful economic growth, and as you saw from my title, my presentation is about the effects of excess on human health. So this is all about excess. And our current Western colonial, you might say, model of successful economic growth is relying on taking more from the environment than giving back. The bigger the enterprise, the bigger the profits. It's all about accumulation. It's all about profit. And economists will tell you that. They don't hide that. That's the way our economy works. Consolidation into monopolies improves efficiencies, improves profits, increases wealth, mind you, of a very few. And how few? We're really talking about the top 1%, not even 5%, not even 10%. And this growth pattern really fuels inflation. And I don't think I have to convince you of that, looking at what's been happening in the last few months. For healthcare is a good example. If you look at what's driving the skyrocketing healthcare costs in Canada or the US, fascinatingly enough, it's not me and the boomer generation. It's not aging. It's not population growth and including immigration into Canada. Over 90% of the increase in our healthcare expenditures is due to inflation alone or cost increases. This graph is from the World Inequality Report of 2022. It's not that old. It's only published 3 years ago. And it shows us really what economists are saying, that if we believe in the GDP, the gross domestic product, which is really the center of a growth economy, and if you believe that a healthy economy needs somewhere between 3 to 4% growth per year, that's a good thing. We hear that all the time. The question that really comes up is, where does this growth end? At the beginning, 3 to 4% might not sound like much, but it compounds year over year. And we've been doing this for decades. And we are now at the end of the curve, the growth end of the curve, where there's essentially no limit other than infinity. And who really benefits in the end? This curve kind of shows you this very, very steep exponential rise at the very end. Really, who is benefiting is the 1% or less. Over 95% of those of us at the bottom hardly benefit at all. So we're sold the line that a healthy economy needs 3 to 4% growth annually, but it rapidly becomes exponential increase in wealth for a very few. And it actually leads to a effective decrease in buying power for the vast majority of us, including those in the middle class. There is really no such thing as a trickle-down effect. Millionaires in this system become billionaires, billionaires become multi-billionaires, and we're probably not far from seeing a trillionaire emerge, at least in our current generation. Greater than 95% of the global population struggles with at least 50% or 4 billion people living in extreme abject poverty. This is basically insane. So I would like to introduce you to this author, Dr. Robin Kimmerer, who wrote several books, including Braiding Sweetgrass. This is her book, The Serviceberry: Abundance and Reciprocity in the Natural World. She is an Indigenous author, a member of the Citizen Potawatomi Nation based in Oklahoma, USA, and a distinguished teaching professor of environmental biology at the State University of New York. And she says the threat of real scarcity on the horizon is brought to us by unbridled capitalism, which is basically what I showed you on the previous slide. Extraction and consumption outstrip the capacity of the earth to replenish what we have taken. An economy based on the impossibility of ever-expanding growth leads us into nightmare scenarios. I cringe when I hear economic reports celebrating the accelerating pace of economic growth as if that were a good thing. It might be good for the 1% for the short term, but it is a dead end for others. It is an engine of extinction. So how are we going to tackle this? Well, as a result of really exploitative, exponentially escalating global economic forces, the United Nations has realized that our planet is in trouble, necessitating urgent strategies to slow down, if not reverse, deteriorating trends. And they've attempted to do this a few times. The latest was in 2015, when the UN Sustainable Development Goals were developed. There's 17 of them, and the target date for reaching these goals is only 5 years away, 2030. We're already 2/3 of the way through these Sustainable Development Goals, and I want to focus on 12, 13, 14, and 15, which are all about the environment. Starting with goal number 12, ensuring sustainable consumption and productive patterns. Having placed ourselves, humans, far above and superior to everything else in the environment, animals, plants, and the rest of the environment, this is a dualistic way, us versus them way of thinking, which is a very Western, colonial, Greek philosophical way of thinking that settler societies have adopted. This way of thinking has become really, or has been, a license to exploit animals, plants, and the environment for economic benefit without paying too much attention to limits, assuming again that infinity is the limit, according to current economic theory, and without paying too much attention to stewardship or to renewal or reciprocity or putting back at least as much or more than what we took out or take out of the environment. And so the UN has come up with something called the global material footprint, which I'll define in a moment. But as this graph series of bars shows you, it's been increasing, and it's projected to increase exponentially by the end of this current century. And it's our global material footprint is growing well out of proportion to our needs, outpacing population and economic growth. And it really results in huge amounts of waste and out of control inflation. And out of control growth, unlimited infinite growth in healthcare, in the human body, we usually call that cancer. Here's another more detailed graphic description of the global material footprint. Basically, what the global material footprint is the total weight of all the stuff that we humans extract and consume each year, whether it's biomass, which is in the green here, consisting of lumber and habitat destruction, whether it's metal ores, which involves mining and habitat destruction for the nickel, the cobalt, the lithium, the copper, the rare earths that we need to make our plain, cellular phones work, whether it's minerals like limestone, quartz, silica, clay, fossil fuels, obviously we need, but producing carbon emissions, and plastics, and all of that is what is in our global material footprint. And as you can see by this chart, this is out of control growth. The red line was estimated back in the 1990s to be the maximal global material footprint, 50 billion tons a year, that our planet would be able to handle. That was the maximum. Above that, we're in big trouble. And that started in the mid-1990s when we exceeded 50 billion tons. We're now at almost twice that, 100 billion tons, and scheduled to be at 200 billion tons before the end of this century. Our planet does not have infinite resources or infinite capacity and will not be able to sustain this kind of exponential growth indefinitely. And so the consequences of this ever-increasing consumerism and accumulation and waste are really dire. And you know what they are: food shortages, water shortages, deforestation, and global climate change, which is the next Sustainable Development Goal, number 13. The Paris Agreement, which is way back now, a decade ago, in 2015, was a legally binding international treaty with essentially no teeth that the US has basically backed away from, had laid out a climate action plan which, with its goal to limit global warming to well below 2 degrees Celsius, preferably to 1.5 degrees. Well, that's kind of become laughable compared to pre-industrial levels of heat. Even though we are a signatory along with 196 other countries, we have already exceeded 1.5 degrees well before the target of 2030, which our children will inherit, and we will reach likely 2 to 4 degrees by 2050. And if you see what's happening right now, as we are above 1.5 degrees with global climate change and weather extremes, I can't imagine what's in store for us a couple decades from now or less. And we know that regions in northern Canada have already exceeded a 2.5 degree increase. And so the result of our massively growing global material footprint has not only been global warming, but the other effects of global warming has led to an increasing ecological disaster that is a result of acid rain, to put it in simple terms, leading to the acidification of both our oceans and our soils throughout the globe, leading to the extinction of countless species, including the disappearance of massive coral reefs in the oceans. And on our land, interestingly enough, the disappearance of our insect biomass. I've noticed this myself. After it rains, when I was a child, 20, 30, 40 years ago, after it rained, I would not be able to walk on the sidewalk without squishing earthworms. It's impossible to avoid all the earthworms that came out. Now I might see a handful of earthworms, coming out. And this has been studied, at least in Japan, where they did soil sampling. They found out that greater than 80% of the insect biomass had been reduced due to soil acidification, including that massive disappearance of earthworms. So we may not think much about earthworms. We may not like them. We certainly don't consume them, and they don't they're not maybe a bug that we care about. But the organic content of our soils is reduced by greater than 50% without earthworms, and we end up with lifeless dirt, unable to sustain plant growth if we don't have earthworms. Oops. So it's not just the environment that's suffering ill effects, climate change, as you know, but climate change also impacts a wide range of health outcomes. This slide illustrates some of the significant climate change impacts: rising temperatures, more extreme weather patterns, rising sea levels, increased carbon dioxide levels, and the effects that these effects have on exposures, human exposures, and subsequent health outcomes. And we've seen this now happening worldwide. We've now seen in the last couple of years huge, unprecedented global dengue fever outbreaks. Dengue fever, mosquito-borne viral illness, completely out of control. Toxic algae blooms are occurring out of control. Extreme heat events and related deaths. Injury deaths related to hurricanes and tornadoes and extreme weather events. And the list goes on. Back in 2013, the WRHA, advocating for equity, produced a document called Health for All. The Population and Public Health Program was trying to advocate and encourage the WRHA to think beyond just acute healthcare and institutional healthcare, but to think about the importance of prevention and public health, and sounding this message and leading the way of this message, Health for All. But I went back to look at the document and realized that who we meant by all came out of a very Greek philosophical dualistic sort of Western way of thinking. The all was really only referring to humans. We were just thinking of humans at the time when we were saying health for all, which is really a settler colonial way of thinking, if I can put it that way, rather than seeing the all encompassing animals, plants, the environment. Really, what this brings to mind for me is the indigenous concept that's held throughout the world of thinking about all my relations. And interestingly enough, the World Health Organization, thinking it was radical, like back in the early 2000s, came up with this new concept of One Health linking human health with animal health, with plant or environmental health into one framework. And really, what that is another reframing, or another way to describe, in my opinion, the whole idea and concept of all my relations, which has been known and practiced for millennia, let alone centuries. It has always existed, this way of thinking, in indigenous cultures throughout the world. But One Health expressed it in a Western kind of fashion, and it's a global initiative that's about 25 years old now, endorsed by the World Health Organization. And it's really essentially promoting beyond health for all, what I would call health for all my relations. And I say this knowing that this audience probably mostly works in a silo of human health. And I think it's going to be
This meeting is
seeing.
being
It's a
recorded.
way of trying to see the world and its challenges from a holistic rather than dualistic perspective. Rather than an us versus them competitive way of thinking, it's more a we are all in this together cooperative way of thinking. So it is kind of different from a dualistic approach. And from a two-eyed perspective, two-eyed seeing is learning to see from one perspective using the strengths of indigenous holistic knowledges and ways of knowing, while at the same time seeing the other perspective or eye with the strengths of Western dualistic knowledges and ways of knowing, reaching that place in the middle where both perspectives are used together and equally beneficial for all. So I'll give you this quote from a settler. This is a non-Indigenous person. This is a settler author. I would recommend this book as well as Dr. Kimmerer's book, The Serviceberry. But I am impressed that this settler author, and his title kind of says it all, Less is More, How Degrowth Will Save the World. He's suggesting that we need to decolonize, to put it simply, our lifestyles. This means living in simplicity, ending food waste, shifting from ownership to usership are examples he uses, like using co-op cars, sharing garden tools and winter tools, owning less, consuming less, sharing more, adopting a practice of generous giving when we have more than we need. He says that if we want to have a shot at halting the crisis, we need to restore the balance. We need to change how we see nature and our place in it, shifting from a philosophy of domination and extraction, which is really the colonial model, it's rooted in reciprocity and regeneration. We need to evolve beyond the dogmas of capitalism to a new system that is fit for the 21st century. No easy task. And I will end with a quote from Dr. Kimmerer. As a botanist, she describes in her book what happens to a forest after it's been destroyed by fire and how the forest regenerates. During its recovery, the invasive colonial or colonizing species come first. They grow like crazy. The weeds and the rapid growing species come in first, and they completely overwhelm the land, but they also exhaust all the nutrients and they actually destroy themselves. It leads to self-extinction. And the subsequent wave of a forest in recovery is more slowly growing, less competitive, cooperative, she says, plant species coming back to the forest. So listen to this quote with that forest kind of illustration in mind. The extractive practices of the invasive competitive colonists in this forest must be replaced with reciprocity and replenishment if anyone is to survive. The transition from exploitation to reciprocity, from the individual good to the common good in recovering forests, has been seen as a parallel to the transition that colonizing human societies must undergo, from hoarding or accumulation to circulation or sharing of goods, from independence to interdependence, from wounding to healing, if we are to thrive into the future. So I don't have any magical solutions or magic bullets for you, but I leave us with the question, how shall we participate in sharing, in interdependence, and in healing? It feels like we have a long way to go, and I think we do, but I think there's still hope if we act now to decolonize our lives, our society, and our structures. So I leave you with those sober thoughts, and I turn it back over to you, John.
Thank you very much. Well, Pierre, you'd be happy to know that I share a snowblower with my next door neighbor. So we are making very small steps towards that process. So thank you very much, Philippe, Wayne, and Pierre. It's 4:18. Why don't we take 10 minutes of questions? Let's see there we are. Okay. So for Philippe, the first question is, so chronic Lyme is not a legitimate diagnosis, but it is possible to be dealing with chronic sequelae of Lyme infection. And are these more common than actual Lyme, than acute Lyme is not, sorry, oh my God. And are these more common when acute Lyme is not treated quickly?
So short answer is no, chronic Lyme disease is not a recognized or legitimate diagnosis in the medical literature, but it is widely used among individuals who who peddle it as a diagnosis. What we are probably dealing with, if there is in fact a legitimate borrelial infection in these cases, is indeed those chronic sequelae of Lyme disease, which we know through clinical trials don't benefit from prolonged antibiotic therapy. Are these more common when acute Lyme is not treated quickly? Yes, we believe, or we've observed, that people that progress to articular Lyme disease are more likely to have prolonged symptoms in the joints, but as an example, but these do not, again, respond well to prolonged or protracted courses of therapy. The only recommendation we have ultimately is a possible second treatment for chronic articular symptoms after a diagnosis of Lyme disease, which may show some benefit, but subsequent ones do not.
The next question is also a Philippe question. I have several clients who their Lyme disease tests were negative. They had further testing done through Germany, which said that they did have Lyme disease. Is there a difference between our Lyme tests in Canada and Germany? Now, I think we also need to add not only Germany, but Palo Alto, California.
Yeah, so this is a very loaded question and warrants an entire discussion on its own. But fundamentally, these two particular labs, one in Germany and one in California, do not use validated tests, have actually been investigated by a number of organizations by even doing things like sending samples of perfectly healthy individuals to see how many of them would test positive, and a not insubstantial proportion of them test positive. They've consistently refused to provide a lot of people with their validation data. They don't have a whole lot of information to allow clinicians and doctors to assess the validity of their tests, and they're not validated or they're not accredited by any national or international lab certification bodies. So largely, it's a bit of a black box. I fully trust the diagnostics that we have here in Canada. Using research use only assays on clinical patients, samples that have not been adequately validated with known positives, gold standards, things like that, is not good lab practice.
No, and in fact, it can actually lead to harm with excessive antimicrobial use. So thank you.
Yeah, and further things like PICC lines, central lines. I saw one case of a woman whose PICC line had ended up in her atrium and had to be surgically removed. It could be awful.
Yeah, no, absolutely. So let's see. Does the reliance on clinical diagnosis and need for prompt introduction of antibiotics counteract the AM stewardship program, especially considering the risks of differential diagnosis? I'm not quite sure what that means. Do any of the presenters?
I'm not sure if that relies to my statement about Rocky Mountain fever or Wayne's statement about treating patients with pneumonia with empiric antibiotics.
Oh, maybe. Okay. Anyway, let's Dr. Plord's presentation should be presented far and wide. I don't disagree. Let's see. If exploitation of natural resources is a Western colonial concept, how come China's population demand for beef is causing deforestation in South America? See March 21, 2021 Guardian article entitled Eating Up the Rainforest. Now, it may be the global concept of excessive consumption as opposed to just the Western concept, but that's a PR question.
Yeah, the global economy relies heavily on, for lack of a better term, a capitalist economic growth model, which is really, even by those who consider themselves anti-capitalist or who use communism as opposed to, are really, their economies are functioning with a similar capitalist economic model that results in excessive consumption and the benefit for the very few, which would include China.
Okay. With the changing environmental conditions, is spread of Lone Star ticks within Canada concerning, as there have been reports attributed to migratory birds in Ontario and establishment of new zones?
Absolutely. And this is something that's kind of a bit of overlap with Pierre's talk about global warming and CO2. We are seeing Lone Star ticks out far eastern Canada and expect their geography to spread into Quebec and Ontario ultimately, which will mean introducing new disease like ehrlichiosis, which I didn't talk about, alpha-gal syndrome, which is commonly caused by those particular ticks, and stari, which I didn't mention again, is another tick-borne illness. It's associated with Lone Star ticks. So yeah, bottom line is they get introduced by migratory birds or other animals that can move, and those ticks can then survive due to climate change, whereas our really cold, harsh winters used to kill them off. They do not anymore. This is what's happened with Ixodes scapularis here in Manitoba. Even when I started medical school, you barely heard about that as a tick vector in Manitoba, and now it's well established. And it is related indeed to climate change, migration, moving birds, and new niches for those ticks due to improving climate conditions.
So I have a question for Wayne, which isn't here, but one that's been on my mind since I watched this presentation. So mycoplasma is sort of the characteristic or the classic case of walking pneumonia. But what about chlamydia? Seldom talked about, but thankfully addressed by doxycycline or addressed with doxycycline.
Yeah, absolutely. I would love to hear from Philippe whether you guys detect through serology PCR chlamydia pneumoniae. This that's been reported, but I assume it's there. But have I recently detected it on PCR? Pharyngeal, NP swabs? No.
Yeah, extremely limited diagnostics here. So basically, no.
However, when in doubt, doxycycline rules.
Absolutely. Like I said, nobody should be left to walk away with your illness that you can't figure out, FUO, without a trial of dox.
It's very true in travel medicine too. A lot of travel related pathogens are covered with doxycycline.
Okay, let's see. If someone had mild Lyme disease but never received treatment, now a couple of years later had strange symptoms, fatigue, brain fog, etc., can someone develop long-term issues attributable to untreated Lyme disease?
So we don't recommend people get screened for Lyme disease on the basis of vague symptoms like this, or protean symptoms, fatigue, brain fog, etc. Good odds it was probably COVID. But in your case, you're describing a situation where you've got somebody who did have a case of Lyme disease, maybe a characteristic rash at that time, did not get treated. Yeah, they can develop the secondary, tertiary symptoms of borreliosis. In that case, I would recommend they get tested. We know that this test is highly sensitive in late stage borreliosis. So one could confidently say if that test was negative, he didn't get treated so early, which could blunt the response. So that if that test was negative, he does not have Lyme disease, and start looking for alternative causes, including COVID. We know COVID is strongly associated with those specific symptoms, and it seems to be increasingly discounted as a possible cause for these chronic fatigue and brain fog-like symptoms.
Fantastic. No, this is great, Philippe. With much of the Lyme diagnosis, are serologic based with borderline results early on, is there a move toward molecular-based methods for better sensitivity?
So short answer is no, they are not better sensitivity, which is why we haven't moved towards them. I did have one slide on PCR diagnosis, but it was already too long, so I took it out. Usually we only use PCR in very rare instances where you have a good sample, for example, a knee joint that's hot and that you aspirate a fluid. You can get the diagnosis a little faster that way. But most other samples, very low sensitivity for diagnosis of Lyme disease borreliosis, which is why it's not widely available and very limited in its use.
And then the grand finale, is Lyme-generated heart block permanent?
Not typically. So if you treat your patients with ceftriaxone, they usually resolve completely.
Okay, well, I think that brings us to the absolute end. Thank you, Philippe, Pierre, and Wayne. And on behalf of the organizing committee, Shared Health, the University of Manitoba, and of course, the continuing professional development group at the University of Manitoba, who did an incredible job today. Thank you to all of the speakers. Thank you to everyone. And we need those who are still on the online and who still have energy to fill out evaluations, give us some ideas for next year. And we need lots of unusual and innovative topics, because we've sort of exhausted all of the typical infections and infectious diseases and usual topics, even sort of the more out there topics like today's focus on excess. So we look forward to seeing you again in exactly 1 year time. And save the date, and we'll see you again. Thank you.